And I think as the day goes on, we'll continue to develop this theme. We have some amazing talks today. I think we wanted to just sort of have some audience reflections of what were your takeaways from yesterday. So I know Gina had something to say, so maybe we could just call on her for a second.
Well, I was just impressed by the bigwigs that have been speaking yesterday and today, and just how knowledgeable and well-connected. I really feel like we could, with the combined brain power in this room, affect a real change in the way we approach brain health.
Absolutely, that's so exciting. I know Harris had something to say.
We're going to wait for him to finish his bite.
The breakfast is very good. That's my reflection. So well done, Helen, if you're responsible for that. I think this is I go to a lot of meetings, and this is very powerful, integrated, and diverse group. I can already sense strategies coming out of this. Universities are thinking about their brain health, brain economy strategies now, and if it's not one university, it's actually 3, so I can tell you that. So we're like, just yesterday we had a big impact, even just in the first half of this. I think that there is absolutely interest in engaging in this $23 billion bond package that's passing through the California legislature. So that remains, I think, maybe to be discussed a little bit more today, but there's clearly a coalition of the willing that wants to be involved in that and helping that. And I think that generally some sort of, like, in a practical way, as Helen's wingman, I think UCLA could stand up some kind of brain health center with good sort of local support, but then of course friends and advisors from all across the state and around the world. So I think from big strategy things that are happening in the entire state through to like what UCLA can do, I think that this is all catalyzing and coming together. But we do have some work to do to figure out how to go from A to B on all these things. But this is really serious stuff. This is great. So I thank everyone for all of the tens of thousands of interactions that we all had yesterday together. So I'm excited for today.
Thank you so much. Lee has something to say.
Yes, I really enjoyed the talks yesterday and the engagement. The thing that struck me most was about the integration, both horizontally and vertically, and I mean that at a bunch of different levels. From the level of the individual looking across development, Dr. Geschwin had spoken about how neurodevelopment all the way to aging needs to be integrated horizontally at the individual level, but also integrating horizontally and vertical across disciplines. And that's very unusual, and I think it's really important. And finally, I think amongst those who are funding and sponsoring and interacting at the leadership levels, this also pertains. And I think having, for example, philanthropy working hand in hand with government officials to get public-private partnerships is absolutely essential. And I think here in California, with the $23 billion being on the table, I think engaging not only the academic community but the philanthropic community to put their weight behind these partnerships could be very productive.
Oh, this gentleman. My friend from yesterday. Good morning. Nice to see you.
Good morning, everyone. My name is Bill Preston. I'm with the Rosa Raymond Parks Institute for Self-Development out of Detroit, but also I'm a bridge builder and working tirelessly to improve patient health care outcomes around the world. I appreciate everything you all are doing. My point is, I'm a Trojan across town, but I love the Bruins as well. They didn't have a school business when I was coming through. Can we partner together with Trojans and Bruins? I mean, at the end of the day, this fight is so bigger than all of us. And I'm being intentional. Mother Parks always said, you know what? We're all here on planet Earth to live, to grow up, and do what we can to make the world a better place for all people to enjoy freedom. So let's have freedom of Alzheimer's, beat it together, Trojans and Bruins working together. I know my my colleagues on the other side will be willing to cross town with you all. This thing is so big, you guys. It's a global tsunami. We got to break it. And the only way we can do, as the African proverb says, if you want to go fast, go alone. If you want to go far, we got to go together. God bless you all. Continue to show up and keep the faith. Thank you.
We have had some Trojans and people from all the UCs, actually. I think Helen's been really mindful about it. Cedars, USC, everyone, UC Irvine, lots and lots of folks. So Ellen, our friend from UCSF and my co-author on a paper, my colleague in psychiatry.
I had a blast yesterday. I loved the talks, and yeah, echoing what other people said, I think the integration across specialties, across campuses is really exciting and led to some really cool conversations yesterday, like with some colleagues about like ways that we can partner and do new studies. Like in our case, our focus is research, and like do new studies focused on like understanding early aspects of neurodegeneration. And that was really, really energizing.
Awesome. Well, thank you so much, audience. You've been very
Thank you. My name is Mercy Santor. I'm with LA County Department of Parks and Recreation. So I'm on the other side. I'm on the practitioner side, one of the people who would be responsible for using this work and helping it shape the work that I do in community settings. And so I remember healthy community initiatives and all the different ways we talked about bringing better health to communities. But the conversation that we're having today integrates a lot of important work. And I think that certainly I have a lot of takeaways. I would definitely describe sports differently in my discussions and advocating for policy change or funding. And I definitely appreciated the early childhood focus through life course, because in communities we look at all of those areas, right? That's our responsibility, that's our job. So many incredible takeaways, and thank you.
Okay.
Thank you so much. So off to Sahib and kicking off day 2.
Okay, one last reflection, and then we'll move on.
Yesterday was incredible. I just want to mention it's not about being a patient, but there are so many people already with patients doing so much for their optimal health and healing. So some of what you were describing yesterday, I don't know all of your research and commend you for all of that, but there are people already doing this, and yet it's in different places and parts. And there is a way to incorporate something for brain health with more traction and more process, more of a process and progress forward. So that's in part what I look for through your incredible work.
Thank you. We're unfortunately, I know it's Saturday, it's the weekend. We're going to have to move forward to keep us on track, but we'll have more time for reflection at the very end as well. Thank you.
So we're looking forward to 3 keynotes this morning that would outline successes to date. Hello. So the first keynote is by Kana Inamoto, and she's a partner at McKinsey & Company and director of brain health for the McKinsey Health Institute, and is an internationally recognized expert in mental health, substance use, brain health, and brain economy. And she will present on a very interesting topic of human advantage, stronger brains in the age of AI.
Good morning. A little bit more energy. Good morning. Was everyone out at Chateau Marmont last night with Harris? Just partying it up? Sorry, I didn't mean to expose you. Because I was like sound asleep. So we're going to talk about brain capital. I think it's incredible that we've gone from neurology to psychiatry to brain health, and now we're going to go one more frontier to brain capital. And so just show of hands, how many people have actually seen or heard, actually, how many people have heard of our World Economic Forum, McKinsey Health Institute, Brain Capital Report before Harris mentioned it yesterday? Oh, yay! That's success. That's success. But I think it's been a really galvanizing framing that I appreciate and respect Harris for being such a great champion of. And so at McKinsey Health Institute, where our work is not commissioned by clients, we are a non-revenue generating entity. We are part of the global consulting for McKinsey and Company, but our work is meant to be shared with the public at no cost. And so we partnered with World Economic Forum once we had spent some time with Harris and thought about what is this concept that is unifying across brain health and brain skills that is going to resonate, right, with different kinds of audiences. So we have a primarily, I think, health audience here, and I've been in health for all of my career, and we have felt like, gee, if we just show people the data, then surely they will start to invest. If we just show people our outcomes, then surely, right, they will begin to invest. If we just show people how impactful our work can be and how much it has this long-term impact, then surely they will start to invest it. And I can tell you right now that in health budgets around the world, less than 2% of overall health spending is on mental health. Right? Brain health, maybe it's a little bit more, but certainly far less than the 1 out of 4 disability-adjusted life years that brain health conditions account for. Right? So we're driving 1/4 of the world's disability, and we're getting 2% of the world's health spending. And so we have aligned on the brain capital framing, because as things are occurring over years, and people have mentioned, I think, several times that COVID was a great unlock for people in terms of their awareness and their acceptance and the reduction in stigma and discrimination around these issues. And then, of course, as you know, many people in America, one of their #1 health fears is cognitive decline, dementia, Alzheimer's. Right? People are more afraid of Alzheimer's than death. And so this is a ripe time for looking at these things, but we have to help people translate that to meaningful investment. And so we think that this is a great opportunity. One of the ways at McKinsey Health Institute we are helping people understand how this translates to meaningful impact was this analysis that we did, and what we looked at was not just the primary mental substance use and neurological burden. You can get that on IHME and Lancet, et cetera. But what we expanded that to was, what are the highly highly related non-communicable diseases that are accompanying these conditions, like cirrhosis of the liver, or where you have exacerbated metabolic syndrome for many people with serious mental illness. We know that people with SMI are dying 25 years earlier, not because of their mental illness, but because of their chronic disease burden. And in this last year, during the UNGA, the United Nations General Assembly, they did have a high-level meeting, the 4th high-level meeting on non-communicable diseases, and we supported data to what do you call it, civil society groups to advocate earlier. It was originally the high-level meeting on non-communicable diseases. We supported data to the civil society groups so that they made it the high-level meeting on non-communicable diseases and mental health. And then during the conversation, a substantial amount of the discussion from the member countries was on mental and neurological disorders. So I think that was a huge win, and we helped by demonstrating that there is this intrinsic tie between brain health conditions and med-surg, physical health, chronic disease, as well as infectious disease, which we've shown elsewhere, but that's not included here. So when we talk about brain capital, I'm sure Harris mentions this as well, but we're talking not just about brain health, but also what we're calling brain skills. And of course, every human behavior and emotion and feeling is mediated through the brain. But when we're talking about brain skills, we're talking about some of those higher order processes like cognitive skills, interpersonal skills, self-leadership, so self-regulation, self-motivation, self-awareness, and then technological literacy. And then on the brain health side, it's mental neurological substance use as well as prevention and promotion. So those factors that are engaged in our mental well-being. And so we take these as a combination of brain capital, which becomes a fundamental asset of society, of organizations, and then in some ways you could even say individuals and families. The movement has been going. We didn't invent it at McKinsey Health Institute, but we have glommed onto it, and we are advancing it, mostly because I've been a mental health person my whole career. I have led federal agency. I was in a federal agency for 20 years, and I will tell you that I struggled for 20 years to get people to pay attention to our issues. 20 years of fighting against, we're competing against cancer, we're competing against health centers, we're competing against HIV just for attention, for budget, for mind share. And yet, we cause more disability than all the cancers combined. And for cancer researchers here, I apologize, but people must spend more money on these issues, and they just don't. Right? I mean, HIV at the time, Ryan White was getting $30 billion or whatever it was, and we were getting 3. Right? It was 10x the budget spending on HIV than mental health and substance use, and yet we know that our issues drive so many more deaths, so much more disability. So that is why we have embraced this, because this narrative, which has been going since 2010, is only gaining steam. And we see that the G7, the G20, the World Economic Forum, UNGA, we have the clip of Dr. Tedros talking about brain capital, Ban Ki-moon talking about brain capital. This is really reaching the global awareness. And this takes us a little bit back to what I was talking about making this, translating this into terms that other people can understand outside of health. And we did an analysis. How many people have heard of the HIV care cascade or the 90-90-90 goals? Thank you, public health people. So I have been, along with Patrick Kennedy and the Kennedy Forum, we've been championing this concept of 90-90-90 for brain health or mental health, which is, the care cascade for HIV was 90% of people should know their status, right? So universal HIV rapid testing. 90% of people who are positive, HIV positive, should have access to ART, and then 90% of people on ART should achieve seronegativity. So very clear care cascade, and by doing that, we could stem the transmission and bring the epidemic under control, which we have largely achieved, especially in sub-Saharan Africa, a little bit less so in the United States, but everyone is making progress. What if we did that for mental health? And we started talking about this, what if we did this for brain health? We started talking about this a few years ago, and when I did that, some of my former colleagues and other leaders that I knew in the field were like, that's ridiculous, that's not possible, that's unrealistic. And I'm like, why is that unrealistic? Why do we have this learned helplessness, right? We're the dog in the cage that is afraid to step out. Because there's no other health condition for which you would say, well, why don't we only have 90% of people, or only have 30% of people who have diabetes know that they have it? Or why don't we only measure blood pressure in 30% of the people who come to the doctor? Or of people who have a broken leg, how about if 50% of them get treatment? We would not say that about any other health condition and say that's what's realistic or that's what's acceptable, but that's what we do for brain health. So we are challenging everyone to say, what if 90% of people had a screening every year? What if 90% of people knew their status? What's my brain health status? 90% of people who screen positive for any condition have access to evidence-based care, right? Not just random things or some eclectic model that people want to use or experimentation of different things, but actual evidence-based medicine, measurement-based care. And then 90% of people who get care are making progress toward their goals, right? I'm not talking about cure necessarily, but cure certainly in the future, cure certainly for some conditions, but that people are moving toward recovery that is meaningful to them. And if we could do that, right, this is a $2 trillion proposition for the United States. Right? If we could address these issues to that degree, it would be a 4% GDP bump. And what other investment wouldn't we make if it meant 4% of our GDP, and yet we're not doing that currently, But I think translating this to, I just had a conversation with a CEO payer in South America, and when I was translating it into these kinds of numbers, he was like, wait a minute, you mean this is a good investment? Yes, this is a good investment. So this is translating it to one company, BrainCo, right? Hypothetical company, 10,000 employees. And these are just a sample of ways in which unmanaged brain health conditions in a community, in a population, right, like in a family, are having impact on employers. So like just translating the 2 trillion to like my neighborhood, my office. Right? People with untreated substance use disorders, people work in communities where you have limited access to early childhood education. Thank you, G. Solon. Where in places where employee burnout is causing $11 million of like increased turnover, low productivity, where untreated depression is causing people to not be able to show up for work, and people who have elder care responsibilities are more likely not just to miss work, but to have higher healthcare costs. Right? So these are all hidden ways in which the brain capital of your employees, the brain capital of their families, and the brain capital of their community cause a hidden tax on a company. And again, when we are talking to CEOs of non-healthcare companies, this resonates with them because they know all of these things are happening, but they've never added it up together. But when you can frame it like this, I think some of your work, some of the research that's happening here can translate to people, to like, what does this mean for me? What does this mean for my organization? And so in our WEF report, with MHI and with much of Harris's help and many of the organizations who are here in this room, we have a Brain Economy Action Forum. We identified 5 pillars. What do we need to do to advance brain capital for society? We need to safeguard brain health, foster brain skills, study brain capital, invest in brain capital using innovative and traditional mechanisms like philanthropy, but also other types of impact investing, venture, private equity, government, all working together, and then mobilizing, which has culminated in some really exciting movement. Safeguarding is the one where we're really thinking about that. That's the health pillar, right? So we're supporting promotion of brain health, access to evidence-based care, and innovation. So that's research, it's also clinical practice innovation in order to advance the treatment. Because while we're right now not necessarily ready with all the DMTs that we need for, say, dementia and Alzheimer's, it's right around the corner, right? Like I feel it in my bones, it is around the corner, but even if we got it tomorrow, we're not ready for it. Our systems are not prepared to screen people, to detect people in the right window, and to deliver those treatments when they're needed, how they're needed, to pay for them. So we need to do this work to prepare our system to safeguard brain health. We're doing a lot of work on task sharing. This is a QR code for our tasksharing.ai project that we did with Google and Grand Challenges Canada, because I think using lay people to deliver evidence-based interventions is the future, not only in LMICs, low and middle income countries, but also in the United States. And I think AI can help us do that really effectively and with high consistency and at scale, sorry. We need to foster brain skills. So this is the part where it's our non-health skills, where it's not only investing in the future workforce, so in our children from cradle to commencement, but also healthy brain skills in the workplace, and of course, fostering the brain skills of our older adults as they age. When we're talking about brain skills, what do we mean? So the World Economic Forum does a Future of Jobs report every so often. I don't know if they do it every year, actually. But in their 2025 report, before it came out, I was thinking, I knew that the prior job skills were heavily weighted to brain skills, right? Analytical thinking, resilience, leadership, social influence. And so we were kind of hanging our hat on that and like, look how important like brain health and brain skills are for jobs and for employers. But I thought, well, when they're talking about the future and what's with AI happening, the future of work, surely our brain skills are going to get displaced by technical skills. That's what we anticipated. But to my surprise, right, so yes, AI and big data, networks and cybersecurity, those have displaced some of our brain skills as the number 1 and 2. But 6 of the other skills are still brain skills. So even into the future, what is human? The things that make us essentially human, our minds, right? That is going to be more and more valuable. I think Hershini said yesterday, is leisure time going to be the new luxury, right, is having the time to really contemplate the world, to be a philosopher. That is going to become more and more valued because more routine activities and skills will be displaced by AI and robotics. But what we are, how we are human, how we relate to each other, how we lead each other, how we persuade each other, that will become still a prized asset. So in all of this, we need to study brain capital. I think you guys have talked a lot about this. We need to measure it. We need to understand it as an interdisciplinary area. And then we need to accelerate the research that's happening in the development of brain capital, as well as, again, on the safeguarding side, the fostering side, across those disciplines. When we're talking about an interdisciplinary approach, I'm so excited that we have psychiatry and neurology here. I think we also, and I know we have many others in the room, but this is really going beyond biomedical and clinical sciences. We're talking about design and technology, engineering, architecture, education, politics, and the creative arts, which we also have, right? This is a interdisciplinary framework of how we are capturing brain capital and building it into the future. Investing, we want to drive fit-for-purpose investment. I mentioned this yesterday. Our Coalition for Mental Health Investment was focused on mental health, but I'd say the frameworks we identified in terms of what are market failures that occur, what are the valleys of death, right, of things that fail to go to scale, and then what are the financing mechanisms that are available to us, and how could we use them more robustly. Other areas of health, other sectors have figured this out much better than we have in the brain health side. So I encourage you, if you're thinking about funding, if you're thinking about how do I really scale something, this is a great way of understanding where do we go wrong, right? Like, we can't just daisy chain grants and then think that things will magically reach everybody. It's just not how it works. I had a call from a very august emeritus professor from an Ivy League university last week, and he said, I have this intervention, it's super effective. You know, he has like 300, first authored, like top tier journal articles. And he's like, I've been talking, I was like, have you talked to some VC firms or PE firms? And he's like, yeah, but they want to start at like 5 or 10 million. I think the government should just fund me, and we need 1.5 billion. And I'm like, I agree with you, and like, that's just not how it works. So I think there's sometimes a gap between folks who are really developing these interventions and their literacy on the financing and the pathway to scale. So I encourage you, whether or not you're that person who is an innovator or you want to be a bridge, I think there's some translation that we need to do more of in our field. And so that is, I think, an opportunity when we're talking about investing in brain capital. And finally, we need to mobilize, and this is the Global Brain Economy Initiative. We feel really glad to have played a part as MHI and WEF and the Brain Economy Action Forum in its formation. We're excited because we identified the need for a central organizing body to really play the lead in catalyzing an economic transition, because this isn't going to be easy. It is multi-pronged. There are 1,000 flowers blooming at the moment. And it's not that one organization needs to tell others what to do, but I think it would be helpful if there was sort of a place to look or a source of truth. So we've identified already 50 organizations engaged in the brain economy. This is their geographic distribution, which is actually quite decent if you think about it. And then this is also on the right-hand side is the levers that they are looking at. So they're pretty well distributed. And it's exciting that there's momentum building, but I think we're also excited for that leadership to emerge. And we're happy for Harris and High Lantern Group and others that are, and those who are here, who are in the room, who are supporting GBAY as that takes off and leads us into a next generation. So many thanks. These are folks who are the organizations that are part of the BEAF, Brain Economy Action Forum. We're going to be doing events at World Health Assembly, at UN General Assembly, and throughout the year. We encourage you to follow us, to engage in the reports and ask questions. If you'd like to be involved, let me know. We are a cheap date. Doesn't cost anything, and we don't order much. So thank you very much.
questions?
Hi, this was terrific. Cards on the table. It seems to me that Europe is far more ahead of the US on all of this. And I guess what I wanted to ask is your thought on that, but also which countries in Europe, I know the UK is like Prince Charles came out with a dementia, even before he was king, initiative. So I guess I wanted to know how you see trying to navigate the hellish landscape that is the U.S. Sorry, but
Funny question. I will let Harris speak to some of the European countries that are really leading. Right, there's a Swiss brain health plan. There was a Finnish brain plan. There are other countries. I think like 26 countries that now are having brain health plans. So that is exciting. I think Europe in particular, if you think about, there were the same number. I thought this number was going to come in like 2050, but actually there were more children born in Nigeria last year than were born in the EU.
Is that basically it?
So go Nigeria, right? But the EU has to be worried that the population pyramid there is really becoming unsustainable. And then you have the Draghi report. And so they are investing heavily in, I think, innovation. And they are really looking at what do they need to do to preserve the productivity of their older adults and their whole population in order to be competitive into the future. The United States, I don't think we have that awareness. I don't know that we're going to get it in the next few years. But I have seen many states. Texas is a leader. California is emerging. Right. Other states are really, I think, going to be where the action is at.
Did you want to comment, Harris?
Sure. Yeah, I think there's firstly, so the brain capital. Maybe I should stand up. The brain capital index that we have that I presented yesterday globally can be broken down country by country, and so we are breaking it down and going to sort of rank countries globally. And I think you'll find in the European context, like Finland is, and the Nordic countries are really the best when it comes to brain health, brain skills, and the sort of environmental context of socioeconomics, digital access, environment, etc. So there are countries like Finland that have like a brain health program where they infuse brain health into schools, into businesses, and kind of mentioned Switzerland. So I think that Europe is doing well, but candidly, Europe's best fund for brain health research is like much less than what just Texas is doing in brain health research. So it sort of depends how you measure these things. I think the key thing is that we do need to think about comparative learnings across nations. Even in Argentina, we were with an Argentine politician last week. He has actually the first bill for brain health across the lifespan of any place in the world. So there are the ingenuity of the global South in this area is really impressive, because oftentimes in the global South they don't have the sort of big solid bureaucracy. They can move actually a bit more creatively if there's the right politician that wants to do things. So maybe the message is like we need comparative learning, to be honest. But then we are very interested in city engagement. So the last thing I'll say, and then I'll stop, is there's a city level index for brain capital that we're developing that will also rank American cities in terms of brain capital. So that's going to be fascinating, and that should be ready in the next few months. So I think we just keep talking about it. Yeah.
Hi there. Thank you so much for your excellent presentation. I was particularly taken by your statement on we need to have individuals, boots on the ground, so to speak, lay people delivering this brain health. And we have done some of that. We know that there are folks here from LA County who are involved, Javier Cajigas. And they actually do this. And we do it quite successfully at UCLA, where we develop brain health programs and then we license them to individuals across the country. We train people how to deliver brain health. It's a win-win. We have volunteers here. Nancy, I'm going to call you out, that have done this, and it's a win-win because it's good for the volunteers, part of the brain health we know. It also generates some funding for nonprofits to continue their operations, and they're being taught, people in the community are being taught about brain health by their peers, which is very well received because of course, the commonalities that people share. So I was wondering though, if you have any ideas on how, I mean, these are our thoughts on how to do it, but there must be other ways to do this. Any, I know time is running up, but any quick thoughts on what are some other methods that people can use to get those humanitarian boots on the ground?
So we do have we've been working on task sharing for about 3 years. We're going to be publishing a playbook on task sharing and sustainability in the next few weeks. So happy to get your information and chat more. Thanks. Thank you.
And I was just going to comment that, so the AN has a brain health initiative that they have like a meeting yearly. They invite people from around the world at other places. The EAN, which is the European Academy of Neurology, has actually been doing a great job. The president, Elena Moro, has been very open-minded, even to things around statements around global warming and climate change, which we have been behind in the US. So I think they actually have an ambassador program. So they've been training people within their fold to actually go out in their communities and teach. So I would urge you to look at the EAN's website. They have some very unique programming, even in schools, educating and things like that. So they are ahead.
Okay, moving on to Dr. Unitzer's talk. Dr. Jürgen Unitzer is a professor and chair in the Department of Psychiatry and Behavioral Sciences at the University of Washington. He's an internationally recognized psychiatrist and health services researcher whose work focuses on innovative models of care and integrated mental health and general medical services. And he established the Brain Health Center in his department, his university. So he'll share his success story. Thank you.
All right, well, good morning. I'm Jürgen. I'm a psychiatrist. I actually learned how to be a psychiatrist here at UCLA a little over 30 years ago. I had some great mentors. Thank you, Ken. And some really great colleagues. Thank you, Helen. And now I'm at the University of Washington. I chair the Department of Psychiatry and Behavioral Sciences there. And as Helen said, we were fortunate. About 8 or 9 years ago, we got a big $50 million gift to start an institute for brain health solutions. And so I'll give you a short 15-minute tour of some of the things that we've tackled with that. All right, a little bit more context. So I'm at the University of Washington. We're in Seattle, Washington. We have kind of a unique role there in that we are the only academic psychiatry department that supports a 5-state region in the Pacific Northwest that covers 27% of the US landmass. And so we're a big department. There's 1,400 of us. We do over 100,000 visits a year. We have a big research program. And I think that gives us an opportunity to think about, if we can figure out how to do something in our place, can we take it to scale? Can we take it out to a large geographic region? When we started thinking about this about 15 years ago, we said, what happens when some things go wrong with your brain health? Well, we have common mental health problems. We have people who have depression and anxiety and addiction, and we have people with severe mental illnesses, autism, schizophrenia, bipolar disorder, and as we get older, our brains start breaking down, and then we have dementia, and we have strokes. And my colleagues at the Institute for Health Metrics and Evaluation at UW tell me that those things drive 25% of all health-related disability globally, more than diabetes, more than heart disease, more than cancer. And this is not a rare problem. This is a common problem. So when we got our institute set up, we sort of did some brainstorming. We said, what is it that we could do to keep our brains healthy? So some of us said, let's start out with a healthy brain. So we developed in our department a pretty big program that focuses on perinatal mental health, and I'll say a little bit more about what that is. later on. Others said we need to protect brains from harm, from injury. So we got a group of people working on that concept. Some people said we need to train and exercise our brains, so that notion of building brain reserve, that we heard about yesterday. And then a lot of us said, what do? We repair or support people who have broken brains. We develop novel therapeutics. We develop treatments and try to use treatments for people who are struggling with a brain health problem. And we were very fortunate. A couple years ago, we got $250 million from the state of Washington to build a new facility on our campus called the Center for Behavioral Health and Learning. And it's really mostly about developing and testing novel therapeutics. And so that's a whole range of things, new types of psychotherapies, new medications. We have a program in our substance use region, in our substance use field, where we're developing vaccines and small molecules to prevent substance use disorders and treat people with substance use disorder. We have a whole program focusing on brain circuitry, neuromodulation, brain stimulation. That's all really fun, really exciting stuff. But that's not what I want to focus most of my comments on today. What I want to mostly talk about is the fact that we already have a good number of very effective treatments for these problems, and people just don't see them. Kana mentioned this with the 90-90-90 concept. The data is roughly like this. If you take all the people living with a diagnosable mental health or substance use problem today, 12% of them will see a psychiatrist sometime in the next 12 months. 20% will see any kind of person who's had training as a mental health professional treating something. That's psychology, psychiatry, social work, counselors. 20%. 40% will get some help from a primary care doctor who noticed that there's something wrong with their brain health. But 60%, more than half, will get nothing whatsoever. No formal attention to their brain health, to their mental health in the next 12 months. And part of the reason for that is this has been a neglected, underfunded, under-resourced part of medicine for a long time, and we just don't have enough specialists. So there is no part of the United States where there isn't a federally designated healthcare professional shortage area in mental health. Every single state. In our state, and that's the slide on the right, we have 39 counties in the state of Washington. Half of them don't have a single psychiatrist, psychologist, or social worker. So nobody who's got any kind of formal training in helping you with a mental health or addiction problem. And part of that has to do with what we do. So when I learned how to be a psychiatrist here at the at UCLA, we were taught something called the 50-minute hour. And so the idea there is you meet a patient and you make a nice relationship with them, you engage with them, and you learn about what's wrong with them, and you develop a treatment plan, and maybe you start on a treatment and then you say 50 minutes is up. I need to know, write a chart note and go to the restroom, and then I'll see my next patient. And so a couple of years ago, and that's a good thing, we should all know how to do a really good 50-minute hour. I'm not knocking that concept. But what we did is we said, what if we took all of the psychiatrists that are practicing, that are eligible to practice in the United States, and we said, we'll make a conservative assumption that at any given time, 3% of the US population could benefit from having one of these 50-minute hours once a month. That's a very conservative assumption. How much time do we actually have for everybody? So it turns out if you're living in an urban part of the United States, we have about 6 minutes a month for you. And if you're living in a rural part of the United States, which is the part that I'm working in right now in the Pacific Northwest, it's a minute and a half. So that 50-minute hour is really great, but it doesn't scale. It's not going to be a solution to the kind of problems we're talking about. So we said, what else can we do to close the gap? So we said, all right, we need to train more mental health professionals. So we have a very large psychiatry training program. We train psychiatrists in 3 states, over 100 people in our residency program at any given time. But that's not going to solve all of our problems. And then we said, okay, we got to work smarter. Those people that we've trained to help somebody with their mental health problems, how do we leverage them better? Can we give them more effective treatments? I mentioned a little bit about that already. Can we use technology? What about telehealth? What about AI? What about AI as a co-therapist? And then we said, that's all good, What about other people who see people who have brain health, mental health, addiction problems? Can we partner with our colleagues in primary care? Can we work with people in schools? Can we work with community-based organizations? And finally, we said, why are we waiting until somebody's got a bad brain? Could we move things further upstream? And I'll come back to that at the very end of my comments here. So start a little bit with training. It turns out it's very expensive to train a mental health professional, and it takes a lot of time, 12 years minimum to train a psychiatrist or a psychologist, and a lot of money. And so we said we can't just limit ourselves to training a handful of doctoral level providers. What if we tried to train everybody on brain health and mental health? We have built, we train psychiatrists, we train psychologists, we train nurse practitioners, we train physician assistant, but we've put a lot of time and effort in the last couple of years on thinking about what if we trained the person living with the illness? What if we trained their loved ones? What if we trained caregivers? What if we trained the many, many undergraduate students who come to the University of Washington who all are interested in healthcare professions, but they're learning normal psychology and abnormal psychology and developmental psychology. They never see a patient. So I said, what if we taught them how to do evidence-based psychotherapy as undergrads? There's thousands of undergraduate students like this, and we started doing that, and it turns out they're very, very good therapists. So you don't have to wait until you have a doctoral degree to help somebody with a mental health or addiction problem. And the other thing we said is, what if we partnered with primary care, with other medical specialists, with social services, with law enforcement, with people who are in supported housing? We can all be mental health, behavioral health providers. And so we've done a lot of training trying to broaden the workforce. Now, when you start doing that, those people will say to you, wait, I trained to be a cop. I didn't train to be a mental health professional, a brain health professional. So what I learned from that is, if we ask them to do that work, we need to have their back. Somehow we have to help them with doing this work. And so what we decided to do is, we have a lot of psychiatrists. We can provide support, backup, consultation to people like this. So in our state, in the state of Washington, if you're a healthcare professional of any kind, doctor, nurse, social worker, whatever, and you have a patient who's struggling with a serious mental health addiction problem, you can pick up the phone 24/7, 365 days a year, right here in the moment, and you can say, I want to talk to a psychiatrist at the University of Washington about my patient. And we do that. And it works really, really well. And it's been incredibly well received by our state. I get a couple $1 million from the state of Washington to support this, and we have 65 psychiatrists who take call. Because we have a pretty deep bench, if I get something that I don't know the answer to, I have somebody in my group who will know the answer to that. And it's been really a great opportunity. We've also provided a ton, 15,000 hours, almost a year of training for people doing this kind of work. We use a model that was developed at the University of New Mexico called the ECHO model, where people join on a regular basis on a topic of interest. Could be autism, could be stroke recovery, whatever it is, and they present their cases, and we have a group of experts who talk to them about those cases, and everybody else learns from each other and from their cases. It's a really effective way to do that. And finally, we said, all right, we can consult to you, but sometimes people say, I actually need more than a consultation. I need some help. So some 20 plus years ago, my mentor, Wayne Caton, Ken Wells, and others were starting to say, what if we did what we call collaborative care? We work alongside a primary care provider, taking care of patients in their office in primary care. And so we developed this model where we have a primary care physician who has primary responsibility for your mental health, for your brain health, for your addiction treatment, but we train somebody in their office to work alongside of them. We call that person a mental health care manager, and we have a psychiatrist who doesn't see all the patients, but who's backing up the team. He hears about all the patients and can focus on those patients who are not improving. We tested this in a very, very large study. This is a little over 20 years ago now, where we took almost 2,000 patients who had pretty severe depression, and half of them got this kind of collaborative care model, and the other half got the best care that was able to be offered to them in primary care as usual. And what we found is if you do it this way, you more than double the likelihood that a person with serious depression is no longer depressed a year later. That's a big deal. And we found that worked in 8 out of 8 organizations where we tested this in. And then speaking about economy, one of the things we learned in this project is when you treat someone's depression, it's not just good for their mental health, it saves money. So we were able to get data. One of the organizations we did this in, I see Don here, was Kaiser Permanente, and they had really good healthcare data and healthcare utilization data. And what we learned is for every dollar we spent on doing this collaborative care intervention, we were able to reduce total healthcare spending by $6.50. The Wall Street Journal picked this up, wrote about it. I got more attention from the Wall Street Journal running a tiny little article than I've ever gotten from all of the fancy medical journals that I've published in. So if you want to get people's attention, try to get in the Wall Street Journal. Don't go to JAMA or the New England Journal of Medicine. We've said, now, could we leverage this even more? Could we stretch this even more? Could we do this for people who are not just depressed, but they have more serious mental health problems, bipolar disorder, PTSD? My colleague John Fortney and I just finished a big trial, over 1,000 patients in 12 rural primary care clinics, where we said, can we take this kind of collaborative care to a rural setting where there are not specialists using pure telehealth? And we tested 2 ways of doing that. Telehealth collaborative care and telehealth specialty care, where the specialist does all the treatment, but it's all done remote. And what we found is, in fact, yes, it works really, really well. Our primary outcome here is a tool that was actually originally developed here at RAND, the Mental Health Functioning Summary Score. This is a tool that measures your overall mental health. The population norm is 50. We started with a group of people who were in their low 20s. That's very, very poor mental health. And we were able to get significant improvements with both of these intervention strategies at 6 months, and stayed stable, actually improved some more at 12 months. We similarly saw significant reductions in PTSD symptoms and a whole bunch of other symptom measures. And then we said, okay, we've done all this research. It seems to work well. Why aren't we doing this in the real world? So we're a big academic healthcare system. We took this intervention and we started implementing it in 20 primary care clinics in our own system. And people paid attention to that and they liked it. And the state of Washington came and said, we have all these rural clinics, can't you do it with them? So we have taken we have trained in all but one county of our state at least one clinic to do this kind of collaborative care for a whole range of mental health and addiction problems. And that's generated a ton of real-world data for us, hundreds of thousands of patients getting care in a system like this. And that allows us to look at how well does this work once you take it out of the research setting? Does this still work when you do it more in the real world? And it turns out, yeah, most of the clinics who are implementing this kind of collaborative care are actually getting results pretty similar to what we got in our randomized controlled trials. There are some clinics who don't do it all that well. There are some clinics actually who are doing it better than what we saw in the original research, which was an interesting lesson for me. You can go to those clinics and say, what are you doing right? And I'll say a little bit more about that. One of the things we learned is people really need help to do this kind of practice change interventions. I think Kana mentioned our systems aren't ready. It's true, we can come up with all kinds of fancy new treatments, but if our systems aren't ready to really do them and implement them, it's very challenging. So we built a program at the University of Washington in our department called the AIMS Center. That's another AIMS Center. Now there's an AIMS Center here at UCLA. And what our AIMS Center does is it helps people who want to do system change, who want to implement these kind of interventions in very complex real-world settings. We also partnered with CMMI and with the American Psychiatric Association. We trained 3,500 psychiatrists on how to do this kind of consultative work, which is very different from anything I learned as a resident here at UCLA. And then I took another lesson from my mentor, Ken Wells, and I said, we've done all this work with primary care. What about people who are working in the community? And a couple of years ago, we got a really nice opportunity working with a California-based foundation called the Archstone Foundation to say, what if we took people who are getting health care in primary care and we partnered their primary care setting with somebody who's in a community-based organization, and some of the care happens in a clinic and some of the care happens in the patient's home or maybe in the community. And we did a nice study where we took 800 older adults who were quite severely depressed. And we said, let's offer them this kind of combined care, where some of the care happens in primary care, some of the care happens in the community. This was a California sample, reflected the demographics of older adults in California, 40% Latino, 32% white, and then, a pretty good representation. And what did we find? This was incredibly well-received and incredibly effective. We substantially increased the likelihood that people's depression improved beyond what we saw with our earlier studies, where we were treating in clinic only, because there is something that happens. You're not living in a clinic. Older adults do go to a clinic a lot, but they're living in the community, and if you can add something that's done in the community to what we can do in healthcare, it can make a huge difference. My final comment is going back to this notion that I mentioned earlier, which is, why do we wait until somebody's got a broken brain and is not functioning well and is not doing well at work? Can we go further upstream? So we took this concept that we had learned that when we do good collaborative care, it can make a big difference. And we said, in our city, in Seattle, Washington, in King County, there is 14 community health clinics that serve mostly low-income populations. And we did a project where we adapted the collaborative care model to help pregnant and parenting women. And so we served 2,500 low-income moms with pretty severe depression in these 14 clinics using this collaborative care model. And they were quite distressed when we first started working with them. 34% of these women during pregnancy were having active thoughts of suicide. So this is not a worried well group. This is a group that was pretty sick. This was funded by King County Tax Levy, great partnership with Public Health Seattle and King County. And the evaluation we did for this is a little bit different. This was a pre-post design. We looked at a group of women who were treated in these clinics before we implemented this intervention, and then we looked at a group of women who were treated after we implemented this collaborative care intervention. This is what's called the survival analysis. Sorry, it's the only data slide I'll share with you. So the blue curve were the people before we did this intervention. So it takes about, on the x-axis here, we have the number of weeks that go by, and on the y-axis, we have the cumulative percentage of women who have had a significant improvement in their depression. So you can see before we started this, it took about a year for about 50% of these women to have a significant improvement in their depression. That's a long time to be depressed if you're pregnant. And once we implemented this intervention, we shifted this curve way over to the left. So now it's 8 or 10 weeks, and people are feeling better, and they're doing better. And we didn't use any fancy new treatments. We just organized the treatment a little bit different and made sure that people didn't get stuck on ineffective treatments. This led us to the last thing I'll mention, which is people said, look, this works. Why are we just doing it in a couple clinics in King County? There's lots of people who need help when somebody is pregnant. So we set up a perinatal psychiatry consultation line where 9 to 5, Monday through Friday, anybody taking care of a pregnant woman in the state of Washington can pick up the phone and call one of our perinatal mental health specialists and say, I want to talk to you about my patient, and we will walk with them through that. We can also see the patient. We can do a telehealth consultation for the patient. And that's led us to the thing that I think we're doing right now that I think maybe is the most ambitious. And so we said, we learned a lot from this. There are about 85,000 children born in the state of Washington every year, and we could all pretty quickly agree there's about 10,000 of these births where you would say this is a high-risk situation. This is somebody who is depressed, who's using substances, who might be struggling with trauma, with domestic violence, or a whole number of other psychosocial risk factors. So we started something called Raising Washington, and that's a partnership. And the idea there is, what is it if we take everybody who has something to bring to the table, and we try to provide comprehensive perinatal mental health and parenting support for the child's first 1,000 days. So the idea there is, ideally before you even think about getting pregnant, but certainly once you're in pregnancy, and then the first 2 years postpartum, first 2 years until the child's second birthday. And the goal really is to say, what is it if we invest that upfront? What happens? And we are doing that right now. There's 8,000 births in our own academic healthcare system every year. We're starting there, but the goal really is to say, if this works well, once we figured out the bugs, Can we take this statewide? Can we offer this to every single child born in the state of Washington? And that's, I'll wrap up on this. This was a very brief tour of a whole bunch of things that we've tried to take brain health to scale. Happy to take any questions. Thank you.
Thank you very much. Funny little joke, but you must be German or Swiss, I take?
I'm German.
Yeah, okay.
Well, I'm American now. I started.
Yeah,
as a
me too,
German.
me too. You proved that your name is exactly the opposite. You got so much done. It's incredible. And I wanted to ask you, how did you garner support for this development of the research, but also into the health system? What was your argument? Because that must have started years ago.
Yeah, it's a journey. I would say the most important thing we can do about stigma, about getting this stuff on people's radar screen is help a person who's struggling and help them get well, because people see when somebody's struggling, they got better. So we've done a lot of work in our own academic healthcare system, working alongside our colleagues in every medical specialty. I have a psychiatrist in every specialty in our academic healthcare system. I have somebody in the cancer center, I have somebody in the heart center, I have somebody in our high-risk OB clinic, and they work right alongside their colleagues, and they help them with these really difficult patients, and all of a sudden these doctors are saying, wow, when depression goes away, when substance use goes away, this is a different patient, this is a different person. So I think some of it is just showing people that you can make a difference with treatment. I think in general, all of the talk we have about stigma and mental health is, if you make it go away by treating it effectively, all of a sudden that stigma looks a little bit different. So that's one strategy. And I think, we did that long enough where I think our healthcare system recognizes it. And our colleagues, even though psychiatry is not a big moneymaker in our academic healthcare system, our colleagues don't want to be without us anymore. So they're the ones who are making the argument for having good mental health support and brain health support alongside. On the state level, I would say we have a fortunate situation in the state of Washington. We're not California. We're not so big. There's 8 million people. It's a very big geography. And we have a really good, close working relationship with our state legislature. Our legislature, when it's in session, I go down to Olympia, Washington, probably every other week, and they come to us and they say, can you help me with this problem? Access to mental health is a huge problem. And those kinds of economic arguments, you can bring them at a state level. And once we started doing this consultation project, when I brought this to my colleagues, I said, we're going to be able to answer the phone for anybody who wants to talk about you. They said, are you crazy, man? And I said, it's going to be really fun and rewarding, and people will call you, and you're going to have answers, and you're going to feel good about it. And it turned out it was a tremendous investment, because every single county has a legislator who's benefited, has a doctor or a nurse or somebody in their county that's benefited from one of my colleagues giving them really good support at a time when they really needed it. And they go to Olympia, they go to the legislature, and they support this. So this bill that created some of these services, this bill that created our new $250 million Center for Behavioral Health and Learning, was the only bill in the state legislature that year that got 100% of votes from both the Republicans and the Democrats. So I think you have to go out and you have to do something that makes people see this person actually really helped me. And then people can be very, very supportive.
Bless you, Jürgen. As somebody who's spent over 20 years of my career at Kaiser Permanente following trails that you and Wayne have laid down, I would just say thank you, and to your mentor who's here, well done. Specific question about the two of the interventions. One was with the elderly people with depression that got community treatment. What did that look like? And the same question for the pregnant moms and early families. And just by the way, I think that last slide was one of the most important brain health slides we've seen in this event, which is how do you make healthy brains at the beginning? But so what were the community interventions in those two?
It's interesting. We chose 6 pairs of primary care clinics. The primary care clinics applied to the foundation for funding to do this project, and we asked them, you choose your community partner. And they were all quite different. Some of these were out in the Inland Empire, San Bernardino area, and they chose to work with a group of people who sent promotoras to patients' homes. We worked with a program in San Diego that worked with basically a soup kitchen, a place where older adults and seniors could go and get meals. We worked with a Meals on Wheels program that's up in Central California. So they were all a little bit different, but it was interesting because they would come to us and they would say, well, we're about food, or we're about this other thing, and we don't know much about treating depression. And I would say, actually, you could be very good at it. So, for example, the folks in the Inland Empire, the promotoras, they didn't see themselves as treating depression, but they'd be in the homes with depressed older people where the people were really depressed. And we taught them something called behavioral activation, which is a simple, brief, evidence-based psychotherapy for depression. And they took to it, and they did an incredibly great job with it. In fact, their outcomes, their clinical outcomes, were way better than anything I've ever seen, in a clinic. So I think that it varies a little bit. I think you have to find the right partner. You have to make a relationship where the clinic isn't feeling like these people out there, we're going to have to share some of our money with them. It has to be a true partnership. And when you can make that happen, it's amazing, because there's people in the community who have access to our patients. If you give them the right skill, and if you give them a psychiatrist who says, when you're getting in over your head, you can call me and I'll see your patient, then they'll be very brave. They can do a lot of really interesting things.
Okay, we're going to have one last question. I know we could have a lot more, but we have to move things on. So last question.
Jürgen, thank you. That was really a transformative paradigm that you outlined there. My question was about the primary care punch-in. Could you describe what level of practitioner was the mental health consultation person that was, backed by a psychiatrist?
Yeah. In the original trial, we used nurses, we used some clinical social workers, we used people who had some formal license. I would say in many of the settings we've worked, it's not so much the person, the degree or the professional training of the person. You need somebody who's got the right skills. So we've trained, like I said, in the community-based project, we were training community health workers and promotoras. A lot of organizations train master's level providers, licensed therapists, nurses can do this very well, social workers can do this very well. I think what you need to have is a person who's got an interesting combination. They have to be extroverted enough to engage with somebody and to keep engaging them, because depressed and anxious people aren't that easy to engage. They give up very quickly. But they also have to be organized enough so they don't just spend all of their time with 2 or 3 people. They have to keep track of a whole caseload of patients and know when somebody is not getting better. So it's finding the right kind of person and then giving them the skills. Nobody has all the skills they need to do this. So our psychiatrists, I think a lot of what they spend their time doing isn't so much direct patient care, but it's helping that person who is actually with the patient, finding the things that they still need to learn. So they do a lot of teaching, and I think they actually like being in that role. Okay.
As an interneuron.
Thank you.
So I witnessed Jürgen's career blossoming and taking flights to space and whatever else. It must be very satisfying to have this laboratory under your fingertips and testing your own research and theories. I congratulate you on these successes. Another German, I assume, changing the lives of Americans. So the next exciting talk about successes, and with very provocative, oh, you disappeared your title, right? The brain economy goes west. Yes, the bigger is better. So Dr. Johan Reiser is the president of the University of Texas Medical Branch and the CEO of the UTMB Health System. He's also a professor in the John Seeley School of Medicine and is the John Stobo Distinguished Chair. Welcome.
Good morning, everybody. It's wonderful to be here in Southern California at this meeting. It is so highly collaborative. I just love this field. So I'm a physician scientist. I'm a nephrologist. And I've worked in molecular kidney disease and immunology for almost 30 years and a lot of NIH funds and all of this. And I can tell you in the last year and a half that I got really interested in the brain economy. I've been invited to speak more on the brain than I've ever talked in the kidney in my entire career. So that's just fantastic. And you can see from this animation of the brain here that there's a lot going on at our institution, but also as a local and global movement. And I'll talk a little bit more about it. We just partnered with Blue Zones to turn Galveston, Texas into a blue zone. And that's obviously supporting a lot of brain health and mental health as well. So you might ask yourself, so why the brain economy for us? And so when I became the president of UTMB about almost 3 years ago, I was pretty clear on what I had to do on the health system and sort of like streamlining all the missions, whether breaking down silos, all what you hear when you go into LinkedIn podcasts and Beckers, and that's all clear. But I wasn't so clear what could be a lighthouse, what could be something that's truly changing the university and the entire institution and bring back the relevance of something like UTMB, which is the oldest health system and university for health in the state of Texas and west of Mississippi. And then I listened to a talk with Harris. Don't leave now, Harris, because I'm mentioning you. He was giving a talk on the brain economy. It was almost 2 years ago, and it really stuck with me that what else is there if we don't invest in the mental health and the brain health, not just of our students, but also of the workforce and the communities we serve. And I sort of like got hooked on that conversation and saw how this will feather with others, and everybody thought it made a lot of sense. So I do want to talk a little bit more about why this conversation is so timely right now, and what does brain capital mean? Now I realize this is the second day of the symposium, so by now probably everybody in this room knows it anyway, but I want to rephrase it a little bit. And then what are we doing at UTMB to actually put this in action, and why this is so important that it doesn't just stay with UTMB, that it's really only done in partnership with other institutions, particularly here in California, but also across the state, the city in Houston, we'll talk about that, and then also on the global stage, whether it's the World Economic Forum or really everywhere in the world. So there is a huge cognitive demand right now, which is rising. And in a short theme, I sometimes refer to where we're living through as artificial intelligence versus actual intelligence. Luckily, it's the same acronym. So AI for me means both. We're asking more of the human brain. I'm sure if you look at your phone, how much phone time you have, aren't you shocked when you see 10 hours or so? I mean, and it doesn't even seem to be that hard to reach that. And so we are piling up more and more technology into our own life, and we're not necessarily feeling a lot better about that. We create a massive amount of data, about 136 terabyte a day. I checked my laptop that I brought here, and I have a storage of 0.5 terabyte on the entire laptop. So essentially 250 laptops at UTMB, fully loaded with data every day is being generated in terms of data. Now you can say use AI that can handle it, but then there's so much data, you still have to then go back to the human brain. We got to do something with it. So it keeps piling up. So we cannot scale like AI can, and we have cognitive overload, and we have more and more fatigue that comes with it, and we're searching for new ways of dealing with this, and we have to realize there's a growing gap between tech capability and the human capacity. On the other hand, we're living a lot longer. And if you look at the sort of like the life expectancy of mankind, and especially in the last maybe 200 years or so, we've done a good job to outlive our own possibilities and are wanting to live longer, happier and healthier and more meaningful. But with that comes another challenge. How do we keep what's so uniquely human, i.e. our brain and mental health, in pace with that physical capabilities that we have created, that we stay longer fit and all of that? And for whatever reason, we haven't really fully focused on that, what seemed to be the most important part, right? And we have not been following as much on that topic as we should have. We also have another problem, that something happened in 2010, this is Europe, where it became obvious that the aging workforce is shrinking. It's about a 40% reduction in workforce over the last 100 years if you project it forward for another 70 years or so. And this means more retirees, less workforce, rising costs in healthcare, and a lot of issues to deal with. Who's supporting all these people that we cannot keep in the workforce? Connor, you've shown some data that speak to that slide directly. That's a problem. The other part is the paradox here, and we have, by the way, we have the same in kidney disease. I am being asked by my kidney disease researchers on my brain talks to also mention kidney disease. And it is a big problem because we have 800 million people with kidney disease. They also have cognitive decline a lot faster and more prevalent than if you don't have kidney disease. Similar here with Alzheimer's. So we have hundreds of billions of dollars each year that we lose in economic force because of Alzheimer's disease. We have a huge amount of healthcare cost that we have to put in. We're investing in AI. We think that's the solution. And if you can't see the other lane at the bottom, then it's because it's almost not there. We are investing literally peanuts in the research that deals with understanding and treating Alzheimer's. This is a line at the bottom. So if you have a hard time seeing it, this is a line. So it just gives you sort of like the wrongdoing that when we are looking at a disease that affects us on such a global level. We also, and I mentioned this earlier, on the healthcare system, but even if you look in general, not just looking at healthcare institutions, we have an incredible amount of new data that we are generating. We have really advanced very much into this cognitive revolution. We'll talk a little bit more about it. And the human brain is at a standstill. So we gotta really not just invest, we have to catch up. The industrial era is probably a part of why we are living longer. We've had a lot of transformation of physical labor. Then it was followed by the digital era. That was when the computers started in the 80s and the internet and the phone transformation and all of this. But now we are at a different level. We are in a cognitive era. We have to maintain and grow in our ability to think, learn, and adapt. And we have to develop strategies to define new brain skills and really put our brain capital at the center of this. I don't even call it a next economic shift. It's a shift that already has occurred. We're in the middle of it. And the problem is that technology accelerates, brains do not. The rapid technological advancement that we see is paralleled by our human cognition that is remaining pretty flat or is even declining. And especially, remember that slide that I've shown you in the European workforce, since 2010, something happened where new technology has not translated anymore into us performing healthier and better. And we have rising mental health challenges, burnout and distraction, which perhaps was magnified by the pandemic in 2020, but it has already declined since 2010. And we see more and more cognitive fragmentation, burnout, and there's an urgent need for coordinated research and strategy, and we have to really understand what the decline means for the brain economy and begin to shift a negative brain economy into something that becomes positive. So what is the brain capital? It's really the human asset. It's the cognitive and the emotional assets that enable human flourishing. It includes brain health. It also includes mental and neurological health. We have to stop separating those two. It's really one. We need to talk about cognitive resilience, and we need to think about innovation and productivity in a different way. And then on the right side of the slide, you see a few points that you can read for yourself. All of them are necessary, and we cannot separate them out. It's not so much just seeing where in your brain is perhaps a stroke or is perhaps the localization of the Alzheimer plaques. It's also about the functioning of the brain that defines our mental health and our values that are so typically human, critical thinking, ethical thinking, all of that. So we have to, as a society, and society can be interchangeable for university, we have to believe that brain capital is the most important asset. So let's invest in brain health. We saw in Dr. Unitzer's talk a great example of how this can look like and the impact that one can create. We need to focus on education and learning in ecosystems. Think of people who are neurodivergent. Right now we're trying to bring everybody back. Oh, you have ADHD, so we need to refocus you that you can study the content best. No, let's do it the opposite way around, where we allow those students to be at their best by us attending to them and bringing the content to them in a different way. And that means to create environments that support cognitive performance, which is different, means different to different people. We need to create fluid institutional designs that support human flourishing. Again, Kana, this is a slide from you. It just shows if we do that, even in the US, by 2050, we can create $1.9 trillion more in economic growth. It's about 17 bit points in annual GDP growth. This is significant. And I've begun to reformulate for chronic diseases what it means when we take a chronic disease. Let's take kidney disease. Yes, we want to fix the kidneys, but if you fix the cognitive performance in a chronic kidney disease, you're going to get a lot more economic growth. It's a different way of looking at the loss versus just saying, let's treat a disease and not thinking why that is. Of course we want to treat the disease just because we want to make people feel better, but let's define it in economic terms. We'll open more doors if we do that. Okay, so what does that mean? Now I'm bringing it back to UTMB. So one of the first things we have done is we officially opened an innovation domain. So we had 3 components: education, research, and clinical care, like most universities. Now we have a pretty flourishing innovation domain as well, where we have a whole structure. We have an incubator, we have accelerators. We have created for-profit vehicles to be able to invest alongside with companies. We're making our data safely available in partnerships and so forth. And we want to ideally continue to bring in more brain-intense research, whether it's in the cognitive field, or whether it's in the AI field, or whether it's in behavioral health field. So we're focusing on that as a key parameter. Not only do we want to innovate, but we want to make sure that as part of whatever that innovation is that we're investing in is bringing us a rise in the brain capital of UTMB. Now, UTMB is very big, so we have a very unique opportunity here. One, we are on an island that is smaller than UTMB. And that is historically driven because most people came to the US 150 years ago, either through New York or through Galveston. That's why it was called the New York of the South. And then, not to go too much into history, but we had the 1900 storm that destroyed that idea, and then the Port of Houston was created, and Houston was located 50 miles further inward. But UTMB remained. So we have this beautiful big health system, and we are essentially the main economic driver of the region. So if we say we want to invest in brain capital, guess what? The community of Galveston and the surrounding communities are beginning to do the same. And that's also why we agreed to do the Blue Zone project. I'll talk a little bit more about it. So I think I'm bringing this slide. Of course, I like to talk about UTMB, but it's about also thinking at your own institution. What makes you uniquely positioned to be a driver of the movement that we are talking about for the last day and a half. Now, we are committed to building a brain-positive ecosystem. We want to support brain health and cognitive flourishing, and that means having components of what that means in research, clinical care, workforce culture, technology, community engagement, so forth and so on. And here you see a high-level summary how this, for example, could look like. I'm going to jump right to orange, workforce and community. We developed together with a company called Wombi, connectivity empathy tool. It's their tool. We have adapted it into UTMB. Okay, it's an app. It's in an app form. And we were planning that maybe 10,000 employees would sign up for this. We have more than 20,000 subscriptions. I can't possibly read all the compliments and reinforcement that are being given on Wombi. I was blown away. We started this in December, and it sounds very simple. Yeah, it's a nice thing to bring an empathy app. People have a dire need for connection. I mean, I'm a healthcare CEO, right? So I look at numbers and open clinics and this really surprised me. And by doing that, we have a much happier workforce. There's so much going on now on this empathy app. And by the way, if you don't want to give a compliment, you can also do that, but it's filtered into patient relation or into our workforce engagement. So even negative comments, they won't be published. You don't see them, but they're not ignored. They're going into a different bracket, and then we work on them, and then there's other feedback. So it has been a great tool to really engage the entire workforce, and now we're developing something together with the students. We haven't done that yet, and the patients are also being part of it within a certain way. We have started a brain health initiative and the Moody Brain Health Institute. This is a brain health research and public policy institute. We got some generous donations, but we also brought multiple neuro and mental health research under one roof. Very important that we break down the silos of these individual domains. In the state of Texas, we obviously have, and you might have heard this, we have a Dementia Prevention Research Institute of Texas, which was just put forward about a year ago. We were helping the state legislator to think about how this program should look like. It started with Alzheimer, and it's now much wider than Alzheimer. It's $3 billion over 10 years. That's a lot of money, and it has created a lot of focus that, of course, we want to do neuro research when we have these funds in front of us. So that really helped, and that also brought us to the role of UTMB within the region. So there's another project in Houston, which is called the Project MEDIS. MEDIS is, I think, Zeus' first wife, and then he was worried that she's producing someone smarter and more powerful than Zeus himself, and that, I think, was not a good end. But she's also the goddess of wisdom, and so the project was called Project MEDIS. But it is a transition in Houston, in the region, together with multiple industries, not just healthcare, university, also other universities such as Rice, Memorial Hermann, and others are coming into this, but also oil and gas companies and other companies to really drive projects in great partnership across the region to become a lighthouse for this transition from a brain negative to a brain positive economy. And Houston has done a good job before with the energy transition. So they did something similar to move from oil and gas to still oil and gas, but in combination with reusable and renewable energies. And we want to do something like this in Houston. And then there's the global component here that is at the World Economic Forum and in Davos, but also in Europe. And so if you look at all those components together, you see these partnerships that are forming. And what we are doing or trying to do at UTMB is at least 50% reflected in the Project MEDIS, it's 50% reflected in the national dialogue, and so we really help each other. And that's why I'm hoping, that's why I'm here. I'm hoping to find more partners. We're already talking with UCLA. I met with the chancellor yesterday, Chancellor Frank, and was walking the beautiful campus. I was in Berkeley the other day and met with a chancellor at Berkeley, and I know that many of you are already collaborating, and I'm hoping we can bring this together so that with time, hopefully not too much, we are beginning to significantly invest in what makes us uniquely human. And so we are standing very pretty, or at least we have a chance in the face of AI. And with that, I want to thank you for giving me a chance as a nephrologist talk here. It's really been fun. If I would do it again, I would probably study neuroscience or psychiatry right away. So it's been great. Thank you.
We have time for one question, and then we'll have to move on because we're running behind. Sorry.
My name's Ramsey Eldib. I'm a retired engineer, rocket scientist, basically. Our house burned down in the Palisades fire. My daughter graduated Luskin, master's in public policy in June. She hasn't been able to find a job. She's depressed, the house, the job. She recently moved to Phoenix with her new husband. He got his master's in electrical engineering here. She saw a doctor while she was here in school, excellent doctor, and it helped her a lot. Now she's in Phoenix, and it's like impossible to see a psychiatrist. It's like months out. So her new husband calls us and said, oh, she's crying, she's depressed, what can she do? I have a Tesla that has Grok AI in the car, and it has a bunch of different versions, and one of them is a doctor, one's meditation, all kinds of things. I drive to my doctor's office to an appointment. I get a doctor immediately, or a pseudo doctor, and I tell I'm going to the doctor for this and that, and it gives me all these questions to ask the doctor and instant feedback. And it seems like we need to embrace AI more and not be afraid of it. Everybody's afraid of using it because they're going to lose their job. My daughter, I tell her, you can talk to a doctor basically on the AI all the time, constantly. And she was, it's in her mind, oh, I can't get a job. Other people are telling me don't use AI because they're taking away jobs. So bravo, it sounds like you're embracing it, and also him, and I think it's a good thing.
Well, thank you for your comments, and I hope your daughter continues to feel better. And I'm actually planning after this meeting to go out to the Palisades. Part of it is I want to see the Thomas Mann House because I'm a big reader. I studied German before I studied medicine, but I want to also see what has happened there. So I hope it's going to be better. But the other point that you're making is so important is, yes, we have to embrace AI, but the fear of AI replacing us is not going to go away by telling people it's going to, don't worry about it. We have to up the game. That's the bottom line, right? We have to go away from the simple task because, quite frankly, people who do these simple tasks and don't want to move up in their skill, they're going to have a harder time. So this is also brain economy. But we have to embrace AI for sure, but we have to grow with AI. And I think there is hope that we can do that.
There's, about that, there's a conversation what makes us human. What is the advantage of human brain? And I think we're just coming to a conclusion, this type of gatherings are happening everywhere. And that pushed the agenda of human brain forward. It's really an acceleration. And, I do a lot of spiritual work. And so there's always a silver lining in any event. People learn it's an information for your growth. And the time has come to innovate. And we can't wait because of this pressure from AI or from other circumstances. And that's a big accelerator. The question is, can we take the pressure? And my argument, yes, we can. And then we should, and we will, and there's no other way.
Other way, and we don't really have that much choice. We have to do it.
Yes.
Yeah. Well, thank you.
Thank you so much.
So very unusual panel that is going to happen tonight. This morning. For me, it's like 72nd hour functioning. So it is my pleasure to introduce a colleague of many years, Dr. Linda Erkley, who will moderate this session, but also Mark and Pam Sennett, with whom I connected. He was referred to me by a colleague of mine over a year ago, and we've been talking since. Very enlightening talks, and also sharing Mark's experience. He'll talk more about, yes, please put on that image that is now coming in. That's his work. Yes, that's Mark's work. He is a photographer. And his wife, Pam, will share their experience, their journey. And also Sandy Glistein, who represents herself and Maria Shriver's enterprises. She's a partner of Maria Shriver. And then James Keach is an amazing producer, director, Hollywood legend. Also will talk about his experiences. So this is a patient slash caregiver slash witness slash observer slash healthcare provider and educator. We've never had anything like this, so welcome.
I can't use the podium. I didn't get that bolus of growth hormone during my sleep. Thank you all. Thank you for that introduction, Helen, and thank you for being here for a second day. And welcome to you, and welcome to the folks who are streaming this event. So we have a room here full of everybody, policymakers, caregivers, former caregivers, people who are struggling right now with some neurodegenerative or mental health problem. We have researchers and clinicians and everybody else under the sun, community partners and people who are interfacing with caregivers and patients every day. This is about where the rubber meets the road. That's what we're talking about here, is the voices of caregivers and people who are right now living with Alzheimer's disease. So Dr. Lovretsky gave an introduction that was fantastic. I cannot follow that up, but please look at people's bios. But we're going to be talking today to the Senate's Pam, and of course, Mark. We're going to be talking to Sandy and James Keach. So let's start, and we're going to have a conversation about living with Alzheimer's disease and how do you advocate and bring people to the table through advocacy, through art, etc. So let's start with a video about Mark's and Sandy's incredible journey of resilience and strength.
Some of the things that we know about women's brain health are just shocking.
2/3 of people with Alzheimer's disease are women.
Hold on, I think this is the wrong video.
1 in 5.
Can we go back to Mark Sennett's video, please? This is for Sandy. It's really good. We'll get to see that part over again, too. And while we're waiting, I just, please, while you're here today, it's a great day to network and don't leave without people's information. So,
Pam and I went to
Jamaica. We went to Australia with Mel Gibson for Mad Max.
Yeah, we traveled all over the world, really.
We did.
Mark did over 100 People magazine covers during that time, those years. And wherever there was a movie going on, any big movie from E.T. to Empire Strikes Back to Mad Max, Mark was sent to cover.
I was assigned to Kenny Rogers to photograph him. He just had his baby, Christopher Rogers, and Pam was the nurse to the baby. I came down with my gear. Pam walks into the room with the baby, and I was smitten immediately. I just fell for it right then and there.
Gradually, we fell in love. And
How gradual was it?
And then we went
Not for
back
me.
to Los Angeles together. Yeah.
I had a great sense of humor that I would lay on everybody, and they just thought I was nuts, and they would really enjoy the session.
You had celebrities doing things that,
They shouldn't be doing.
well, that they wouldn't normally be doing, like Dudley Moore was pretending to cook his dog on the stove.
He had this beautiful Steinway in his place at on the beach, and he was going off to New York to perform at Carnegie Hall. I asked Dudley, could we take your piano to the beach? And he was not going to let me take the piano, so I rented one. And I put him in his tuxedo. He's playing the piano, and black and white, the whole thing. And then his dog must have heard the music, and the dog was black and white. And just the dog comes into the shot, and Dudley's looking at the dog's looking at him, and it was a very cool shot.
Nanu, nanu.
I became pretty friendly with Robin Williams, and I did his first cover with Mork and Mindy. And anything you asked Robin to do, he would take it to a different level.
You're very funny. You have the most amazing sense of humor. You laugh all the time, which has really gotten us through your diagnosis. Well, I think the diagnosis was a shock. We knew that something was going on, but we weren't sure what. And Mark had had a seizure. So we didn't put seizure, Alzheimer's together. Mark's incredible spirit of, we're going to enjoy every day. We're not going to let this get us down. We are going to push through this. And that's how we have kind of taken it from that moment.
It's such a strange disease because you're compliant to it. But I would imagine that when you get this death sentence, you would immediately react to it like that. I didn't. I didn't have a spare day to get upset about it. I have 3 films I'm working on. I'm working on the coffee table book, which really excites me. That's all I can think about, is when I get behind the camera, what am I going to shoot today? As far as my work goes, I can't cut that off. That's who I am. And I think that the more interesting things I do with a diagnosis gives me hope.
The reason, before we had the diagnosis, that we moved to Atlanta was to be close to our daughter. Family is so important when you have a diagnosis like this. We had developed in this community friendships that are very supportive. It has been just so much easier, I think, than being in Los Angeles.
I was concerned about moving here and giving up my career to an extent. But I think just our family together is so special to us.
The diagnosis has brought us even closer together.
Yeah.
It's made us slow down a little bit, smell the little roses along the way. This disease can hit you. Doesn't matter if you're a photographer,
or what you are,
movie star, a teacher, a nurse. This disease can come, and here it is.
I find my hope with some of the specialists that are trying to get this disease under control. So part of the book, Alzheimer's book that we're doing, I've been reaching out to the pioneers in this world, because I think you can combine what they're working on to eradicate this disease, and also make it not entertaining, but make it hopeful. Most people that get this, they don't have this window that they can bring some light to it, you know, and I think that's so important. And it keeps me and Pam and Lauren going, because every day should look beautiful.
This is your window.
Yeah,
This is your window to do this work.
Yeah. And it's something that for me, I feel I should do because we've had a crazy life. I know it's going to change our lives at some point, you know, but it doesn't have to be today.
In my life, I love you more.
So, Mark and Pam, that was so inspiring is an understatement. But Mark, I wanted to ask you, you are thriving with really early onset Alzheimer's disease. You are working. What is this like for you? What have you learned from this journey that you're on and you continue to be vital?
That's an interesting question. It's been just about 4 years that I've got this. And, you know, Pam and I just celebrated our 43rd wedding anniversary. And even though we're from Hollywood, which is unusual to say the least, yeah, we're really enjoying living in Georgia around our daughter, and have made really great friends with Sandy and with Helen. And Helen and I are doing a photo session on Monday with her babushka outfit, you know.
I want to see
yes,
that.
mhm. And, you know, which thrills me. And I think that my photographic career, which was a long time at Time Life, there's the first part of it, and then the new part is when I got diagnosed and how I look at that photographically. And it's not with depression. You know, I don't feel I don't get up, this is not a death sentence at all for me. And I think that if people that look at it and have Alzheimer's and approach it that way are not going to make it. You know, you have to, a good friend of mine says, Mark, you really have to love life. And that's the most important thing to do, and your relationships, because, you know, you only live once. And this is something that, yes, I wake up, I know I have Alzheimer's, but at the same time, it's not that I don't care about it, I don't think about it. You know, I think about what I'm going to do today, how I'm going to have fun. I have a crazy sense of humor, which I've not given to James yet. And, and really it's about the quality of life. And I think that the disease, for me and for Pam, makes it, our life is richer than it was before Alzheimer's. I love my routine in the morning is to get up and sing to Pam a lot of Neil Diamond songs, which drives her crazy. And especially, you know, and getting into the new Elvis stuff, music, which is really good. And then I go to PT for my shoulder, not for my Alzheimer's. And I try to get, because everybody's really old, you know, at PT. I mean, they're in their 80s, 90s, you know, and I'm trying to get them, I arrange dates, you know.
It's a new hot scene.
Yeah.
Right? Okay.
Mm-hmm. And I have a great time having fun and with my sense of humor. And a lot of that is having a quality of life that is much more described as who really I am and what I want to do and what I believe that I can contribute to people that have Alzheimer's, because you're really, I look at it as an advantage. You know, I know most people, when we're listening to all the doctors and things that have to be done, you know, that's all great material. But for me, you know, I work out 6 days a week. I watch my diet, and I watch movies at night. Some of yours, James. And I love talking to Sandy. and Helen, because it's a new day. It's a new day, and I have the best partner who is for 43 years and who is drop dead gorgeous and is just the best friend I could ever have in my life. So all those things combined together, you know, make this part of our lives. And I'm 75 years old, and there's a lot of things I can't do that I wish I could.
How do you deal with that though? Like, because your attitude is one of like, nothing can stop me except at some point when I'm going through. What do you do about the things that you notice have changed, whether it be your work or in other areas of your life?
Well, to answer that, you know, my long-term memory is totally intact. I have probably 300,000 assignments when I was at Time Life. And, you know, a lot of assignments that I have problems remembering. Putting the film out there, you know, brings back the situation for me. I'm working on my 3rd Stephen King film, and have let my agents and producers know what I'm going through, and they've all been very supportive to me. You know, it's not like a stigma, you know, that there's the first part when I had got diagnosed, everybody thought, oh my God, he's dying. You know, they would call up and do that. So to answer your question, if you really think about the downside of Alzheimer's or, you know, or dementia, I don't think you're going to make it. So I think the most important thing you can do is setting up goals and things that you want to do. And if you wake up every morning and you think this thing's going to kill you, you know, I don't look at analyzing the day. If I can't remember something in the short term, I ask Pam, and she'll remind me. I do have those issues, but they don't last long. I can retrieve the memory pretty quickly, which doesn't, I really don't feel that much different today than I did before I got the diagnosis.
What about, and this is for both you and Pam, what about brain health, and were you practicing brain health before, and what are you doing now? So you mentioned some important things like staying stimulated in your exercise. What else?
You know, we were never thinking about brain health before. Our life was so busy, we were running through life. But this diagnosis has made us really stop and think about our mortality as well as what we can do to stay healthy. And we have worked very closely with Emory Brain Institute in Atlanta, and they gave us a lot of recommendations of what we can do, such as CPAP, Mark got a sleep study, exercising 5 days a week, a lean diet, monitoring his blood pressure and his cholesterol, staying on a statin anti-platelet. And Mark is so compliant. He is the best. I'm a nurse for 40 years. I've got to be honest with you. Mark is the best patient there could be.
Coming from a wife,
yeah,
that's
for a wife,
major compliment.
You know, and it's his dedication to all of the interventions of a brain healthy lifestyle that I believe have kept him stable. He's in the early stages. It's been 2-3 years, and wow, what a joy to be able to have this time together and to keep him stable. And we're going to continue working on that.
What about you, Pam? How has this been for you? Because, you know, the sad part is you did notice changes, and you couldn't ignore them.
Yes.
How has this been for you?
Well, Mark started having changes at least 5-6 years before a diagnosis. And when we finally got a diagnosis, for me, it was absolutely devastating. We were told basically, go home, good luck, and there were absolutely no resources given to us. So we struggled and we scrambled, and again, we found Emory, and we also found the Alzheimer's Association, who gave us recommendations that we're using now. For me, for Mark, because he's so dedicated in all of his interventions and his brain healthy lifestyle, it's hard to keep up with him. I mean, I've had to really think about caring for myself. Nurses don't do that very well.
That's right. They care for others.
They care for others, so I had to really focus on that. And I'm seeing a therapist twice a month. I Zoom in with her. Her mother died from Alzheimer's disease, so there was like this instant connection. And she's been so helpful in me processing my fears and worries, because there are. I don't want to sugarcoat it, but there are, although we're doing extremely well.
Would you share what a couple of those are, if it's not too much to ask?
You know, every day I worry, how long am I going to have Mark's mental ability with me? He's the love of my life. How long am I going to be able to be with him and keep him so that we can have this lifestyle? I'm crazy about him, so I worry about that and the future. You know, I want to keep Mark home. We have a ranch-style house that we bought so he can stay home, and I'm hoping to be able to do that. And maybe look, Tony Bennett lived into what, 95 years old?
Yeah.
So maybe we will never have to cross that path. But we're talking about, we picked out our plots together.
Okay.
And so we've done some things like that, and we have our finances in order. I've made a good friends and community in the neighborhood that support me. I joined a women's club, and there are lots of Zoom activities I can do, from book club to yoga to Marjan. That's a big thing in the South. Needlepoint is a great thing in the South, so I've taken up needlepoint.
It's good brain stimulation to do something new, too.
It is, and I love to walk. And I also just purchased an electric bike. That has given me so much freedom in the neighborhood. I can ride, and I can get home fast. So, you know, as Mark said, our life has become very rich, richer than we lived in Los Angeles. It's amazing.
And what the two of you are doing together, the research says, should prolong the good years.
And I believe it. I think Mark is living proof of that.
I do too. So you can thrive.
Yes.
This is about thriving.
You can thrive, definitely.
Now, one thing that struck me, and I want to thank you both for this, and we're going to have some more conversation, but one thing that struck me, Mark, is how many of the people you photographed developed neurodegenerative diseases. And we see Robin Williams was there, Ronald Reagan, but also Nancy in her later life had vascular dementia. And it really struck me. And because you didn't know it was coming, like you didn't know this was going to happen to you too. And I wanted to segue into James Keach, because this is exactly among his other accolades and professional activities and artistic endeavors, is that James has done many documentaries on people suffering from chronic illnesses, particularly neurodegenerative diseases. And he is showing how to also bring this to the public so that people understand what that daily life is like, and juxtapose it with who that person was across their lifespan. So can we have the trailer on? Okay, Mark, go ahead. I'm sorry.
No,
my bad.
I looked at James's work, and I haven't been able to see everything, but it's absolutely brilliant and so important to bring, different than photographs, but just emotionally, the work you've done, James, is just phenomenal and so important to do. The only example I'll give is two. One is Robin Williams, right. And Robin. And I photographed Robin for like 15 or 20 years. And, he was the type of man that, however his brain worked, was unbelievable. And there was a side to him, if you could penetrate that humor and everything that he was, there was a much quieter man in there, and he wasn't always on. But it took time to really, dig deep with him and get him to relax. And so when he hung himself, and had, this disease, and it was, different, And the other person was President Reagan. And I was pretty close to President Reagan in the sense that I used to travel with him when he was running for president. And I was a producer at HBO, and we had him come to a meeting and with his Alzheimer's, and he wrote a letter later, and we were talking about Gorbachev and him, and he couldn't remember, why he was in the meeting. And it just blew my mind, now that I have it. And I know this was a long time ago, but this was the most astute, brilliant, person, and how protective that Mrs. Reagan was for him. And it was just, and she said to me one day, she said, the hardest part about this was that everything that we've accomplished in life and as a couple, and he can't remember it anymore. It was just absolutely devastating to me. And so when I got diagnosed, this is kind of a strange thing, I didn't want to end up like that, and I don't fight, I just, I don't think I'm heading down that road. I don't feel like I am, and I feel like the more that you work at being positive with your life, and the more you have a wonderful partner, I think I'm going to be around a long time.
And we know from the research that all of that positive thinking and people feeling valued, having something to give, is really important for thriving with a neurodegenerative disease. Do not roll up your driveway and turn out your porch light, right?
Exactly.
Okay, thank you.
The record he's got out, which I guess is one of the biggest records he's ever had, called Rhinestone Cowboy. Somebody told me he's on the way to selling 2 million copies of one record.
He took country music to new heights and became a global superstar.
Who is that?
That's Billy.
Billy. And who is she?
That's your second wife.
Really?
This indicates that in all likelihood, your difficulties are due to Alzheimer's disease.
I mean, I was drinking about a quart of vodka every day in my life. And if I didn't, I would get the delirium tremors. And I mean, you'd have bugs crawling all over you, and just from withdrawing from alcohol. I mean, it's some diabolical stuff to some people.
Just like a fool. Mm-hmm.
If I can somehow save one person from having to go through the hell that I went through, mine will not have been in vain.
Living this life alone.
She was the first female rock and roll star.
When we heard our voices, it was like a high like you've never felt.
I've been put down. I've been pushed round. When will I be loved?
You know, I'm grateful for the time I had. I got to live a lot of my dreams, and I feel lucky about it.
Another person with Parkinson's said that life after death isn't the question. It's life before death. So how are you going to do it? How are you going to live?
I hope you know nothing about ALS.
It's the brain functioning without a body. The brain in solo flight.
Everything was thought about in terms of when Augie dies.
I'm gonna beat this son of a bitch.
Here's a guy who's in control of everything.
We can see Ogie getting stronger.
He's going to be an entrepreneur in the ALS field.
He's the only one. He can change the way we think about this stuff.
He's learning how to be alive.
When we got the official diagnosis, you have Alzheimer's. Adele was distraught, and she swore me to secrecy. She was ashamed.
Never seen anything like this. This is so far beyond what I ever thought this disease was capable of. And the only thing that made it manageable for us was that we had money.
It's not fair. People that have given up their jobs, their friends, all to care for their loved ones.
Nobody's come up with a disease-modifying medication for Alzheimer's.
You give a new medicine to somebody, it takes a long time to see whether that medicine's going to have any effect.
And 99.6% of all Alzheimer's trials fail.
We kept looking. We looked at each other and
kept saying, you all have something here, don't you?
we said, we have a drug.
So there's excitement and there's hope. Two words you never hear with Alzheimer's.
My 4-year-old's really into superheroes. And he's like, Daddy, you're a scientist. And I never realized this. Almost every superhero starts off as a scientist.
They are not in the spotlight, but they are heroic characters fighting against all odds.
Imagine the impact if we could change the course of Alzheimer's disease.
Just because we think the brain is more complex than the universe itself doesn't mean it is. It just doesn't feel that way yet.
This is the final frontier in medicine.
We have to find the cure. Failure is not an option.
Hello, hello, hello.
That was a compelling 3 minutes. James, to ask you, you've made a number of these films now, and these weren't even all of them. What was it like for you to make that first film when someone actually asked you to do this?
That actually started me down the road of making documentaries. I'd made a movie years ago called Walk the Line, and with Reese Witherspoon and Joaquin Phoenix. And I have a friend named Julian Raymond who's a great songwriter and was nominated actually for an Academy Award for the film that we did. For the song that he wrote, I'm Not Gonna Miss You. Anyway, Julian was producing Glenn Campbell at the time, and my son Johnny, who was a very good musician, they were interested in Warner Brothers in signing him, and Julian was the guy they sent over. But he said he used the time to say, hey, James, I'm producing Glenn Campbell. Would you like to do a movie about him? And I said, I don't think I want to do another biopic. And he said, well, no, that's not it. We just want you to film his shows. He's going to be doing 7 shows, and we'd love for you to film him and interview him and maybe, do something with that. I said, okay. And he said, but he's got Alzheimer's. And I went, oh, I don't think I want to do this. I was scared of the word. This was back in, I was literally scared of the word. And this went on for a few months, and finally he said, come on, man, just meet Glenn. And so he brought Glenn over to the house with his wife, Kim, and here comes Johnny across the living room, and he's got a guitar in his hand, and Glenn goes, hey, I play guitar, you want me to show you something? And Johnny says, sure, and he goes, do-do-do-do-do-do-do, and he just shreds it, absolutely shreds it. And he said, my Uncle Boo taught me that, and he said, if you do that, you're gonna be good. And then he walks into his bedroom, as all teenagers do, and then Kim says, Glenn, we're here to talk to you about your Alzheimer's. And he says, I don't got no Alzheimer's. I got part-timers. And then Glenn goes, when a man findeth a good woman, he points to Kim, he findeth a good thing. I found me a good thing. And here comes Johnny walking out of his bedroom across the living room. He says, hey, I play guitar. You want me to show you something? Well, I got to see the whole thing up close. I saw the Alzheimer's. I saw the love that he had for his wife. I saw his sense of humor. I saw his musicianship, and I fell in love with the guy. So that 7 shows that I was told to do turned out to 171. 3 years with a guy. It started with early onset, and by the end of it, we were in another place. And after that, people just started asking, because for me, storytelling is about emotion. It's about the emotional journey of the people. And I'm watching all you folks here today, and I'm listening to all the things that you've worked on. And it's very similar to what happened when we showed the film at Eli Lilly. I'm listening to all the scientists in this room, all the people that are really profoundly trying to make a difference and making a difference. But the story's not out there yet, okay? So the last film that you saw there about discovery, I went to Eli Lilly, and I went with Nancy, my wife, and who's, anyway, you saw her yesterday. She's like you, I feel that same way about her. Okay, anyway, so we went to Eli Lilly, and they wanted me to meet the research scientists. And I said, that'd be great. I thought it'd be really cool. I'd like to know how many drugs they've developed. He said, uh-huh. And so I met all these folks, and I said, one of them, Pat, who was retiring, and he'd created a drug called semaglutide. And they wanted me to talk to the folks about solanezumab, which was going to come out at that time, and they thought that it was going to work. And I said, so to the scientists, how many drugs have you guys successfully taken to market? None? What? None? He said, wait a minute, how long have you been working on this? He's 40 years, and you're retiring. I said, what? I said, that's a movie, guys. I mean, that's like me making a movie for 40 years and nobody ever seeing it. So when I'm listening to what you folks are saying here, I was thinking of You Gotta Have Heart, and I was singing the song in my head today, I don't know why, and then I started saying, you gotta have a brain. You gotta tell the world about brain health. This is a whole new thing. I mean, all the things that I've made movies about, addiction, ALS, Parkinson's, Alzheimer's. I know a little bit about depression, having suffered it most of my life. Pain. There's so many things that I think could be presented to the world in a way that would be compelling and emotional. It's like listening to Mark. I mean, it's emotional to listen to the guy. And you know what? Which is really great, what Glenn did and what you're doing is you're taking the shame out of the game. I used to say to Glenn, and I'd be sitting with his musician friends, and I'd say, so Glenn, how's the Alzheimer's? And they'd look at me like, what are you talking, why are you saying that word to him? What are you doing? I said, he knows he's got it. He wants to take the shame out of the game. And so congratulations, man, you're doing it. And I really think it's great.
James, can you tell us about the impact of your films regarding policymakers?
Well, we took, I think Nancy mentioned this yesterday, one of the things about getting policy changed is to put the folks in the film. So we went on the Glenn Campbell film, we had Nancy Pelosi, we had John Boehner, we had the senators on both sides. I don't believe in I don't believe in getting my political views and trying to sell an audience on that. I believe in telling the story the way it is. And everybody wanted to end Alzheimer's, but they had policies that they weren't supporting, and a lot of these folks are afraid to move forward until somebody else says, let's move forward. So they were all huge fans of Glenn, and we had a showing at the Library of Congress, and I think it was several $100 million that they were giving to Alzheimer's, and after it was $400 million, and then after that it went into the billions. Because the show went on CNN, and it was the highest rated show CNN had ever seen. And we had 5 or 6 million people that one night, and it aired. So it changed the trajectory. It literally did. And I know that Linda has done the same thing, and I hope the Greg Allman is coming out this summer. So I just finished it, and I mean, this is a 12-step call for anybody who's been in AA or suffers from drug addiction or early childhood trauma. I mean, the guy's father was murdered. His brother died when he was 21. He was in 15 rehabs. But he never gave up, and he was an incredible musician. But that trauma from so depression, so all of these things are so important, and I think the world is ready to identify with it. I mean, I hear on the radio when I'm driving to work, you know, you can have social media shrinks, you know, AI shrinks, you know, or you can have mental health. Selena Gomez, who we're working with, she's going to play Linda Ronstadt. She did a film about mental health and her own depression. So when you have young influencers and movies people and celebrities and sports, just admitting the truth, taking the shame out of the game. We're all human, for crying out loud, you know? And why do we have to hide? We don't.
Hear, hear. What about brain health? What do you do, James, for brain health?
I exercise. I try and eat right. What? Oh, I do Tai Chi, yes. I've done martial arts for years, but I took up Tai Chi recently. It's really fun. Yeah, I follow what's good for the heart's good for the brain. So I've been around these conversations so much, I try and do my best. But am I perfect? No.
And you don't have to be. That's it. Because a little plug for missing pieces of the puzzle is behavior change. How do you change people's behavior? So there's lots of information out there, but how do you get people to actually apply it? And we have these gaps, right, between what people know and what they do. And that would be a game changer if we could have, and I know people are trying, but this is where I think we need some funding too, to really enact and truly translate what we have learned to become enacted in everyday life. So thank you, James, for that. And any projects on the horizon? You said Greg Allman and...
Well, we have a few. I don't want to. I felt really weird.
What you can talk about, that is, yeah.
All the accolades. Anyway, we have films coming out in the summer. The Greg Allman did. I've been talking to folks about doing the longevity revolution, and which, to me, is not as vital as what everybody's talking about in here. So, you know, I've been working on a movie series about pain for years that I've wanted to do. I mean, there's just so many things that we need to pop people's minds open, and to make them aware of them, and to identify. What's really important is that people, when they watch a film, they identify themselves in the film. They identify with that character, and if that character, if somebody watching Greg Allman goes, you know what, that guy never gave up. I can do this. If somebody watching Mark's story looks at Glenn's story, or people who've taken the curtain down, and can go, wait a second, that's me. In fact, when we did Glenn Campbell, the other thing that we did to create awareness was we did impact campaigns, and we screened Glenn, and I think at 400 or 500 screenings, you know, and this is in communities. So people would come up after the screenings, not that I went to 400 of them, but I did go to a few, and would say to me, thank you, James. And I go, for what? And they said, well, I have Alzheimer's, and I feel seen. I feel like people might understand what I'm going through. So I think that's really important. I think that's even more important than the amount of people that are seeing it. Yeah. If one person's life can be changed, that's a big deal. That's a big deal.
Well, thank you for leaving us with that important message. And this is a good time to talk about impact and education and prevention. And so we're going to introduce Sandy Gleistein, and we have a video as well to show about her work.
Some of the things that we know about women's brain health are just shocking.
2/3 of people with Alzheimer's disease are women.
The lifetime risk of Alzheimer's is 1 in 5 for a woman, 1 in 10 for a man.
Pathology likely starts 2 decades before we see any symptoms.
We still do not know, is it an enzyme? Is it a molecular change? Is it a mutation? Is it the environment?
Maria Shriver and WHAM have moved the needle in the field of Alzheimer's and Alzheimer's prevention for women.
Now that they're part of WHAM at Cleveland Clinic, their work is only becoming more impactful.
They're raising the awareness, but they're also raising the money.
WHAM funding is the innovation platform from which significant advances can be made.
We received a pilot grant and a seed grant from WHAM. We're able to measure estrogen activity in the living human brain successfully for the first time.
The WHAM grant let us dig into which microbes are actually causing the disease, and this will help us someday design new microbiome-based therapies like probiotics.
My WHAM grant basically was used to test out the idea that sleep disturbances will make the manifestation of Alzheimer's disease faster in women versus men.
My WHAM grant allowed me to create these dementia-friendly online worship services.
My funding from WHAM consists of understanding how sleep and diet impact brain health in people who are on a controlled ketogenic diet.
Our work showed that when women receive hormone therapy, at the time of menopausal symptoms, there is a 40 to 60% reduction in risk.
What we showed for the first time is that simple lifestyle changes can often stop and even reverse the progression of early-stage Alzheimer's.
What we found is that the more severe the sleep apnea symptoms, the greater the tau burden.
We're also finding that just sleep complaints can really indicate how much pathology people have in their brain.
My project is looking at the connection between women's Alzheimer's risk and spatial navigation.
We are using the protein and metabolite in the blood or brain to diagnose Alzheimer's disease earlier.
The Women's Alzheimer's Movement Prevention and Research Center at Cleveland Clinic started out as a pilot program.
Without that funding, I wouldn't have been able to complete my study and wouldn't be talking to you right now.
We're all working towards the same bigger ultimate goal.
Each one of us is going to just add one drop into this bucket, and that entire bucket is going to lead to the cure.
45% of dementia cases may be preventable. When I first met Maria, no one believed any of that. Women's Alzheimer's movement changed everything.
It's been so inspiring to see how WHAM can really take it to the next level. Maria will post on her Instagram and millions of people get to hear about it.
Now I have people saying, oh yeah, I know about the gut microbes. I know gut microbes are important for brain health.
WHAM is important because they're speaking to women. When women are engaged and ignited, we're the ones that make the change happen.
Thank you. Sandy, tell us about WHAM and what you do and what WHAM does beyond this video.
Well, I'm going to say we exist. Our mission is to understand and help explain why 2 out of 3 brains that develop Alzheimer's are in women. So that is our mission. So everything we do drives towards that goal. What you saw was our WHAM research grant program. And, I'm in watching that, I'm actually quite proud that we had cast such a wide net to so many interesting researchers around the country. The amount of money that we actually are able to offer is not enormous, but as Harris was saying to me earlier today, seed grants, properly done can change the world. And, I wake up every day hoping that the money that we raise for women-based Alzheimer's research will help change the world and answer the question about why women are so, at such high risk. The other piece we do, and I share this with James, is a desire to tell the story We have spent many years now. Maria Shriver started this organization. This is a person's story that ignited the movement. And I always come back to that idea that one person can make a difference. And in my case, and Maria has made a tremendous difference in my life. I've worked with her for 40 years now. So I'm dedicated to her passion, her vision, and her energy. But it was her father who actually had Alzheimer's, and he was diagnosed in a very different era back in 2003. I, even though so close to this family, had no idea, because it was still a day of shame and darkness and fear around this disease. And I applaud where we've ended up today, that Mark and I are pretty good pals now and able to, be part of a world that is talking about Alzheimer's, and that people are using their voices literally in your films to tell their story. Because every time someone does use their voice, it helps chip away at the stigma of this disease. And that has been a radical change, and Maria has helped be part of that movement. And in 2010, she came out with a report that she did with the Alzheimer's Association, and it was that report which for the first time really, especially to a lay public, talked about the fact that women were at higher risk. Because as you know, until then, it was really thought it was because women lived so much longer, and that was the only reason. And we know age is still the #1 risk factor, but being a woman is the #2 risk factor. So
what about being a woman and being a caregiver?
Well, being a caregiver, I mean, Pam told you, from a personal experience, but we do know that being, it's still, though the gender gap is closing somewhat in this country, caregiving still is very much women's work, especially the caregiving for people at home with dementia. And we know that there are health risks. We heard it earlier today in the slide that Kana showed about healthcare costs are up for caregivers. Well, that's because there's a lot of stress. Not everybody has their finances in order. Not everybody has the ability to bring in care to help bathe and lift people. I mean, there's physical strain that can happen. There's financial strain, emotional strain, grieving. I mean, all of this leads to, it's an assault on people's emotional, the overload. It's real. People who are in a position to, as the Rogans admit, and their work is extraordinary because they work so hard, Seth and his wife, Lauren, and we work with them a lot. It's about bringing caregiving to families that can't afford it. And, it's so important.
So I want to thank you all. I think this would be a great time to open up for some questions and further conversation. So we have someone in the back of the room. We don't have mics. Oh, okay.
Oh, you can have it.
Sorry about that.
And we're going to have time for maybe 1 or 2 questions because we're running about 15 minutes behind. So sorry for that. Who had the question?
Good morning. My name is Cindy Lopez Paz. I'm with the Los Angeles County Aging and Disabilities Department. Thank you so much for this panel. The work that I do centers around Alzheimer's, dementia, autism, cognitive impairments, and the wandering behavior of these individuals and how LA County can help in keeping those individuals safe. One of the things that I wanted to kind of allude and just one of the themes that I think that really resonates is the theme of resilience, reframing the diagnosis of Alzheimer's or dementia. There's such a negative connotation with that. In a lot of the families at the clinical setting, when they get that diagnosis, they just shut down. So there needs to be a reframing that occurs. It's like, I have Alzheimer's, and how can I reframe what my life or what my behavior is going to look like in the future? I think that's really important for families to know that there are still things that you can do in your day-to-day life. They just might look a little different, and we have to pay attention to that. And also, I want to highlight and I'm glad that Sandy mentioned the concept of not everybody has the same means financially to be able to afford care, and that is a huge strain on families. Also, culture plays a role. Culturally, families see Alzheimer's differently, and I think that in any approach that is taken forward, we need to look at culture on how we deliver this information and how we, even with the healthy brain, how do we communicate that in a way that is receptive to people from different backgrounds?
Can I just, while we're waiting for this question, I just need to say this. All of this begins with people using their voice. And I cannot tell you how important it is that Mark and Pam are sitting here and having this conversation openly with you. It is always an act of bravery to be somebody who raises their hand and says, let me tell you my story. And you know that better than anyone, James. But I really have to applaud James and Pam for being willing to speak up.
Thank you for the panel, really deeply heartfelt and stirring, and it's something that I'll be reflecting on for the next couple of days for sure. So thank you all for your contributions. And question, how can we leverage platforms like, I'm thinking, the G20, the club of all the biggest countries in the world, from the global north, global south, to inspire heads of state and business leaders of all the Fortune 500, the world's biggest companies, around change? You know, you're doing this already. How can we leverage these platforms with touch points and storytelling and emotions to try to really transform, you know, systems of science, but then also systems of community? What advice would you have for us to keep in mind, and how do we collaborate on these sorts of big multilateral platforms to leverage them to change things?
I would say that the first thing you do is you don't make Alzheimer's Americanocentric. You don't make disease, depression, brain health Americanocentric. You make it globally centric. And so you look at the problems, you know, just on and you'd have to probably do it a little episodically. I haven't thought exactly about it, but you have financial problems, you have medical problems, you have health, insurance problems, but it's the personal stories. So I would say go to those countries and find people that really resonate, that the audience, when we're watching it, we immediately identify somehow with that person. You know, it doesn't have to be a celebrity. And the same thing with their leadership. So you have people that they respect and that we respect here in this country, back and forth, and you have a conversation and you would maybe put a bunch of people in the same room from different countries, all talking about the same problem. I don't know that you'd want to spend a whole film doing it, but it certainly would be a dynamic scene. And then, or to cut away from, you know, there's a whole bunch of, but it's just, the point is, don't make it all about the USA. I know, we won't make, well, let's make the world great again. Okay.
Well said. Thank you. The stories are very moving and very important. And I wanted to make more of a statement, and that is, there are neuroenergetic technologies, evidence and science-based, that you will learn more about that help to modulate the neurometabolic processes of the brain. There is hope in this area. We are seeing stories in this area. And I just wanted to share with people, there was a comment I think that maybe Stacy made that we can prevent this disease if we have the will to do so. We've seen it. So I just wanted to share that, wanted to thank you for your stories, and be attuned to maybe a different modality for helping to solve these neurometabolic disorders.
Yes, Gina Poe, Brain Research Institute. I just also want to commend you and say thank you for the really important work that you're both doing, all of you are doing, and say that we want to partner with you. We want to be helpful in any way. We can bring the world to you and bring you to the world, and we can bring the scientists who are working on all of these things. I love the fact that the sleep was mentioned so many times in that film. Yes, and we have compelling stories like Rosa Parks, which you're probably going to tell us about next. So everybody in this room, this conference. We can spend some time at lunch and really figure out how to do this. I think it's super important. So thank you.
Thank you all so much for sharing your story. Storytelling is so important. And I share something with you that Mrs. Parks, a quote that I love dearly, and one of the things she told when she was receiving the Presidential Medal of Honor from President Clinton. The young journalist said, Mrs. Parks, you're 42 years old. Why didn't you just give up your seat and make your life easier? And Mrs. Parks, and I offer this to you all in the room as well for being here. She said, you should never be fearful of what you're doing when you know it's right. So I just thank you for sharing your story. What you're doing is right. We have to fight this fight. It is a good fight. It is a noble fight. It's a just fight. So I thank everybody in the audience, but I thank you for sharing your story, because stigma and challenges, the boogeyman in the room, we don't have it. So God bless you. Go believe and be encouraged. And again, thank you so much. I really appreciate it. I know everybody in the room appreciates you for being vulnerable, but we got to address and tackle it head on. So God bless you. Continue to tell the stories, everybody. We can do this. We have to do it. And like Nelson Mandela said, it always seems difficult or impossible until it's done. God bless you all. Thank you.
We have one more question, but I want to say something to follow up your comments, sir. Thank you so much for talking about what's right, because what's right is to help the average daily caregiver. What is right is we need the money to help them. We need drugs that people can afford. We need caregiving that people can access. And yes, we need the message to get out in different languages and different cultural appropriate ways. So thank you for that message.
Thank you very much. My question, I guess, is to more Mark and Pam, and maybe anyone else who has an interesting point. My background is actually in auditing at financial institutions and looking more at patterns and systems. And what stands out to me in case with Mark and Pam is your agency, internalizing agency, something that you're in control, not the disease is in control of you. And also, I think it was mentioned yesterday about the chronic pain, disentangling with the pain and treating it as something separate rather than like personalizing with it or entangling. Do you think how much agency has played in your experience? And maybe overall, do you think that could be something important for patients with Alzheimer's and other brain diseases?
I do think agency is very important, and resilience. As I am a nurse, I'm very task and skill oriented. So when Mark was diagnosed, I knew right away if I was going to take care of him well, that I was going to have to get a plan together, because I knew what could be coming. And so I made a list, and I went through the list. And so for me, I think therapy has been the biggest help in my life, absolutely. I didn't want to be a burden to my daughter by sharing all my inner fears and being able to talk those fears out. And it's a process. It's not something that happens overnight. And it's something that you have to work at developing friends. I have people come over to the house and have dinner with us and get to meet Mark and realize Mark is, you know, he's got Alzheimer's, but, you know, he's fantastic. Come and look at Mark's photos, you know. And Mark is a shining light for getting rid of the stigma of this disease. So yes, agency. And not everyone has that skill. I think I'm just lucky.
for me, to answer that correctly, being Jewish, we started therapy when I was 4 years old.
You knew it was coming.
You know it's coming.
You know, Ellen.
I mean, you know, laying on the couch when you're 4 doesn't say much. Especially when they take it you're 18 or 19. You really don't know what it's about, you know, and why you're there to begin with. You know, you try to put that behind you because you didn't really know what they were talking about to begin with. And, you know, Pam is Catholic, I'm Jewish, and it's a great mix, you know, because I say whatever Pam says, I do. And, you know, because you can't fight with the Irish, you know. I mean, there's no way, you know, at this age of 75, there's nothing you can do, especially with the agencies, if that's what you're talking about. Yeah, I don't know really how to answer that, except when you start therapy and you're Jewish at 4 or 5 years old, and you take that all the way to you're 19, it doesn't work to begin with. So, you know, I mean, especially not marrying a Jewish girl.
Okay, let's not go there. I think we're going to take the mic away now.
On that important note, thank you so much, everyone. This is incredibly valuable. We're running, as you can tell if you've looked at the schedule, we're running behind, so we're going to take a very short but essential coffee and bio break. Come back in 10 minutes, and we'll just shorten the lunch hour.
Yay, Linda.
so much. So it's Raj, and then I'm not sure where I am. What did you say? I think there's definitely city-based people. I don't know if there's. They were invited. But that the policymaker types are the people that are influencing, right? Yeah. Yeah. So the slides are also. Okay. Oh yeah, just a little bit, right? All right, so I think we're gonna just try to get back from the coffee break. So much awesome networking happening. Where's
Oh, okay. I'm going to use all three mics.
Are you? Yeah. Wow. Little reverb going on. Oh, I see him. Okay, he's here. You intro. What? No one? Okay, it's fine. So am I kicking it up then, or do you want to? Okay, fine. All right, so we're going to get started again. Thank you so much for staying with us on this beautiful Saturday afternoon or morning. So without further ado, we're going to have kick off the Brain Health Science Panel 3, which is brain health and neurologic diseases. And you'll see sort of an interesting theme being developed as we go through our speakers, but I wanted to introduce very briefly our first speaker, who is a very good friend and colleague, of mine who was my residency program director and has been a mentor to me for longer than I care to admit right now. And he is a professor of neurology emeritus. He just won emeritus here at UCLA, and he has founded the and is the director of the UCLA Goldberg migraine program, and is just a world expert in so many things, migraine especially, and has been really trying to increase disease awareness of this state of something that I think is so common and affects many of us, and we don't even know it. So welcome, Andy.
Yeah, thanks, Indu. And thanks for inviting me to be here at this really spectacular conference. I'd like to start with a dad joke. This is an actual dad joke that was told to me by my father, and I have repeated it to my own children. And so the joke is, actually Indu's rolling her eyes already, I can tell. How do you know if there's an elephant in your bedroom at night? He has a little red E on his jammies. So I tell that joke because I've often said that migraine is an elephant in the room of brain health. It's extraordinarily common. I'll bring up my first slide here and have these little metrics that it affects more than 1 billion people worldwide. 1 in 5 women, actually probably closer to 1 in 4, 1 in 16 men, and importantly 1 in 11 children, 1 in 4 homes are affected by this. And I have on the right here this global burden of disease study, which has been this study that's been done by the World Health Organization over decades now. And very consistently, migraine lands at number 2 on the causes of time spent disabled of all disorders on the planet. Also importantly, there's a remarkable association with other disabling disorders: major depression, anxiety disorders, neck pain, stroke, opioid use, epilepsy. So migraine is really at the nexus of a variety of disabling brain diseases worldwide. So it's important to think about not just necessarily as itself a cause of problems with brain health, but even indirectly as a result of its association with these other conditions. It's also incredibly important to realize that a migraine attack is not simply headache, but rather this extraordinary constellation of neurological symptoms that happen not just during the headache, but well before the occurrence of the headache, and then after the headache as well, the so-called postdrome. And now that we have functional imaging studies that can visualize the brain during a migraine attack, you can see these spectacular changes in different brain regions that are correlated with different time or different symptoms of a migraine attack. And so thinking about migraine as really a disease of spontaneous changes in brain activity, or sometimes we'll describe it as an aberrant brain state, is something that really changes your ideas about this. And so for most people, fortunately, it's an episodic disorder. It may occur, say, 1 day a month or 2 days a month. But for many, too many, it is a frequent and chronic disorder. And when it becomes frequent and chronic, then it's when the interictal period becomes important, where it's not just the attacks themselves, but there's this blurring of the attacks and then the times in between what we define as attacks, and people then develop more persistent mood changes, cognitive changes, changes in sensory function. So really key to, again, think about whatever disease you're thinking about, whether it's Alzheimer's or brain trauma or mood disorders, that migraine could actually be playing a role in these other disorders that you're thinking about. Migraine also has profound effects on sleep, and really is something that indirectly, again, through its effects on sleep, could be something that could be very important. So then there's the question of what does a chronic migraine do to you in terms of other sorts of states of mental well-being. Are you anxious about when the next attack is going to occur? How does it affect your function at work, at home? How does it affect your capacity to achieve your potential? And these are things that I think we really need to be thinking more about, particularly because we now actually have some therapeutic approaches that are helpful. And so I'll just end by saying that migraine is really an important, vastly underappreciated public health issue, particularly for women, but also for children and men. It plays a significant role in brain health, not just as a pain disorder, but also as a disorder that causes a wide variety of other symptoms. And again, the good news is that we've had some spectacular recent advances in the specific therapy of migraine, not simply painkillers, but therapies that are targeting the fundamental neurochemical mechanisms of migraine. And so this is where awareness becomes increasingly important, because if we actually have the capacity to intervene and help people with migraine to a better extent than we've ever had before, then it becomes very important that we identify patients who have migraine and get them the appropriate treatment. So I'll stop there and say thanks.
That was amazing. And I think as we're going through, I think it's important to realize that when we talk about neurology and neurologic disorders, a lot of our emphasis sometimes is talking around proteins that are positing, which the disease that I will speak about, Parkinson's, affects, as well as Alzheimer's. But the reason that I had wanted Professor Charles to be here is because, this is the sort of changes in the brain are so interesting from a disease state like migraine. We're going to hear from an epileptologist. So epilepsy is another disorder that affects the brain. And I think just sort of expanding our thoughts on how the brain is affected by these different disorders is really important. So next we have Raj Mazumdar, who is my resident. So it's a little bit of a club up here that you'll see. And Jason Hinman was also one of our amazing residents as well some years ago. And so proud of just where they've landed. So Raj is, as I mentioned, an epileptologist. He's an assistant professor of neurology here at UCLA. He's really doing some very cool work on what causes epilepsy and really some global health work in Africa. And so such an interesting sort of, again, way that these stigmatizing disorders like migraine, like epilepsy, can affect our populations globally and really change quality of life so fundamentally. Thank you, Raj.
Thank you very much. Thanks to the organizer for inviting me and giving me this opportunity to share my thoughts. I will sort of take you on a journey, the story of my how I ended up here today. As a child, I grew up in India, in Calcutta, where my mom is a special educator, one of the very few in the 90s in India, working with children with disability. Being a single mother, oftentimes after school or during vacations, I would basically spend a lot of time in her school. This is where, inside the school, I'm playing with the children over there who are using wheelchairs. There are wheelchair ramps. The playground looked very different than what was in my own school where I was going. But what I remember, what my memory strikes, what I from that time was not what was going inside the school, but what happened outside. Often, I would see a kid suddenly, some of them became my friends, not come to the school anymore. And so when I asked my mom, like, what was going on, it was oftentimes the family felt ashamed what the neighbors would think to take them to a school with children with disability. So they were basically kept hidden. Many of these children were kept hidden, and that sort of stayed with me, that experience, and has sort of informed my journey and the way I sort of think about brain. The lesson that I learned, I realized, now I reflect back upon it, that the brain is part of its environment. These children were not, not showing up to school because of their ability or, or anything else about themselves, but how society reacted or responded to them. And that has sort of stayed with me as I made my decisions in my life and career. Epilepsy, again, is a very common disorder. And biologically, it's a very simple thing, and to explain. It's basically a abnormal electrical brain activity that disrupts the normal signaling processing, the rhythm of the brain. And that basically manifests into a sudden loss of awareness or, recurrent form of seizure, from the Greek word to be seized. So anytime there is a change in behavior, because of this abnormal disruptions, there will be episodic change in, the person's, state at that time. While that is the simplistic thing, and we have good, measures for some of these things, the context in which this condition is stigmatized and where people live with it is what I think is a big gap that we have to bridge. When we zoom out, and I'm showing some numbers over here, you look at it's 50 million people in this world suffer from epilepsy, and oftentimes suffering in the stigma, in the darkness, behind the shadows. And many of them, this is where again the gap in this, in sort of the global gap that exists, is 80% of people living with it has, in low and middle income settings and countries where you do not have access to either diagnostics or treatment. So, some places the gap being 90% of people living for, decades if they make it without having a diagnosis. As a neurologist, we are, our training is all about thinking about, what is going on in the brain. That's what we are basically trained at. And with epilepsy, we have, several measures that we use. And again, because this disorder is an episodic disorder that leads to a change in behavior, and there are several domains that we basically look at. So first, we have a 100-year-old machine called EEG, electroencephalogram. It's similar to like what an EKG would be, but for the brain, that measures brain waves. And it's a very specific marker that we have. But it's a multimodal because it affects people's cognition, affects people, mood, depression, anxiety, very commonly associated. Oftentimes, I'm working closely with our neuropsychology colleagues, who are many of them in the room, in terms of understanding the cognitive aspect of things. And then there's a functional aspect where, because of this episodic disorder, people will, or change in cognition, people will lose their job and there will be extreme poor quality of life. And when I explain to my patients, these different domains that we examine are almost like looking at, the story of the, elephant and the 5 blind men. Each one of us, basically, somebody holding the trunk of the elephant and thinks they're a big snake. Somebody, holding the tail of the elephant thinks like it's a rope, the legs like a trunk. But all of them put together is what likely will give us a biomarker. Unlike diabetes, where we have, a single blood test that tells you, or a LDL, or, that tells you about cholesterol. Unfortunately, in epilepsy, we do not have a biomarker yet. But I think, with the advent of AI, most likely we will be coming up with a multimodal, emergent, where we can, study these different domains all at once together and come up with a comprehensive marker. That's my hope. Then the next thing, I want to take you, back to my story. The experience that I had in, as a 8, 9 years old kid. Later, about 2 decades later, when I was in medical school, I, because of my mentor working for the WHO at that time, I ended up in northern Uganda, and he was responding to a call that there was, northern Uganda where you have 20 years of civil war going on, completely decimated the northern part of the country. And in that, with the lack of infrastructure, where you have, the lack of health care, even the war had stopped a couple of years back before we went in, complete decimation of, road infrastructure, healthcare infrastructure, governance issues. And in that context, there was this, increase in a syndrome, mysterious disease that came out called nodding syndrome. And this was 2014 when I started studying this as a medical student. And what this condition is, basically, it's a child is born healthy, but around 6 or 7 of age, they start having this head drop spells. That's why the name nodding comes in, and cognitive decline and uncontrolled seizures. And when later on, a few years ago, when we looked at the pathology, the pathology of the brain is exactly like Alzheimer's, but in children. So it's neurodegenerative disease that's affecting teenagers. People, the kids who survive will develop Parkinsonism and whatnot. So when you look at this story, you're like, oh, is this unique to this place? What we found out was not. Like, there were many reports in the 1960s and 80s from across the sub-Saharan belt that were describing similar symptoms. And most recently, we basically did a study where we looked at, from 3 different countries, Tanzania, Southern Sudan, and South Sudan, and Uganda, and we found that actually these diseases that were being described separately were all the same. So this basically brings us that, in terms of studying the brain disease as intrinsic factors of the brain, we also need to understand the extrinsic or the environmental exposure that the brain is exposed to, as we are trying to think about a comprehensive brain index here. And also trying to reach out to communities that are are either hidden in plain sight or maybe far off somewhere. And somebody brought up, the call for global health, where, a disease that we think is, novel and, affects those people, it's not truly that. It's affecting as we have to address that as a human family. So thank you.
Thank you, Raj. That was excellent. Hello, everyone. Good morning. My name is Jason Hinman. I'm a director of the Mary S. Easton Center for Alzheimer's Disease Research and Care here at UCLA, and I'm so delighted to co-moderate this session with Dr. Subramanian. I'm going to take over with some of the introductions, including for Dr. Subramanian, who is a mentor and close friend, and I think colleague now for a variety of, quite a number of years. Everyone's seen Indu over the last few days, so I will make this brief, but only to say that she is an outstanding neurologist who considers and focuses not only on her disease specialty, but on the patient as a whole. And in doing that role, she serves as clinical professor of neurology here at UCLA and is a specialist in movement disorders. Thank you, Indu.
Thank you so much. So it's just an honor and a privilege to present on the brain neurology side of the story of brain health. And Sahib and I have been working closely with Dr. Luretsky to produce this program, but just excited to have so many friends and esteemed colleagues on the panel here. So I'm going to tell you a little bit about my journey, and as Raj did, I grew up in Canada. My mom's a family doctor who knew everything about many things, and I decided to sub-specialize to be the opposite of her in a disease of Parkinson's. I always loved the brain. The brain was always cool, and so I developed this love for Parkinson's, came out here, met Andy, who interviewed me so many years ago and was a resident and fellow here. I've run the VA Center of Excellence in Parkinson's for the last 10 years, and I want to teach you a little bit about this disease state. So these are some images. So the images here of these largely Caucasian men are the images in which we teach medical students for so many decades about Parkinson's disease, which is, by the way, the fastest growing neurologic disease in the country. It doubled in the last 40 years, and it was slated to double in the next 20 years, but we already reached that milestone in the last 6 years. So it is a very, very increasing explosion of this disease, and we classically taught our students about this motor disorder, which included things like stiffness, slowness, and tremor, that affected these sorts of images, right? So if you think about, close your eyes and think about this disease, you will largely, and if you Google this disease, ChatGPT this disease, these are the images that are going to come up. And so if you look like me and you start to have some of these symptoms, you don't even think that you could get this. And there's whole populations, African-American populations, that say Black people don't get Parkinson's, these people don't get Parkinson's, women don't get Parkinson's because of these images. So first and foremost, we have to change the images in a public health campaign of who gets Parkinson's, because there are many people who are not getting diagnosed and hence not being treated. There are a large number, as Raj had pointed out, of people in Africa who have these diseases in increasing numbers. And in Africa today, in 2026, we are still not able to give the most basic medicine that has been out for 70 years. And I just wrote a paper about the anniversary of this medicine, still not being able to be even prescribed to large numbers of patients in sub-Saharan Africa because of a number of issues with bringing the drug in and being able to prescribe it. So we are not able to even give a chemical that replaces dopamine in the brains of so many patients around the world. So a lot of what I've done, I have a passion in yoga and mindfulness. I'm very outside the box. We just, as I mentioned to some of you and shared already the paper with you, came out with a paper on spirituality and neurologic disorders. I love music in my own life, and so I'm very outside the box, happy to have these conversations, but a lot of what I do and have been driven to do is really change the advocacy paradigm and really bring attention to who is not being served. And so we wrote a paper with a number of women that are amazing advocates around the world who are themselves cheerleading the space to change the images. So this paper in 2022, it took until 2022 to write a gaps and controversies paper in our main journal to really think about women and represent why women are not being served. And it is fundamentally an amazingly problematic issue. So women, when they get this diagnosis, they are very stigmatized. They don't feel like they belong with those images of men. They then hide their disease, often because they are not able to be caregivers to all the people in their lives, from their husbands to their mother-in-laws, their children. If we're doctors, they don't come forward because they're too busy taking care of patients. So many people, and they feel very self-shame and self-blame when they cannot be caregivers to people and provide the domestic sort of care for their families. And so then they have a lot of negative self-image and they become very stigmatized. So we have tried to shine a light on this to help women connect with each other through ways, through social media, through virtual support groups. And so women are now coming forward to talk about their needs in the psychosocial realm. We also, for the first time, brought this image of the hormonal cycle. So we have women that are as young as in their 20s with this disease who are trying to get pregnant. And we've not had a registry for Parkinson's patients. So the women themselves living with Parkinson's actually created a registry to do better. We also have a lot of problems with understanding even how the menstrual cycle affects women, how the perimenopausal time, the menopausal time frame, and postmenopausal hormonal changes all affect their symptoms. And so this is one of the first images that we've produced out there. Weirdly, I didn't even know that we were going to have this elephant theme, but we had the elephant theme here with my friends earlier, and so we have this image that we have just put together of the elephant in the room. The elephant in the room was really about Parkinson's, but I think we can think about so many disease states, right, and think about even the psychiatry aspects that also are so stigmatized. And so this woman in this image, and this image was produced by a woman herself living with Parkinson's in Canada, who's a beautiful artist. And so these images, again, bring home, right, the story. So this woman is already conflicted. She's Asian, South Asian, you know, thinking about herself in the workforce, thinking about herself at home, all the sorts of push-pull of her life. with these children, trying to develop, trying to take care of her self-care with, that barbell and cook and clean and everything and still be a working woman, right? So this is so much of the push-pull and all the things that affect her in her daily life from, just all the things that we teach her to do about her own self-care, but then, the secrecy, this elephant in the room of not even telling people that she has this, right, and is living with this disease, sort of feeling alone because the images, again, are of that first slide. So I think, we can think about this image in so many different ways and bring that to all the diseases that we've talked about. I think you saw this slide here on the right. This was, again, produced by the daughter of a Parkinson's patient living in Italy. And so this is sort of that wellness sort of ideas of what can we do, putting the patient and their caregiver in the center, all the lifestyle choices that we can teach people to live better from the day of diagnosis. We give this diagnosis, you have Parkinson's, to so many people regularly, and patients tell us that they heard those 3 words, their life changed, and then that they were not given the tools or the support they needed to live well from that moment, often felt very isolated, really sort of hit rock bottom. And then it was years later, after something changed, that they came forward and then are now some of the most strong advocates that I really admire. So we need to be thinking about how these diagnoses land, give people the tools that they need from diagnosis. So my last slide here is, many of people know that I've become kind of obsessed with social connection and loneliness. This is that's why I've been urging you all to connect here and network. But we have data in Parkinson's disease that says that actually loneliness puts you at a higher risk for getting Parkinson's and Alzheimer's in the first place. And this is a modifiable risk factor, a big modifiable risk factor. And if you have Parkinson's, our data in these blue bars here, you may not be able to appreciate what it says, but it's as bad for you to be lonely as the beneficial effects of exercising 7 days a week for 30 minutes a day is good for you. We had this data and it came out right before the pandemic, so we really had this fear that we had this sort of synergy of loneliness and people being derailed from their wellness, their exercise, and exercising groups is actually very beneficial. So we had all these people and our patients sort of struggling with how to sort of take care of themselves. And so really, I think a pro tip for all of us in the room is that in order to not be lonely, you need to actually have social connection in 3 spheres. So the first sphere is that intimate sphere of somebody living in your home. We saw these beautiful couples up here who were talking about their loved one who supported them through these things. So you have to have that intimate sphere, but you also have to have connection in 2 other spheres. So one is relational. So we each actually in the room need to have a friend circle outside of our intimate sphere that we can talk to, a tribe that you can go maybe and have a glass of wine and talk about your issues and people cheerleading you, and then a collective sphere. So we all each need to actually have meaning and connection to a group in maybe our community and our society that brings us joy and meaning. So I think we hopefully can think about brain health. We can screen loneliness very easily, actually. There's a 3-question UCLA loneliness scale that we came up with, and a lot of this work has actually been done right here. Go Bruins. I think we can think about brain health as an important measure that involves things like social connection and loneliness, which hopefully you can start screening, start to be proactive, and then once we identify people, especially in the neurodegenerative or at risk for neurodegeneration, we can urge them as part of the medicine to socially connect. Thank you so much.
Great, thank you. It's now my privilege to introduce a good friend and colleague who's joined us all the way from Boston, my friend Dr. Lee Goldstein, who is an associate professor of too many departments to count. I'll rattle them off briefly: psychiatry, neurology, ophthalmology, and pathology, laboratory, and medicine. He's also the director of the Molecular Aging and Development Laboratory in the Center for Biometals and Metallomics at BU, and is the co-director of the Biomarker Core for the BU Alzheimer's Disease Center. And I think, Lee, you now have an obligation to include some kind of animal analogy in your talk, so proceed.
Has to be an elephant.
Exactly. Let's see here. Great. Okay, thank you for the invite, and good to see everybody here. It's lovely to be on the West Coast where it's in the mid-90s. We still have snow on the ground, so it's a bit of a problem. Following Indu, that was lovely talks throughout yesterday and today, but I'm going to talk a little bit about traumatic brain injury, neurotrauma. I really want to talk about this as a spectrum. And as an introduction, I think you had a lovely intro to this, that societal health really is the basis for brain health. And we can't, there's really no way to extricate the one from the other. And it's bidirectional. And I think it's really important for us to understand that there's no way to talk about a brain economy independent of how we take care of each other collectively. So with regard to traumatic brain injury, actually it touches on essentially all the other disorders that you've heard about here, including migraine and epilepsy, Parkinson's disease, neurodegenerative disease. I'll touch on that very briefly here. It's a huge problem globally. And you can see here, in fact, it sort of dwarfs. If you look at neurotrauma as a spectrum across an acute to chronic time frame, we tend to think of traumatic brain injury, for example, as an acute phenomenon, but it has a long tail. And that tail actually extends throughout life and throughout the community and throughout society. So this is a hugely impactful disease, if you will. It's really not a disease, it's a spectrum of diseases and disorders and associated sequelae. And you can see here, it really dwarfs I'm an Alzheimer's disease researcher primarily, and it dwarfs Alzheimer's disease, stroke, Parkinson's disease, and multiple sclerosis, although it touches on all of those. This affects every year. You can see, interestingly, the incidence is really high, as well as the prevalence. So this is every year we're adding 50, 60 million people across the globe with neurotrauma. So it's a huge problem. The disability and long-term disability associated with this really is of global dimensions. In fact, this is costing many hundreds of billions of dollars in disability across the world. And in fact, TBI and its associated sequelae in lower and middle income countries is affecting the population and the economy at the level of 1% to 2% of the GDP for many countries across the world. So the patterns actually differ in the causes of traumatic brain injury by GDP. So if you look here, high-income countries related to falls, and then road and vehicular accidents, others in violence. And then in low and middle income countries, you can see road accidents, motor vehicle accidents really overwhelm the other causes, but also violence and falls. So you can see that the patterns are different, the causes are different, but they're leading to not only acute injury and death, but also long-term morbidity. And I want to call out here in the United States the long-term consequences of any war. Most of the costs, both human and economic, of course, extend in the future well beyond the military fighting. And we see this now from the operations in Iraq and Afghanistan. We have about 500,000, this is a conservative estimate, of blast-exposed military personnel who are now suffering tremendously after blast exposures. We did some work on this area. I'll touch on that in a minute. So there are also vulnerable populations that include the elderly that get little attention with traumatic brain injury. These are groups that are at increased susceptibility. Children, adolescents, women. Domestic violence is a huge underreported problem. Violence and crime, sports and recreation, and then also the military, which also gets short shrift, particularly on the back end of our adventures, or excursions as they're currently called, apparently. So the way I like to think about this is an integrated, sort of an integrated model about how the effects of traumatic brain injury widen like ripples in water after throwing a rock in a pond over time. So there's an acute injury, and often there are repetitive injuries. That's a whole nother issue I'll just touch upon. But there are a variety of different domains in which that are impacted that lead to the chronic outcomes, and those chronic outcomes will lead long-term to sequelae. This looks like an older slide that didn't get, but anyway, the point is that there are biological, social, psychological, and ecological components that all need to be addressed in order to affect a societal outcome that's helpful for the patient and reduces the burden at the level of the family and the family structure, the community, and globally. But the long-term outcomes are really severe, and they set you up for a lot of long-term risk, including increased incidence of seizure disorders, of substance abuse and poisoning, even infections and pneumonia. And in fact, in moderate to severe TBI, globally, there's a 9-year reduction in life expectancy as a result of a TBI that could have been sustained decades earlier. And where we've done a tremendous amount of work at Boston University is in the long-term sequelae of repetitive head injuries, in particular in sports, but also of traumatic brain injury more generally. And we're looking at a variety of neurodegenerative diseases that are associated with neurotrauma. And these include Alzheimer's disease and ALS and Parkinson's disease, post-traumatic seizure, migraine, a whole bunch of things. And our sort of specialty, niche specialty is in chronic traumatic encephalopathy, or CTE, which is a late neurodegenerative disease that is directly associated with repetitive head injuries, not with concussions, by the way, not with concussions. It's repetitive head injuries. And we see this as a progressive neurodegenerative disorder that we've seen in NFL, the NFL brains from former players in the NFL, but also in blast-exposed veterans. And I want to mention that we have seen this type of neurodegenerative disease pathology in adolescence. So the early consequences of these TBIs are occurring many decades beforehand. And when you see a neurodegenerative disease in a 14 or 16-year-old, it gets your attention. It gets your attention. So you know that the damage had been occurring and the disability had been occurring many years prior to that. So we have many ways now of looking at the disorder, both prodromally and even before any signs and symptoms occur. And we're hoping this will help us for other neurodegenerative diseases. So where do we go from here, thinking about this hugely impactful collection of neurotrauma-related problems that's really impacting, has a large impact globally. So it really depends on the different situations in the different countries and the GDP and what's going on locally. And so in the low and middle income countries, we have a real problem about access just to primary treatment. So it's hard to believe, but we don't have enough specialty clinics or access to just acute care. So that's a huge problem, just getting acute care and quality care at that. And then in the higher income countries, it's the linkage of acute to chronic care across that whole lifespan look at traumatic brain injury. And then across globally, we need new biomarkers. We need new ways to think about who's at risk after these injuries, how is this person different from that person, a precision medicine approach that we don't really have at the moment. And then finally, we need to think about the susceptibility risk associated with groups I've mentioned before, older people with comorbidities, women, children, and those people with repetitive head injuries. So I won't get into this in any detail, but amongst the many things that we need, and you heard this from Raj with epilepsy, and this is really throughout the world of brain health, is having ways to differentiate what's happening in the brain. And by that I mean we need to be doing something better than saying you've had a mild, moderate, or severe TBI, which is just absolutely ridiculous. Or having a concussion, and that means anything any clinician wants it to have. I know Chris Giza will be talking about this later. So the categories that we use now are primitive, pre-primitive, and we need better ways to do this. I mean, we're sophisticated clinicians and scientists and healthcare consumers, and we need better ways to understand that we can't put all people in the same bucket. So we need new ways to both functionally detect damage to the brain and the systems that are involved, and we need blood biomarkers and other better classification systems. So in summary, this disease really touches on everything that happens with the brain. We need better access, we need better clinical care, we need better biomarkers, diagnostics, and different ways of classifying brain neurotrauma and sequelae. I'll stop there. Thank you.
Wait, where was the elephant?
Oh, sorry. Yeah. Elephant. Yeah.
Well, I think a lot of these things are an elephant in the room, right? So I think stigma is huge in all of this. So, all right, well, it's with great pleasure that I introduce my co-moderator of this panel, Professor Jason Hinman. He is a friend and colleague and mentee, and just so proud of all the things that he's doing. He's professor in residence here in the Department of Neurology and director of the Easton Center for Alzheimer's Research and Care at UCLA. He is also an amazing neurologist and a big proponent of taking good care of veterans with stroke and Alzheimer's and all of these things. So has been just a pleasure to work with him. And so, yeah, I'm excited to hear his talk.
Thank you, Indu. And I stand before you now as the barrier to lunch. So you, perhaps like me, I'm hungry like a wolf. There's my animal analogy. I'm done. I wanted to thank the organizing committee, particularly Dr. Levetsky. This is a critical event with impeccable timing. And I can't think of a better place for this to occur because we have such a unique neuroscience community here at UCLA. As Indu mentioned, I'm a physician scientist and a stroke neurologist, and I have an interest in cognitive impairment. And so I find myself now running the Alzheimer's Disease Center, and you might ask, how are those two things connected? But my research focus has been on the interaction between cerebrovascular disease and neurodegenerative pathways. And so advanced slide, there we go. And so one of the ways that these concepts have been connected in the last few years is using a term that we call vascular cognitive impairment and dementia. It's a bit of a clunky term, but we are privileged now to run an NIH-funded Center Without Walls focusing on this particular topic, one of 6 in the country. And as I reflected on what to talk about today, I thought about something that Helen said very early on as we prepared to speak at this event, and that she asked us to be bold and try to be transformative in our concepts and presentations. And so I'm going to offer you my sort of core guiding principle as I think about brain health, which is that there really is no more important indicator of brain health than brain blood flow. Brain blood flow, there are nearly 400 miles of brain blood vessels in each of your brains right now. Brain blood flow is uniquely conserved across animals. It is quantitative, and it is directly responsive to neural activity. And so it's uniquely positioned to play a key role in how we think about brain health. And so I would posit to you then that how we conceptualize vascular health is a direct driver of how we should be thinking about brain health. And moreover, most of the disability and mortality that's due to stroke and dementia is preventable. I show in the top left corner there a graph of the dichotomy between the advances we've made in protecting ourselves against heart disease, with a 7.3% decline in mortality due to heart disease over the last 30 years, against the dramatic increases in death due to stroke and dementia, 175% over the last 30 years, an increase. This is a fixable problem through quantitative monitoring of brain health. And if we were to have this summit 5 or 10 years ago, I probably would be chased off the stage because it wouldn't be, my last statement would not be possible. But as we sit here today, advances in how we quantitatively measure brain health, particularly for these two disorders, create the unique opportunity to transform brain health in the same way that heart health has been transformed. Now, on the surface, these two diseases have nothing in common with each other. Stroke we think of as a disease of acute onset. It's occlusion generally of brain blood vessels, lack of blood flow. It causes disabilities that are rapid in onset in movement and speech. Whereas Alzheimer's disease is a slow and insidious neurodegenerative syndrome that results in the degeneration of brain cells and disabilities generally of cognition. However, together they represent two of the most common disabling neurologic ailments. My colleagues on the stage would likely take issue with that, and you've seen some presentations that suggested that they are amongst the most disabling. However, I would argue back that the most severe consequences of neurologic disability result from these two disorders. In the US, we have 7 million folks who are suffering after surviving a stroke, approximately the same number with Alzheimer's disease. If we posit how many might be at risk for either one of these conditions, a conservative estimate is 27 million. That's a tenth of the US population. These two disorders are directly linked, though, through poor brain health, a long antecedent prodromal syndrome that manifests with these two disorders at the end. And prevention through maintenance of vascular brain health in advance of both disorders can modify the risk for both of these. I'm showing a graph, a roadmap that we've seen already in this summit, the WHO preventable risk factors for dementia. I would just highlight that 8 out of the 14 are directly related to vascular health. This is the AHA guidelines in the top left corner of the prevention steps that one needs, the risk factors for stroke. Again, you see the same 8 out of 14 dementia preventable risk factors. So there's direct overlap. This is not a coincidence. It implicates shared underlying biology. And recent advances in how we think about measuring the brain using both imaging and blood-based biomarkers can dramatically change how we think about this and really provide unrivaled tools for advancing these disabling disorders. So I've shown a few examples of the techniques that are available today if you have the right approach to thinking about how to prevent these disorders. So on the top, an example of how we can now image in exquisite detail the wall of brain blood vessels. That here really limited to the large arteries that feed the brain with most of its blood supply. We can look at the specific layers of the blood vessels and identify atherosclerotic plaque years in advance of it causing a thrombotic occlusion resulting in a disabling stroke. The smaller vessels are harder to see, but there are advances in imaging. I'm showing one here, a measurement technique from MRI diffusion tensor imaging called cerebral free water that allows us to make an inference about the functionality of the small blood vessels of the brain. And in the same way we can do that with the large vessels, develop a preventive strategy that can revolutionize how we think about these disorders. In Alzheimer's disease, we have new similar imaging techniques, including amyloid and tau-based PET scans. They can give you these detailed images of how proteins are accumulating in the brain. We know that these pathways start, as Dr. Goldstein indicated, years before the symptoms begin to appear. And so they provide a quantitative tool for understanding Alzheimer's disease. Our own work on blood-based biomarkers for vascular risk have identified inflammatory and angiogenic pathways that can in the same way predict the future likelihood of events such as a stroke. And they transform it into a measurable biology that occurs in advance of the disease. And we now have new Alzheimer's disease biomarkers that allow us to do the same thing. And while these we're still trying to figure out exactly how to implement them to the broader populations, they provide a unique, accessible way to understand brain health in advance of disease. And so I'll wrap simply by saying that the future of the future of brain health in neurologic disorders, such as stroke and dementia, is a quantitative one, where brain health has an index and interventions can be tied to those measures and utilized by patients, providers, payers, and policymakers. Thank you.
We have some time for, I'm just looking at Sahib, who's the master. Okay. Did you want to ask the moderator?
Oh, sure. But certainly, if there are questions in the audience, we can take those as well. But yeah, I think one question I had is we heard about a variety of different disorders that have both acute as well as chronic sequelae. And when we think about brain health, I certainly talked about prevention, but I think can any of the speakers think about or comment on how brain health interventions that we might share with our patients or the broader community might be particularly relevant based on the particular epochs when these diseases manifest?
Andy, do you want to say something?
Yeah, so migraine as an episodic disorder like epilepsy is one that we don't necessarily think about the chronic sequelae, and I don't have a specific answer about any brain health, like sort of lifestyle or tips about how to mitigate it, but more just to think about effectively treating something that we have effective treatments for, and seeing how that will then change people's responses over time. I just wanted to also point out to the point about women, the fact that here we have a disorder, migraine, that is 3 times as common in women as men. What does that tell us about neurodegenerative diseases and Alzheimer's in women? Maybe nothing, but maybe there's something to learn there. And this is a critically important question, I think, that we have to ask. Acknowledging migraine as this extraordinarily common disorder, and not just does it have negative effects, but maybe it has positive effects. Maybe actually there's something beneficial about having migraine, which is why it's evolved to affect 25% of women. So I think just being alert to and being aware of all of these diseases that we're talking about and how they intersect with each other is something that's critically important. So I really enjoyed all of your presentations, and great to think about how all of these neurological disorders intertwine.
One thing that I wanted to ask the panel is, I think we have a sense that we can predict who might get disease before they get it and give them a risk score of how likely it is that they'll get this. You deal with, Raj, genetic diseases, and as do Parkinson's has certainly a genetic and a predisposition. We can predict from sleep studies and smell tests and things like that with actually a very high likelihood who was going to get Parkinson's. So how do we tell people? We already found from our patients that when we give them the diagnosis of many of these things, that we don't do it well. We don't give them proactive things to do, and they really feel very demoralized about having now a disease diagnosis that really is hugely stigmatized and impactful on their quality of life for it's life changing. So how do we give these risk scores, for example, Jason, with and yet give hope and deliver them with some you have this and X, Y, and Z?
Yeah, so I'll take that. So yeah, I mean, we heard a beautiful, we heard a tragic story about that from the patient story we heard in the panel before this. The diagnosis given and then, on your way. I think my teaching in my training has been that we should be very careful about that predictive or even the diagnosis, sharing it, conveying it, doing it with the appropriate consultation. I think patients are over that. I think patients are ready to hear about what's going on with what they're at risk for, how can they mitigate it, and what we have to do is develop an infrastructure that can wrap them in those tools. And so maybe it doesn't come from the healthcare system exactly, but it comes through a broader discussion like we heard. So I think James was talking about that, kind of destigmatizing the discussions. So how's your Alzheimer's going? What's going on with it? What are you doing to make it better? Are you going to the doctor? Are you following up? Those kind of casual conversations, I think, extend what we can do as providers. And I think the more we can create in the broader community a safe space where these diagnoses are not considered,
the end of one's, cognitive life or whatever the case may be, their work life, whatever the case may be, that can be an important way to extend and offer them guidance on what to do with the metrics that we were discussing.
Oh, I was just going to add to that. I think you're right on, Jason. But in addition, for some segment of these disorders, we can also do risk assessment as a preventive measure, right? So certainly with traumatic brain injury and neurotrauma generally, and maybe for some of the other disorders as well, we can reduce the profiles of preventive as a way of de-accelerating an ongoing process or preventing the process from getting started in the first place. So that's where there can be direct societal impact, no pun intended, to drive the risk of preventative risk up so that the profile is decreased at the global as well as the individual level.
I just wanted to relay a question from Paul Thompson from the live stream. He says, great session, great talks, everyone. He's interested to ask Dr. Subramanian why Parkinson's has increased and if there are any environmental, like non-genetic risk factors that are supported by research.
Yeah, so I mean, I don't think we have the answer to that. That people have said, well, the population's living to greater, older, it's just from longevity, but really that's not the case. I think there are certainly environmental, pesticides, a number of things that are in our environment. Trichloroethylene is another one. There are things that are still available and used in this country actively that have been banned in pretty much many other parts of, almost most other parts of the world. So we have a lot of, again, public health, this is a public health crisis, and just this past week, a number of my, patient advocates that I admire have been lobbying, directly in Congress to try to get rid of these chemicals that are being actively still used. So there's a huge amount of environmental toxins. I worked at the VA, Agent Orange has been brought up. There's I think also as we increase disease awareness, hopefully we'll see actually, more numbers coming forward and identification and certainly people of color, people who are women, younger patients. This is a disease that affects 15% of patients are onset below the age of 50 is what our current numbers are, but I think it's actually higher. So
I would just add to that very briefly and do that. We just had a unique Los Angeles experience that the brain particularly does not like elemental metals, and they were dramatically released during the fires. So directly toxic to brain vasculature, directly toxic to neurons, something definitely that we need to think about and study here.
Directly neurotoxic.
I wanted to ask sort of the accessibility question. I know we're getting better. We have more and more technologies. We can look at arterial walls and have fancy DTI scans. And are there efforts to distill predictors for your everyday person that will not have access to a lot of these technologies for a while, even if we get going on making them more accessible? How can we distill other types of prognostic factors and get them out into the public eye? I think there's a need to be responsible in that way, and in realizing that we can create a very boutique-y kind of early identification strategy, and our technology is going that way, but how can we get it more accessible to people in everyday life?
I think for epilepsy, that has people have recognized, particularly yesterday Dr. Lewis talked about the eye gap, where the UN Charter and all the signatories to at a policy level, people have recognized that there are upstream measures that it changes in terms of good prenatal care. A lot of access to prenatal care is lacking in many parts of the world, and and in some parts even in our country. That prevents childhood like sort of perinatal trauma and sequelae of epilepsies. So I think integrating care across primary care, and not just providing care at a tertiary center, as we are thinking like by subspecialists like epileptologists, moving the care out in the community, I think that's where we are going to see a lot of change.
And I'll just weigh in that I think this revolution in sensor technology is really democratizing the sort of capacity to collect information about oneself because these sensors are incredibly cheap. And so they can be configured in ways that really people can use them to gain information that can lead to early disease state detection that's interesting in different ways. And one of the things we've been thinking about also is not just having like these gigantic power-eating data centers, but actually have individuals have their own data centers where they actually control their own data and can analyze their own data without necessarily putting it into the hands of other people. So I think these are exciting times to make that kind of technological advance more accessible.
And I'll just say that, so we had a task force that I had cheerleaded for 5 years, finally happened at the Movement Disorder Society, which is our international society that takes care of Parkinson's and other disorders. So we had a task force that was global. It included people from Africa, and the whole point of the task force was what you can do for yourself, not what you can buy to live better with Parkinson's. So it was very accessible, and almost everything I do is about how can we distill this to people who don't even have access to the medicine. So the loneliness scale, which I put in there, is like, takes a minute, can be self-administered, and I think is profoundly important. So these sorts of low-hanging fruit that is right in front of our eyes, we really need to partner across, our in our own communities to start just doing this, in real time. So
a quick comment on that. So I know that we're developing AI that can tell just by your speech patterns changes in cognitive decline, and I really worry about privacy because some of this is with publicly accessible ones. So just one. But I guess maybe the next panel on technology will do that. But I actually had a question surrounding about the role of microplastics in this. So we know that it's hugely inflammatory. It disrupts the gut microbiome. And I would like to look at the role of microplastics in vascular disease and neurology.
Yeah, that's a great question and a huge concern. The National Institute on Aging is pushed and in INDS have pushed this concept of the exposome as being a primary driver of neurodegenerative diseases in brain health and aging generally. We're one of 3 centers in the country that received a large UO1 to look at this. One of the components is explicitly on microplastics. And we now know that microplastic particles that are really some of them at the nanoplastic level reside in the brain and have been found in animals, not just humans, but animals all across the globe, including in remote regions in both the Arctic and the Antarctic. So the consequences of long-term exposure are not known and clearly have effects both on brain function and particularly the cerebral vasculature. Under study now, completely underappreciated up until now. This is the whole concept of a gene by environment interaction. So we have, this is a fundamental concept that kind of pulls this lifelong brain health aging axis where microplastics are intervening at different levels across the development of the brain and throughout life. It's a completely, largely unexplored area that needs intensive research now. And I think when people realize that these large plastic islands that are floating both in the sea and in our air and in our soil, realize that this is impacting your brain and your heart health, maybe it'll push efforts to get this cleaned up and addressed appropriately.
All right, we've got time for one last question.
It's actually more of a comment, but I just want to speak to the accessibility issue, particularly as it pertains to easily accessible digital technologies. And we sometimes tend to think of those as the problems of other nations. But in fact, some of my colleagues are working with groups in northern Wisconsin, not northern Uganda, where actually during a pregnancy, there is a lack of access, not just among poor women, but middle-class women, to care that can tell them they're at risk for diabetes, gestational diabetes, for preeclampsia, and it's a 2-hour drive to their routine once-a-month clinical care checkup. And having those actual easy, accessible digital technologies in place gives them an opportunity to be able to track themselves, call their doctor and say, I probably need to come in to see you today or tomorrow. So I think we have to also think about the low-tech use that could really improve access here in the United States for many individuals.
All right, everybody. Let's go ahead and we'll get started with the afternoon session. The quote-unquote pediatric session, but we elected to change the title a little bit in fitting with some of the conversations that we've had from Helen and from Dan Geschwin and other speakers, even yesterday and earlier today. It's not a pediatric brain health session. It's a session that's emphasizing the fact that brain health begins and even starts before childhood. So brain health in development starts in utero, through childbirth, and into the pediatric age range. We're going to have 4 speakers. We'll have just very brief transitions in between, so you can read the bios on the website with the PDFs. I'm going to lead off. I'm the Division Chief of Pediatric Neurology and Developmental Behavioral Pediatrics, Chris Giza, and I'm going to talk about traumatic brain injury and about recovery and plasticity and the use of sports and exercise in kids and how that can have impact on long-term health. Dr. Rajuda Wilson works in neurodevelopmental disorders and quantifying and early diagnosis of neurodevelopmental disorders, which is incredibly important across the lifespan. And she's also going to talk about the benefits of movement and exercise in the NDD population. Dr. Shefali Jesti, who is our department chair in pediatrics and a member of the Division of Child Neurology, is going to take the precision health approach to neurodevelopmental disorders and talk about that. And then lastly, Shannon Tyne, who runs the Department of Pediatrics at UCLA. All of you, our county hospital affiliate, is going to talk about adverse child experiences and both pediatric and long-term brain health. So it's really, I think this is really the foundation, I think, in many ways of what we wanted to talk about for the last 2 days. But everybody starts with a little survey, so I just wanted to start with a survey in this room. How many of you were once a child? Show of hands. Okay, all right. So this is important for all of us, right? And all the people who come after us, all right? When you think about, what's the most precious resource in the world? Okay, I know we all say the brain health economy. It's not gold, it's not diamonds, it's not even oil, although right now oil's getting up there, okay? Okay. The most precious resource in the world is not just the brain, but it's the brain of a child, okay? And if you think about this from your economic standpoint or however you want to think about it, your highest return on investment is going to be investing in brain health care for people who are still putting their brains together, okay? And so all the stuff we've talked about up till now is based on the foundation of having a good brain to start with, or making the brain that you have to start with develop in the best possible way. Okay, so with that, I'm going to start the first of the 4 talks, and then we should have at least a half an hour for questions at the end. My talk is the most complex injury to the most complex organ. So this is traumatic brain injury, and we'll talk about it in a couple different contexts. But I want to tell you a story rather than show you a lot of data. If you want data slides, get me afterwards. I can come and give you a talk for 45 minutes or a whole afternoon if you really want. But I know it's right after lunch. So I want to tell you a story about a soccer player, 17-year-old soccer player who came to see us. We'll call him JB. And you'll probably think already, oh, I know what this story's about because TBI is just one thing, and I know soccer players get a certain kind of TBI. It's either a concussion or a heading injury, but it's not. Okay, and what happened is this soccer player was with his buddies on the golf course, and fell off a golf cart and essentially had a kind of a motor vehicle accident. And he had an acute cerebellar hematoma. That area of the brain doesn't have a lot of space for pressure, so it compressed his brainstem. He was going to die. He was transported, urgently had neurosurgery, which opened up the posterior fossa, drained out the blood clot. At the time of doing that, the CAT scan also showed what we call the contracou injury, so the injury where his head hit, and then there was an injury in the right frontal on the opposite side. So he actually had a pretty complex injury. In the old days, we would just call this a severe traumatic brain injury, like that means anything, right? His Glasgow Coma score was 6, it was a bad injury, okay? But the way we're doing now is we're trying to classify the injuries pathophysiologically. So it was a traumatic injury with a cerebellar hematoma, acute cerebellar hematoma with imminent herniation, a right frontal contusion, loss of consciousness, unresponsiveness. Fortunately, did not have any early post-traumatic seizures. So he ends up in the ICU, but is stable after that. And so the first point I want to make is, and Dr. Goldstein alluded to this a little bit, okay? So in the world, about 1 in 3 people have had a traumatic brain injury somewhere along the spectrum, and that's why one word doesn't describe it all. From a severe injury like JB had, to a concussive injury, maybe even to repetitive head impacts that don't reach the level of a symptomatic concussion, they may be having effects on the brain. So that's a lot of people in the world. About half of people have brain injuries before they're 20. So it really is, and then there's another peak in old age. So traumatic injury is one of the top causes of death or acquired disability in pediatrics. We're also going to talk about genetic causes of neurologic disability, but if you're starting out with a normal brain and you're getting injured, this is one of the things that's going to get you. And guess what? It doesn't limit itself to neurodevelopmentally normal kids. It can also affect neurodiverse kids and much more complicated to manage and to take care of. So it's a big problem. All right. So our guy comes out of the ICU. He doesn't have, so one of the things you worry about in brain injury is pathways that get activated, change. And that's this function of neuroplasticity. We've heard a lot about it over the last few days. I like to say, is being plastic fantastic? Being younger is supposed to be better, right? And so you're supposed to have a better recovery after these things. But that's not always the case, right? If you have more plasticity, what that means is if a pathway in your brain gets turned on, it gets strengthened. So if I'm learning times tables, and supposing I want to know times tables, then that's a good thing, right? Because that pathway gets easier and easier. If I want to learn how to ride my bicycle, okay? But if I'm having a chronic pain stimulus, or I'm having a seizure, or I'm having, some autonomic disturbance, and that pathway is getting reinforced, that's a bad form of plasticity. And so it's a two-edged sword for kids. The developing brain is both remarkably resilient, but also uniquely vulnerable, and vulnerable in different ways at different stages. Hence, the most complex injury to the most complex organ at the most complex time. Okay? So our guy made it through the ICU without having any acute post-traumatic seizures. That's good, okay? He actually made it through the rehab phase and got pretty good motor recovery. He was actually able to get back and go to school. He didn't have chronic headaches, so a lot of the bad plasticity stuff was kind of not an issue. In fact, he went back to school, private school, getting A's and B's, and aspiring to go back and play soccer. His senior year coming up, he's applying to college. He doesn't intend to play in college, but he's with his, his peeps that he's been playing with for years. And someone tells him, well, because of this injury, you'll never play soccer again. And almost within a few weeks, literally, he became depressed. His grades dropped to C's and D's. He had his first suicidal ideation. Fortunately, no suicide attempts, but everything, the wheels were falling off, okay? And so the question is then how do we use this plasticity, and what do we use to treat him in this situation, right? One thing we did was we identified he had balance problems, and he worked with physical therapists and his athletic trainer to improve that. We did a good cognitive assessment to make sure that frontal contusion didn't put him at risk for some impulsive or executive dysfunction that was going to make him at higher risk for injury. We knew he could probably perform pretty well because he had been getting A's or B's until the depressive situational issue came up, right? So he was starting to recover. We obviously had to wait for the bone to heal. So several months went by, but at least there was the prospect of returning to sport. And that brings me to my third point, is that sports and exercise equal brain health, and they particularly are important for brain health in kids, because the habits that you develop when you're a child are ones, like I said, there's plenty of data beyond what I'm showing here to demonstrate that the things you do as a child will stick more when you become an adult. Team sports, in a survey of over 15,000 adolescents, kids who do team sports generally eat better. They're more active, not just through the adolescence, but into adulthood. About 40% reduction in drug use in adolescence, about 30% reduction in smoking, less likely to carry a weapon, about a 30 to 40% improvement in mental health, and a bunch of other at-risk behaviors in this study showing less likelihood for unprotected sex. Many, many bad things are mitigated by participating in a sport, and particularly a sport where you have a social construct. That transfers into adulthood. So it's not just talking about kids. In a study of over 1 million individuals who were self-rating their mental health, it turns out that participation in team sports was 22%, give a 22% reduction in measures of mental distress, which was larger than the effect of going to college and getting a college degree, or having an income of greater than $50,000 a year. Now, $50,000 doesn't buy a lot of beer anymore. You can't wear the shades if you remember Timbuk 3. But the exercise is actually a bigger protective effect than some income stability or a college education. So regular exercise protects mental health more than education or income, okay? So if I want to leave you with 3 points, one is that brain injury is an important thing, and it's an important thing when it happens very early in life. It's important all the time, but early in life it can alter a trajectory. The second is that the young brain is remarkably resilient, okay? But it does have vulnerabilities, and we need to be attuned to those. And that's why we need to intervene when kids are young, not waiting till they're years and years later after injuries to try to help them. And then last thing, that sports and exercise are a natural way that gives lots of benefits to both the normally developing brain and, as we'll see shortly, the developmentally challenged brain, the neurodiverse brain. So thank you for that, and I'm going to turn it over to Dr. Wilson. She's an assistant professor in pediatric neurology. She's working in the CAN clinic. I'll let her tell you a little bit more about the things she does, but she specializes also in autism and neurodevelopmental disorders.
Good afternoon, everybody. Very excited to be here. Very excited for this Brain Health Summit. and as Chris said, to really highlight the importance of brain health in childhood. So I'm going to be talking about this concept of movement as medicine, and particularly in shaping how we rethink about brain health in individuals with neurodevelopmental disorders across a lifespan. And so I'll start first in infancy, where we know that movement or motor function is really the first visible or observable output of early brain development, right? When infants learn to roll, crawl, walk, that develops rapidly in the first year of life, and it gives them access to their world around them, engagement with caregivers, exploration of objects, maybe walking away from caregivers, as you say here. And there's beautiful data, both from our lab and others, demonstrating that these early motor skills lay a very important foundation for the development of language, social communication, and visual spatial abilities, right? Many other critical cognitive processes. When we think about neurodevelopmental disorders, particularly autism, motor function is impaired very often and early in life. You see this young girl here, same age as the girl on the other video, where mom is really supporting her access to the world, right? So now that we have this lens of motor function, let's think about it in the context of autism. Early identification and intervention in autism have been demonstrated to be the two most important outcomes for optimal brain and behavioral health across a lifespan, not just in childhood, even in adult academic outcomes, right? And now, as we know, the most recent CDC estimates are that 1 in 31 children in the United States have a diagnosis of autism. So this ability to identify early and provide available therapeutic options is paramount. But somewhat surprisingly, given all the work that we do in early identification and early markers, early identification remains a major challenge in autism across the world. And one of the reasons for this is that we don't yet have robust, reliable, scalable, clinical predictors of autism in the first year of life, despite knowing that these symptoms arise quite early. So let's talk a little bit about what we know about autism in this diagram that I have here, where you can see ages, prenatal all the way through 5 years, and then I have different sort of colored blocks talking about behavior and brain development. So from very rigorous scientific and genetic studies, we know that the brain differences associated with autism start very early, in infancy, if not prenatally, right? When we think about autism symptoms, things like social communication difficulties, restricted behaviors, from a clinical perspective to diagnose those, many times clinicians aren't observing them or feeling confident to make those diagnoses until closer to 2 to 3 years of age. Again, even though parents are noticing signs and symptoms earlier. That means a diagnosis is often happening after that time, with the average age of diagnosis in the United States being 4 years of age or later, particularly in certain underserved ethnic and racial minority groups. And then, of course, in order to get intervention, you need to have a diagnosis. So interventions are really starting way later, right? 5 years old and beyond. And I just told you that early identification and intervention are the two most important things, particularly during this really plastic, critical period of brain development, like Dr. Giza was mentioning. So our team started thinking about how can we address this? What would be the visible behavioral output of these very early brain differences? So we came back to the fact of these motor differences that I showed you in the previous videos. And what we did is we developed a study to assess infants longitudinally in the first year of life that are what we call at elevated likelihood for autism. So these are infants that have an older sibling with autism, a family history of autism, where we know from beautiful data done here at UCLA, at other sites, puts you at about a 20% higher likelihood of autism compared to the general population. So it's an opportunity to study this cohort very early, longitudinally, to see if there's early signs of autism that we can find before 2 to 3 years of age. So what did we do? Our work in the lab is a lot on wearable sensor, computer vision technology to make objective, reliable markers of early prediction and change over time and make those scalable. So we took this wearable sensor here, or a gyroscope, and we scaled it to the home for infants to study them in the first year of life. Here you see a 6-month-old girl. She has the wearables and these cute little warmers on her wrists and ankles. Only in Los Angeles are they custom made by a designer downtown. Trying to scale those a little bit more as well, so we've done that. But so you could see that here. You see one of our other kiddos here at 9 months of age wearing these wearable sensors. And again, we wanted to make this scalable, so we deployed this to the home. We got full-day naturalistic data, not just the type of movements they might produce in a lab when they're hungry or they're tired, but when they're engaging with their mom, before sleep, after sleep. And from these wearable sensors, we can develop really important metrics of movement, right? Really detailed examination of subtle movement differences. So I'm going to show you a little bit of data here. And what you see in this graph, first what I want to show you is on the y-axis, we see one of the metrics that our team developed that we hypothesized would be associated with autism. And on the x-axis or below, we see each age that we measured these infants, 3, 6, 9, and 12 months of age. And there's 2 lines on that graph. There's a purple line and a green line. What that's indicating are the infants. We followed them through the first year, then we tested them at 3 years to say, do you have an autism diagnosis or not? The purple line is no autism at 3 years, and the green line are those who went on to have autism. And what I want to point out to you is that time point at 12 months, where we found that the infants in the first year of life, by 12 months of age, differed significantly in their movement patterns, the ones that went on to have autism compared to the ones that didn't. And we were able to predict with high accuracy at 1 year of age those that will go on to develop an autism diagnosis. So being able to do that would significantly reduce these diagnostic delays. And now what we're doing with the new grant is we are scaling these data, validating these points, and scaling it to clinical settings so that we can actually start addressing these issues of early identification. But once we do that, even more importantly, you can see it really opens up that window of opportunity for early intervention during a very critical time of brain development. So from this infancy lens, I'm now going to move over to thinking about motor function or movement as medicine across the lifespan in neurodevelopmental disorders and link back up to what Dr. Giza was talking about. So we know from data in our lab and others that these movement difficulties aren't just in infancy. Actually, motor challenges are across the lifespan, adolescent, adulthood, in autistic individuals and many other neurodevelopmental disorders, intellectual disability, ADHD, and data has shown that greater than 80% of autistic individuals have motor difficulties. We also know that these individuals with intellectual and developmental disabilities, those who identify as neurodiverse, are twice as likely to be inactive compared to their neurotypical peers, right? So these poor fundamental motor skills, these delayed milestones, lead to more sedentary behaviors, more reduced peer interactions and social opportunities, more screen time, further compounding these motor difficulties and exacerbating things like poor physical health outcomes, mental health outcomes, and brain health outcomes. So in our lab, we also think not only about identifying these motor difficulties, but treating them. And how can we have accessible, available, sustainable interventions for individuals across the lifespan to improve outcomes not only in infancy, but even in adulthood? And that's where comes in the role of sports or organized physical activities, which are often readily available and accessible. But we wanted to think about how can we really build this idea of movement as medicine even in neurodevelopmental disabilities? So we built a program here at UCLA back in 2019. Then medical student, Dr. Emily Coker, who's a pediatrician at Stanford now, and I established the Expressive Movement Initiative dance program at UCLA. You'll see here at the top photo is when it was run, it's still running in person, but when we first started. The bottom photo is a beautiful article the Daily Bruin did when we quickly had to move to remote when COVID set in. But this program is now a fully run student organization program at UCLA. It runs 3 times a week, once in person, twice on Zoom. It serves individuals with neurodevelopmental disabilities 4 to 17 years of age. and each child is paired one-to-one with a trained UCLA volunteer in neurodevelopmental disabilities and adapted movement. So how do we think about movement being medicine? How do we make it prescriptive? We study it, right? We make it science. So we got funding to study this program as a randomized controlled trial. And what we found in our pilot phase was 10 weeks of this program delivered 1 hour a week with a paired volunteer. In our treatment group, they had a significant improvement in motor skills and in social communication skills. Really these broad benefits. And since then, even before that, there have been beautiful data showing that the neural effects of these intervention programs for those with developmental disabilities and broad behavioral and cognitive improvements as well. And so I'll end on saying that these programs not only have great benefit, but they're highly inclusive, right? We have many families coming to tell us, my child now who identifies as neurodiverse or with a neurodevelopmental disability is doing the same type of programs that their neurotypical peers are. Or maybe more importantly, their neurotypical siblings. And now they're engaging with it as a family, and it's something they can all talk about at the dinner table, and it's building confidence across the board. They're accessible, they're highly beneficial, and probably most importantly in childhood, they're fun. So we actually studied that with a colleague, a sports scientist colleague at GW, to show that these sports are fun for neurotypical and neurodiverse individuals, which keeps them retained in these programs, and hopefully can really impact brain health across a lifespan. So thank you for your time.
We'll move right along. Dr. Shefali Jesti is the new chair of pediatrics here at UCLA Hospital, and she'll talk about precision health and neurodevelopmental disorders.
Thank you for the invitation. What an incredible summit. So Helen and organizers, I think this is, so it makes me love UCLA actually, is that we can bring all these experts from so many different backgrounds together to talk about this really important topic. So I'm really happy to be here. And I also will not show you data, which is very hard to do for all of us as scientists. But what I'm going to talk about is sort of some big principles and themes in 10 minutes. Just know that every point I make has a tremendous amount of data that supports that, that fact or that comment. And I'm happy to answer questions or talk to you about data afterwards when we do our Q&A. So I'm going to talk to you about the promise of precision health in neurodevelopmental disorders, which I will say, you know, a decade ago sounded like a pretty audacious, you know, proposition, right? Precision health and neurodevelopmental disorders. We're talking about conditions like Rajutha, introduced in that you heard a little bit about from Dan Geschwind yesterday. You know, these are conditions that affect developmental skills and abilities, often very early in life. They're very heterogeneous and do not fit into one perfect bucket. So how can we be precise when we think about treating these? So let's start, oops, hold on, I know how to do this. Aha, okay. Let's start with sort of how we define precision health. And I really love this formulation from President Obama over 10 years ago when he was actually describing an initiative to improve funding for precision health across health at NIH in his State of the Union. And he said, precision health is delivering the right treatment to the right patient every time. That's our North Star in medicine, right? That's what we absolutely want to achieve. In neurodevelopmental disorders, I would add, we want to do it at the right time. You know, I think a nice segue from what Rajutha talked about, as early as possible. And I'd say also accessibly and affordably, right? But how do we start thinking again about precision in neurodevelopmental disorders? And this is where genetics has helped us tremendously. So there has been an absolute explosion in our understanding of the genetic underpinnings of neurodevelopmental disorders over the last 10 to 15 years. Now, with any neuropsychiatric or neurobehavioral condition in neurodevelopmental disorders such as autism, you know, many children have what we consider polygenic etiologies, meaning there are a bunch of common variants that are inherited from mom and dad, and that combination affects the way the brain develops, functions, and leads to those behavioral symptoms. But what we've also really learned over the last, again, decade or so is that about 10 to 15% of children with autism or related neurodevelopmental disorders have a de novo or a new mutation or variant that is not passed down from a parent that causes a pretty significant impact on brain development and function, and then leads to autism or intellectual disability or other neurodevelopmental challenges. And in fact, genetic testing is now the only gold standard medical workup for a child with autism. So all these other tests we do, MRIs, EEGs, blood tests, I mean, they can be done, but genetic testing is really what's routinely recommended for all children. We still face challenges with insurance authorization and coverage for the testing. We're working on that, but it is really recommended. And so with the advent of that becoming a standard of care, we're identifying more and more kids with specific genetic causes. Now, again, these are all different rare conditions, right, that taken together account for 10 to 15% of the spectrum, but each of these genetic changes accounts for less than 0.1%, right, of the whole spectrum. But what these genetic diagnoses have allowed us to do is really start this, as we think of like pathway to therapeutics, right? So let me walk you through it a little bit, right? So first, you identify a genetic cause, right? Then we can appreciate that there are probably hundreds of other children, maybe even thousands, with the same genetic etiology, and we can get connected with those families through social media, through other platforms. And as we identify cohorts, we can start phenotypically characterizing them better, understanding what the clinical manifestations of that genetic change are. We can start thinking about biomarkers or biological markers that really define what are the changes in the brain that are caused by that genetic mutation or variation. We also can then really start robustly and rigorously developing preclinical models, whether they're animal models, rodents, primates, or whether they're iPSCs and patient-derived models that allow us to start studying the underlying mechanism of disease, but also testing putative therapeutics. And in this space, when I say therapeutics, I don't just mean repurposed drugs that might work in this capacity, but actually, gene editing strategies, ASOs, other strategies that are really targeting the underlying cause of the condition. And again, many of you in this audience who have worked in other aspects of medicine, this is the pathway, right, to targeted treatments and precision health. But this is the pathway that we're also following now in autism, especially in these genetic forms. So as we develop therapeutics and test them and their potential efficacy in these preclinical models, we then can test them in patients, right? And that's where clinical trials in neurodevelopmental disorders become very important. And then lastly, if the trial works and the drug is effective, we can then ideally get FDA approval to deliver it to children in a more accessible way, and that fundamentally improves neurodevelopmental outcomes and, of course, brain health. Now, you might think when you look at this pathway that the biggest challenge here is, well, there's every piece has a challenge, but the biggest area of challenge might be in developing the preclinical models or really thinking about therapeutics. And absolutely that is true. Our colleagues in neuroscience and in genetics have been extraordinarily effective in really accelerating that space. I will say that one of the really big areas of challenge in neurodevelopmental disorders is in the clinical trials. How do we test that treatments are effective, right? So I'll take a step back for 1 second and just, ask, when we think about an effective clinical trial, what comes to mind, right? So maybe most recently, some of you might be thinking about something like Ozempic, right? If you look at the Ozempic trials, those figures, like you can have one eye closed and be 10 feet away from the figure and see that Ozempic worked, right? Because you have a graph that shows that the treatment group, their BMI, well, we'll go this way, improved substantially, reduced substantially compared to the placebo arm, right? You don't need to measure anything complicated. There's no need to do fancy statistics. It worked. Now let's take this same idea and goal to neurodevelopmental disorders. Do you think we're going to see such a slam dunk response? We would love to, but there are challenges, right? What are the challenges? Well, one, in these genetic conditions, these conditions are rare. These are small cohorts of kids that are all over the world. So we're dealing with very small cohorts to really study, which is an issue. Secondly, these are neurodevelopmental populations. So we're dealing with development. So kids look different at different stages of their life. but they also are quite often severely affected with the consequences of that genetic variation or mutation. So these are kids who often have, severe motor impairment or intellectual disability or global developmental delay or profound autism. And so the measures that we might think about using in more standard clinical trials don't quite work in these populations, right? Our standardized measures of cognition may not capture variability in a population where there is still variability, just maybe not on that standardized measure. They may not effectively capture change. And so in that context, oops, wow, I did not mean to do that. Sorry, I just blew it up. Our field has been quite focused on this space of what I like to call clinical trial readiness, and we've written quite a bit about this, which is what are our main areas of focus that can help us be ready to effectively test therapeutics that, again, are ultimately going to improve brain health and outcomes? What do we need to do to be ready as therapeutics are being developed? How do we sort of keep up with our preclinical neuroscience colleagues? And I think about trial readiness really in 4 buckets. And again, lots of data and papers underlying all of these, but I'm just going to give you key principles. The first is we have to engage the patient community from the start. And this is really important because I think that, these are communities that have not been in clinical trials before. They haven't actually been offered the opportunity for therapeutics. And there's a lot of stigma around trials. There's fear around the possibility that a therapeutic might be harmful, might change their child, might lead to other consequences that they're not expecting. There's a lot of questions around things like placebo effect. Parents don't want to be in a placebo arm. They want the treatment. So we have to explain why is the placebo arm important, right? Things like that. So a lot of destigmatization and just education around trials needs to be done. The second and third sort of tie together, which is we need to figure out what we're going to measure, right? So we need to use actually our relationships with these patients and directly test to understand what are the best clinical endpoints that will be most sensitive to change, and are there biomarkers that we can quantify, whether they be brain-based biomarkers like electroencephalography, which is what my lab largely uses. Is it imaging like MRI? Is it quantitative phenotyping measures like motor or eye tracking? But what kind of measures will give us really concrete objective data that could either tell us about drug target engagement, it might precede a clinical outcome, or might even be in itself a meaningful outcome measure, right? And then lastly, we need to, again, partner with families, but here really to launch and promote the trial itself. We need to engage families so that we can ensure enrollment, so recruitment, enrollment, and retention, because attrition is a major issue with pediatric clinical trials for obvious reasons, right? Parents are busy. These kids are often very affected with other medical co-occurring conditions, and being in a trial takes a lot of work and resource. And so we have to think about how we can do that effectively. And I just want to make a point about engaging with families, and this will actually maybe tie nicely to Shannon's talk, which is next, which is, when we think about outcomes and the health and well-being of these kids, so much of this depends on the community around them and the engagement of families. And I will say that it's been an extraordinary experience for me in my career over the last, 2 decades now, working with these patient advocacy groups that are cropping up by the second, right? So what happens in the genetic neurodevelopmental space is that a family finds out that their child has a rare genetic diagnosis, and they go on social media, and they find other parents who have a child with the same diagnosis. And then these intrepid parents create patient advocacy groups. And what is their goal? Of course, it's to support their children and to support each other and to create a community, but it's also to accelerate research, right? They want trials and they want treatments. And so this is just, a snapshot of a few logos of these patient advocacy groups, but there's 1,000 more. And it's been really amazing to see how these groups have been the catalyst for progress in this area. I show one, picture here from one of the rare disorders that we study called Dup15q syndrome, where we started a trial a few years ago in partnership with a large pharma company. This was actually a repurposed drug that was being used to really target the underlying mechanism of disease in this condition. And we went to the family meeting like we did every year, actually, to engage in research. But at this particular family meeting, the keynote speaker, who's also a parent of a child with this syndrome called Duke 15q syndrome, at the end of his very moving talk, flashed this number 90. And 90 was the target enrollment for the trial. And that launched this like mantra of the number 90. And for the whole week at this meeting, parents were talking about, we got to get to 90, we got to get to 90. And in fact, within a few days after that meeting, we'd 40 families signed up on a wait list for the trial. And we had no problem enrolling. Right? There's a whole other story to that trial that I will tell you at coffee or over a beverage at some point. That trial ended up getting halted about 6 months later. And the parents, in response to it being paused, wrote tomes of letters to the company itself, begging for a reconsideration of this trial. And there were quotes like this: "The need is here, the participation is here, our community is unstoppable." And we now actually have that drug has been bought by another company, and we're relaunching this trial very soon. But just experiencing that advocacy and engagement of those families was really powerful. This figure, quickly, I'll show you. I actually had Claude help me make this, in full disclosure. And I asked Claude to help me make a visual of the growth of clinical trials in genetic neurodevelopmental disorders over the last 20 years. And the colors are just based on bins of like genetic mechanisms, so don't worry about that too much. But look at this growth, right? So between 2022 and 2024, we have about 150 new clinical trials in genetic neurodevelopmental disorders. So it's happening now, right? This is super exciting. And so the last thing I'll just share with you is that in that context, there's a new initiative that's being launched that many of you will probably be hearing about if you have not already, called ARIA, which is Aligning Research to Impact Autism. And it turns out this is the largest funded initiative in neurodevelopmental disorders in this country. And it's funded by the Sergey Brin Foundation, and it's a multi-million-dollar initiative really meant to promote clinical trial readiness and clinical trials in autism, with a focus on these genetic autisms and also on what we call profound autism, so children with more significant support needs. There's a bunch of hubs in ARIA that are really more focused on the basic neurosciences, studying mechanisms of disease, and developing therapeutics. But at the core of this, of ARIA, are these impact centers that are getting funded. IMPACT stands for Innovative Medicine, Precision Approaches to Clinical Trials. And the network, which will be sites around the country, will be well-funded to be able to engage in all that clinical trial readiness work that I described. And then, as therapeutics are developed, kids can be moved directly into trials effectively and quickly. Our team at UCLA, in partnership with Boston Children's, we're overseeing the activity of these impact centers. And so we're right now in the throes of developing the protocols and thinking about all the different data and regulatory and all the aspects that have to be considered as these sites launch. But you'll be hearing a lot about this, and it's incredibly exciting. And then the last thing I'll say is that I've been reflecting a lot on the fact that I was a resident now 20 years ago. I wish it was less, but it was 20 years ago. And 20 years ago when I was at Boston Children's, we would do genetic testing for kids with autism, and it was academic, right? It was to get data and to put kids in a registry, and families would say, what does this variant of unknown significance mean? And we would say, I don't know, but it's information, and hopefully at some point we'll be able to give you more guidance based on this. 20 years later, we're in a completely different space. So now I make a genetic diagnosis in a child with autism. I can connect them to a patient advocacy group. They can form a community, which in itself, I think, can be very therapeutic. But we're also able to better clinically monitor kids based on our knowledge of what these conditions look like in larger cohorts. And lastly, we can give families hope that we're working towards actually effective treatments to improve brain health and outcomes in these populations. And so with that, I'll stop. Thank you very much, and I'll turn it over to my colleague, Shannon.
And then our last speaker is Dr. Shannon Tyne, who is a vice chair in the UCLA Pediatrics Department and is chair at the UCLA Olive View Hospital.
Thank you all. It really is wonderful to be here. And I come from to this work with a little bit different perspective. I am a generalist, so I'm not a developmental pediatrician nor a neurologist, but I also come from the public health perspective and trying to bring this group out to a broader view as we bring this home in the pediatric realm. But I want to bring this perspective because for the last 4 years, I've been a co-PI on a project called the UCLA UCSF ACEs Aware Family Resilience Network, or UCAN. And what that really is, it's the implementation of a state initiative around looking at adverse childhood experiences. And through that perspective, I've been able to bring in implementation science, policy and advocacy, as well as the beginning stages of life for kids, because as you can see, we all believe that the future starts with, I don't know, conception maybe, but it starts with healthy parents, I guess. We'll even start there. But so I think we're all in these really uncertain times. Our funding is all challenged. Our medical infrastructure is certainly under attack. And I've had the benefit of having some state funding that allows some of the things I do to continue even in this really crazy climate. And so we started this UCAN initiative, implementing ACE screening and evaluation, and then responding to ACEs, which I'll talk about in a second. And we were all ready to go, and then the pandemic hit. And one of the greatest things about the pandemic, and I'm sure you don't hear that often, a great thing about a pandemic, but one of the greatest things about the pandemic was that everybody in the world learned what it was like to experience trauma. And I'll tell you a little anecdote for me, walking in with my hazmat suit, because I was on the 210, going to all of you every day with no cars, going in, and patients were coming when they absolutely had to, right? And patients were doing trauma-informed care with me. I would say, how are you? This is so awful. This is this. We're going to give you your shot, and we're going to get you out of there. They're like, but doctor, how are you? How are you doing? And that was completely new. That was just not the way people looked at their healthcare providers and the system that I worked in. And for me, as somebody who doesn't look like a lot of my patients, it was the first time that there was this normalizing that allowed us to be on a similar playing field. And for me, in the work that we're doing now with trauma, it's been so helpful because there's a mutual understanding. So I would say an ACE, which is an adverse childhood experience, is something that we all went through during the pandemic, and that set the stage for some of the work that we're doing now. So I'm going to talk about the initiative a little bit, and then about how some of the things we've done with the initiative apply to brain health. So what are ACEs? There was a study done in, actually in the 90s, looking at 17,000 adults that were Kaiser patients, and they identified 3 areas: abuse, neglect, and household challenges, that made up a set of 10 ACEs, and you can see them here. And the abuse was physical, emotional, or sexual. Neglect could be a broad range. And then household challenges, things like growing up in a household with incarceration, mental illness, et cetera. And we all know that those are not the only bad things that ever happen in people's lives. But what we do know now is that there's a body of evidence that shows when these 10 things happen in life, there are evidence-based things that we see in adulthood. So ACEs happen before you're 18, and then later in life, your life is different based on having experienced, or can be different based on having experienced those things. So the scientific research, The scientific research around this is really interesting because we look at what does a traumatic event do, and how does that change your brain? So if you look at I'm a pediatrician, you can see the little cartoons that I like, but a traumatic event happens to you. Somebody leaves, someone gets sick, someone goes to jail, and I mean, a snake is a good example. And my dear colleague Nadine Burke-Harris, who helped launch this movement, she's all about the bear. Like there's a bear in the woods, and you want to run away, and all these things happen. Well, so a traumatic event happens, and what happens? Your brain has a response, and just to put it super simple, you have your rational thinking brain, your emotional feeling brain, and your instinctual brain. And if a bear is running at you, nobody really cares about the neocortex, right? You just want to run. And so when those things happen to you, your brain has the different parts of it that respond in different ways, the limbic system you can see here. And then my little kid fights, flights, or flees. You just do what you need to do to get through it. And then what happens is a potent memory develops. And that is where there's the potential for what we call toxic stress to occur. So sometimes I don't know, people who like high adventure, you jump out of a plane, right? And you get that rush and your fight or flight response goes in, but the aftermath of that is exhilaration and joy. But when it's a traumatic event, the way that your brain structure changes is different. And so what happens is, if you think about somebody who has a trauma and has potentially toxic stress developing, rather than having the typical brain development that we see when you're younger, where that cortex gets thicker and better and more well-developed, and your social emotional development happens, you see an inversion of the pyramid. And so what's happening is you're having less focus in your brain development on your cognition and your social emotional development, and more of the focus of your brain's development in your young plastic brain addressing the survival techniques. And so what's happening in your brain when you're young is just different than it's supposed to be. And we talk about, well, how can you change that? And obviously we want to buffer against that. And everybody who has a bad thing happen to them does not have this happen, right? And so what we're trying to figure out is how to interrupt that so that you have the development that's going to lead you to the most success. And why do I bring this up? Well, we didn't want to talk about a lot of data, but I want to show you this data because it's pretty compelling. If you look at the scientific research, what you will see is that when you have cumulative adversity, especially during a critical period of your development, you can see some association with the root cause of some major, major problems in adult health. And we all think, oh, well, when you have stress, you have depression. When you have stress, you have anxiety. But when you have toxic stress, you actually have 2 times the risk of dying of heart disease. You can look at this graph, right? More cancer. COVID, we don't even know. It's not even on the graph yet, but it's in the top 10 leading cause of death, which is what this is. And then for the purposes of this talk, something that I know very little about, because it happens in older people, Alzheimer's, right? Look at the odds ratios that you see in cause of death from Alzheimer's in people who have 4 or more ACEs. This is profound. And that is just one of many neural outcomes that are impacted by ACEs. And so when you think about what this all means, we go back to the pediatricians and we say, well, how do we work on the front end to try to prevent us getting to that? And that's what this work has been about in the state's initiative. Because what we're doing with the state is saying, hey, how can we screen for this? And there are a billion questions that you can ask people about trauma, but this happened to be an evidence-based approach. It was studied early on, and people came up with a rubric for how to ask. And the state actually passed legislation to say, let's allow reimbursement in addition to capitation for Medicaid patients for screening and responding to ACEs. So through UCSF and UCLA and UC Davis, based here at UCLA, we set up UCAN, and what it does is it trains clinicians to screen for ACEs in primary care. It allows data collection around the screening, and then allowed pilot projects, which we've done all over the state, to look at how to best respond. And that's what we've been doing for the last few years. And it all comes together in this pathway. There's another kid graphic I've put together. It's like, how do we prevent ACEs? How do you prevent trauma from happening? Or if it happens, how do you buffer against that inverse pyramid of your brain development? What do you do? And then once you've identified ACEs, how do you respond to them so that even if you've had them, you will do better? Just like my colleagues here saying, you have brain trauma, you have neuroatypia, what do you do to maximize someone's potential? And that's what we've been looking at. And when I take the global perspective on this, I think about individual health and community health. Like, what can we do as communities to set ourselves up to buffer against that ever happening, right? So give people access to food, give people access to supportive communities, give people access to an environment free of violence. How can we increase that opportunity? And then when you have the stress response happening, what can you do to teach someone how, or help someone not allow it to become a toxic stress response. So can you teach someone meditation? Can you give someone buffering against some other component of stress? If there's an incarcerated individual in your house, can you give someone a different stable environment? And then when you do that, not only do you improve someone's immediate health, you can improve their opportunity and their health equity and their overall health moving forward. So if I think about what we're doing now, and again, this is a little bit out of the brain realm, but it's been really fun for me as a health services researcher to think about this. We're looking at things like, oh, you have 4 ACEs and you are 3. And we're looking at how ACEs impact different health problems that you see. And so as a pediatrician, I'll just give you a couple examples. If you have high ACEs, we all know that ACEs are associated with obesity. So what we're looking at now is, can you look at ACEs and obesity and how they vary together? And one thing that we're just writing up right now is it turns out that lots of people are overweight and obese, right? It turns out that in the 2 to 5 window, your ACEs start to go up before you go into the overweight category. So what if we, from the precision medicine approach, looked at kids who were in the 2 to 5 age range with higher ACEs and really did very aggressive nutrition counseling, support for activities outside, improve the environment they're in so that they never get that. And last year, we actually published on a similar thing with anemia. And again, a lot of people think that obesity and stress go together, but did you think anemia and stress went together? Well, it turns out in the young population where we screen for anemia, and the reason we screen for it, you may recall, is because your cognitive development is impaired if you have anemia. And what we found is kids with higher ACEs have a linear relationship between the increase, basically low hemoglobin varies with higher ACEs. And so what we've started is an intervention to kids with higher ACEs to try to prevent the development of anemia. And again, that has real potential to stop some of the downstream effects that we're seeing that lead to lack of opportunity and poor health. So I'm really, really excited about this, can you tell? But the most important thing is what we've seen is we've taken funding from the state and been able to funnel this into training for providers and service to patients that then can generate revenue because we're paid for the screening that allows us to do the things we need to do to support people in the community. So we have a very robust online referral system. We have community programs that we connect with because the health doesn't only live in the medical home. It doesn't live at the doctor's office, right? It lives in the community. And thinking about how we can all do that, whether it's, the programs that my colleagues have shown today are really exemplary of that. We're not doing this in isolation. We're not doing this ourselves. Some of us are doing it in labs and clinical trials, and some, like me, are doing it in implementation science, like in the communities. But the most important thing, I think this applies to a lot of what is happening here, and particularly in the pediatric realm, is ACEs are not destiny. My dear colleague Nadine Burke-Harris says, just because you have them doesn't mean your life is ruined. And I'm sure you've all heard Oprah say, it's not what's wrong with you, it's what happened to you. And how do we take what's happened to us and figure out how to make the next thing better? So the ACE response activities that we're starting to develop and look at and associate with other health conditions earlier on in life really have the potential to help mitigate, well, one, them ever happening, but to mitigate the impact when they actually do occur. And so I just put a couple dynamic figures up here of some of the ways that we've used evidence to pull together things like, what can you do to decrease stress? And that Stress Busters algorithm is actually in some CDC work that we put together that's now being disseminated as evidence-based practice, and then looking how to build ecosystems of support. And some of the things on there have a few acronyms on there, but what they are is community online programs, community mental health programs, different care processes that are now funded by the state. Some of you may have heard of enhanced care management, which is a supplemental health insurance for people to get more supportive services when they have higher medical or mental health or social needs. And so trying to build some of this preventive work and responsive work into the infrastructure of what we're doing, I think has potential for all of us as we live in this really uncertain time. And I'll just end with this. No matter where a kid starts out, whether it's a tumor or asthma or a head injury or neuroatypia, our job is to maximize where they end up. And so I think of pediatrics as maximizing potential, and I have so much respect for my colleagues that are doing this work in the areas very precise at the precision medicine level with therapeutic medications or with therapeutic activities outside, or like me with trying to look at bigger population health things. And the way I see it is, if we do more on the front end, it will help those of you doing this work with adults and people who are older. It will give you an easier playing field to work with. And I really believe that prevention is where we need to be. And I think we all believe that. That's not how modern medicine works. We all do that lots of work at the very end of life. But from my vantage point as a pediatrician, that's kind of how we roll. So, thank you.
Questions? While we're waiting for people to do that, we got questions already. Let's go. Let's go. I won't even do an icebreaker.
Thanks. That was really wonderful and kind of heartening. So I'm just sort of thinking about this, like where do you think some of this should live? It's obviously got to be culture change, but it can't all live in the medical system. Children often go back to their traumatic homes every single day, and so it's ongoing. ACEs are an ongoing, kind of complex process when you really, get into the nitty-gritty. So, like, where do you see the school's role in this, kind of family support role? It has to be this big ecosystem, right? So I'm kind of curious on opinions here.
Is this working? It's such a great point, and one of the key components of the work we're doing is actually around education, and it started with education of the medical workforce, and it has become super clear that it has to go beyond that. So the education arm of the movement is actually based here in the Center of Excellence in Psychiatry, and we have now extended that work to child protective services workers, teachers, and the legislation has even changed to allow screening in those settings too, with support from medical personnel. And my newest one, I just taught a class at UCLA, I was just telling Shafali about it, where half of the people in the class were incarcerated individuals about to leave incarceration and go into the world. And their number one place they say that people need to learn more about this is in the justice system, because so much of the perpetuation of what we're doing is occurs in the setting where people are getting the least help. So I think what you're saying is really important to remember. And I will say, whether or not this happens in the world based on funding, but at least in the state of California right now, there are so many initiatives that have recognized that brain health or this kind of health is so much more expansive than the medical setting. And so I think for all of us, I mean, again, we've all been through that. I think we really need to acknowledge how much the community in the very broadest sense of the word is part of this. And I think we're all trying to do that.
I mean, just to make a point from sort of thinking about this from the neurodevelopmental disorders perspective, is I think we often don't do a good enough job in asking about the very important factors that influence a child's well-being. We tend to focus so much on the medical side, right, on co-occurring conditions and sleep and medications for these things. And we might talk about school, but you're totally right. There's so many other factors that absolutely influence a parent's well-being, a child's well-being, that are outside of those sort of typical things we screen for and measure and treat. And I think we're getting better at it. And I think that part of the, I think part of the I think, goal is for us to be able to do it in a more consistent way so that families know that we're actually supporting those other areas. Because I think sometimes parents don't even think to share those things with us, right? Because they're like, oh, we're here to see the doctor. We're going to focus on this one symptom that they're treating. Yet it's all these other factors that are influencing that much more than even the, the sort of targeted history we're taking.
I'll add to that also in the sense that, I ask every single one of my patients, what's your child doing to move, right? How are they getting outside? What are they doing to be active? Because exactly as you were saying, we often focus, especially in neurodevelopmental disorders, so many other therapies, other medications for co-occurring conditions like ADHD and anxiety and depression. But I also ask, is the family getting out to move? Right? Are you going out 5 minutes down the block and back up and down the apartment stairs for 3 minutes right before bedtime to start really thinking about how you can move in short little bursts that's accessible? The other thing I'll quickly say before passing it over to Chris is, trying to arm the parents with more information. So I talked a lot about early identification in autism, and there's this huge consortium called the Baby Siblings Research Consortium that we're a part of, many other researchers are a part of, and one of the big goals on the communications committee right now is to develop infographics. It used to be for pediatricians, right, and geneticists and others, but now it's for parents, right? Here are early signs. Here's what you should do. If your provider says, let's watch and wait, here's what you should tell them to try to go from watch and wait. So arming them with as much information that we can that's tangible and digestible for them.
Yeah, and I'll just piggyback on that. One of the things we talked about is precision medicine, but the other thing we talk about is scalability. And so they're almost at odds with each other. And so you have to partner with others who can be force multipliers for you. So for example, in 3 weeks, a couple of people from our brain sport program are going to teach all the LA Unified school nurses about concussions, sports safety, and return to learn. Okay? And then those professionals will carry it on in their practice, creating webinars or infographics that are not just accessible to other physicians or other medical people or at a medical conference, but people can get it on the website, and parents and coaches and teachers and people in the community can learn. I think that's another way. And then the other thing that will be really important, I think, is for us to figure out a way to measure how that is having an effect. But I think these are all important things.
I was going to bring up one more quick thing. So we recently published the results of a clinical trial that we were doing in a rare genetic syndrome called tuberous sclerosis. And it was actually a behavioral intervention trial, but it started early because we found early markers of autism in this population. But in any case, so there was an active group that was receiving, the behavioral intervention, and then a waitlist group that still had developmental testing and were engaged in the study, but then would be on a waitlist and then would get the treatment, so that we would have a comparison group. And what we found at the end of the trial was that both groups made gains. So we didn't have a main effective treatment. And it turns out that there is something very therapeutic about being followed, right? And we call it the surveillance effect, that families, and we did exit interviews, at the end of the trial, and families reported that just getting feedback about their child's development, feeling like they had someone who was paying attention to that, having some, getting some help around accessing interventions, that was incredibly helpful for them. So even though they weren't receiving any additional, autism-directed intervention, their kids, their babies were showing some progress. And I think that's a really good example of how we need to be thinking about supporting, families, because it does ultimately help, the child too.
Thank you for the great talk. Dr. Giza, you mentioned about the JB case and how exercise is very helpful after a traumatic brain injury. I'm a severe TBI survivor myself, and I took your advice before you gave it. I was exercising, and I got the second TBI on the court. So we know the secondary injuries, like after a traumatic brain injury, is another animal. And how do you, I'm trying to navigate this myself, but it's very important for adults and children. How do you suggest navigating through the risk of getting another injury or improving the functionality with the exercise?
That's a great question. And also, you caught me, because
I was going to ask at the end of the whole session, anybody want to hear about JB? So this gentleman remembered and asked me the question, so that's even better. So what you're asking for is a very individualized risk assessment, right? It depends on, traumatic brain injury is not a single thing, so it depends on the injury, it depends on the individual, it depends on the recovery, and it depends on what activity they're going back to. So I'll use JB as an example. So I told you he was getting better. Once he was allowed to start exercising, his suicidality went away, his grades went up, okay? He wasn't returning to skydiving. He wasn't returning to tackle football. He was returning to soccer, where the likelihood of an intracranial hemorrhage is very small. So we actually did clear him after testing him, and having him go through a gradual return to activity to make sure he was safe at each step. And he played the last 2 games of his senior year with his friends. He didn't want to go on in college to play soccer, so he didn't have that risk, but he felt better. And he went on to study kinesiology and go into sports medicine. So I think an individualized process, judging both the risks and where you are in the recovery, I would still encourage you, without knowing a lot of details, but I would encourage you to seek ways where you can do physical activity safely, and what looks safe right now may be different than what looks safe a year or 2 from now when you're feeling better and have had more recovery. But thanks for the question.
Hi, I am Celine. I am an incoming trainee in medicine, and I'm also I also graduated after studying neuroscience and psychology at USC. So I have 2 questions, mainly for the pediatrician, but anyone can answer. So I'm currently working on an advocacy project that includes interviewing unhoused communities on Skid Row who are recovering from drug abuse. So everyone that I interview with has a childhood trauma or an adverse childhood experience, and one of the person that I talked with had started using drug as a form of self-medication after both of his parents suicided. So I'm talking about that in LA, we have a lot of neighborhoods, such as East LA, that has a lot of abuse, a lot of gun violence and gang violence. So I think the reason why we are lacking a lot of providers in those neighborhoods are exactly why, the same reasons as why those adverse childhood experiences existed. So this is a hard question, but how do you propose to attribute resources or address the adverse childhood experiences in those neighborhoods? And then I have a second question.
Let's do a first question.
Okay.
We got to move on.
So how do we approach addressing adverse childhood experiences in some of the most challenged communities? I think for me, that's the only place I work. And one of the things about this initiative, and I am not saying that trauma doesn't take on all shapes and sizes and families and communities, but we do know that childhood adversity is more common in underserved communities. The LA County operates a public health system that actually partners with CHLA and USC hospitals in some of the areas you're talking about. And then on the UCLA side, we partner with Harbor, All of You, which is out in Sylmar, and then there's 12 community clinics across the county. And in every single one of those clinics in primary care, people are being screened. And so children are being screened for childhood adversity starting at their first visit after delivery. And then for kids, you can get reimbursed to screen once a year until you're 18, and then once after your 18th birthday or any time after you switch providers. That being said, as the first questioner said, it's not always in the medical setting. So we're starting to screen in school settings, in other, in community settings, and those are great, but I do think it's important, at least from where I sit, to remember that this is a medical model. We're talking about associated health conditions, not just social challenges. And so I think part of what I hope we can do, and I think what this UCSF, UCLA, and UC Davis initiative is doing, is trying to make sure that it's done using an evidence-based approach and with real links to
services that can support. Because, and I use this analogy in adult audiences a lot, if you do a screen and you don't have an opportunity to address what you find, it's like doing a mammogram and not having a surgeon to refer someone to. You could actually be doing harm. And so I think what all of us are trying to do is making sure that the things that we identify that we're looking in the right places, and then when we find them, we're doing right by the people that we're serving.
Okay, I'm a geriatric psychiatrist in the business of preventing dementia, and it sounds like we have to start in utero, which I've been saying, and then Gershwin said it's actually before conception. So that makes it a little more complicated. What I'm struggling with is how to convey this message to the parents and families, because when they're young, especially in this, they're dealing with a lot, and nobody's thinking about getting old. So how do we bridge this knowledge and education, public education?
How do we bridge the knowledge that good, health in childhood really impacts adulthood? Dr. Levetsky, is that what you're asking?
Right, but also teach them essential brain behaviors. For example, we have these 14 factors in dementia prevention, but we don't talk about them to the families who are raising children.
Yeah. I'll speak. I want to hear from the rest of the panel. I'll give sort of one example which ties very much back to what Dan Geschwin spoke about yesterday. So in neurodevelopmental disorders, we're starting to get better and better at this and think about this more and more because we're learning about these really increased risks of Parkinson's and Alzheimer's dementia in a very heterogeneous group of autistic individuals, not just in Down syndrome, where we know certain reasons why they're at higher risk. And so now that we're gathering this data and seeing it from these large retrospective Medicaid studies, these smaller sort of cohort studies, we're starting to talk to families that, without scaring them, without saying, because we still need, there's more to learn, that there are very important things that we need to think about in childhood beyond some of these other therapies that are very quickly accessible. How you eat, how you move, how you sleep, right? Sleep is a major issue in neurodevelopmental disorders. And we know if you improve sleep, you have multiple outcomes that we're often giving them medications for to treat, right? So as soon as you improve sleep, suddenly you're off of these medications to improve daytime functioning, irritability. And so I'd say at least from that lens, with that data, that sort of preventative discussion right there in pediatrics is really important. We're starting to do that, and we need to be even better at it.
I mean, I'll answer the question wearing sort of my peds chair hat, which is that, what's really striking is that child health right now is at its worst. Mental health conditions largely driven, COVID, social media, there's been so many changes in the way kids grow up now compared to 10 years ago. So mental health issues, obesity, overall wellness, obesity then which leads to heart disease and diabetes and other things. There's a really nice JAMA paper that came out about a year ago describing exactly this phenomenon. And I don't say that to say that child health is in crisis, but I think many people do believe it is. And I think that nationally, the child health kind of advocacy and leadership community has really tried to sort of scream that message at the top of the mountaintops, right? To really say, listen, how do we address this? We need more funding for research in prevention and in child health, a lot of the things that Shannon does, that sort of piece of it, but also a real recognition, exactly what you're saying, Helen, that promoting child health helps us, helps promote healthy adults, which, ultimately has really important consequences on the financial health of our country, right? So I just sat on a the report is I think actually officially out. We did our public webinar, but I just sat on a National Academies of Medicine committee where we had to write a report. Somewhat ironically, it was before this current administration when I got tasked, but it was around how do we enhance child health research in NIH, through NIH. And NIH was our sponsor, and they wanted us to tell them, not just give us more money, but how do we do a better job to promote research in child health? And one of the main points we made in that report is, supporting child health has implications for a lifespan,
right? And I think we just need to, that message has to be just repeated in a very simple way to every legislator and advocate and funder, right? Because the work that we do is relevant, you know, again, across a lifespan. And I think that's a really important point.
So I just want to thank all the speakers. I think our time is up, and I want to thank you for a stimulating discussion. And please talk to us at any of the breaks. We're happy to talk.
Awesome.
Thank you all. So we're moving on to the next Jesty presentation. Shefali's father and my mentor and friend of many, many years, Dr. Dilip Jesty, will be speaking about exposomics and social determinants of health, why AI should be transformed into artificial wisdom. He is currently the director of Global Research Network on Social Determinants of Health and Exposomics, and president-elect for the World Federation for Psychotherapy, past president of the American Psychiatric Association. Please welcome.
Good afternoon. And thank you, Helen, for really putting together an amazing conference. I must say I haven't attended a conference like this at any academic meeting for years. So thank you. So I'm going to talk on exposomics and social determinants of health. The main thing I want to focus on is the single most important social determinant is social connection. Not the number of social connection, the quality of social connection. And so I'm going to go through exposomics and social determinants quickly, but then I want to spend more time talking about what is happening during the last 20 years to our country. And as actually the previous panel speakers also talked about that, we are going through the worst times in many ways, especially with the loneliness pandemic. And what is the antidote for loneliness? The antidote is wisdom, especially the compassion component. And that is where the AI will be helpful, but not the AI as it is practiced currently. We need to transform artificial intelligence into artificial wisdom, because intelligence doesn't improve well-being, wisdom does. So that is what is needed. So along that line, I will talk more about that toward the end. So let me go through the first part quickly so I can spend more time on loneliness and wisdom and artificial wisdom. So exposomics, as you all know, in 2003, Francis Collins and Craig Winter, they decoded the human genome. There is a huge advance in genomics. And it was thought that probably that will solve all the problems from the genocide. It didn't, because it was soon realized that less than 50% of heritability of mental illnesses is explained by genes themselves. What is important is what happens to the genes because of the influence of the environmental circumstances. So those are the social determinants. And that is where exposomics was born. Dr. Christopher Wilde, a brilliant oncologist, wrote his first paper on exposomics in 2005. And he described that as the exposures to social and environmental factors in an individual over a lifetime with epigenetic and other internal biological responses impacting health. So these environmental factors has a major impact through genes on the health. Around that time, the World Health Organization issued the first reports on social determinants of health. And they defined social determinants of health as non-medical factors which influence health outcomes, including conditions in which people are born, grow, work, live, age, and the wider set of forces and systems that shape the conditions of daily life. And if you could look at these social factors, some of them are at individual level. For example, food supply, housing, transportation, all right? They affect each individual patient separately. Then come factors that are really at a much broader societal level. For example, social discrimination of different types, like racism or LGBTQ bias, so on and so forth. Climate change. So those are the big societal level changes in which the patient himself or the treater actually won't have any much influence. And then there are those that are both individual level and social level, and the best example is social connection. So talking about exposomics briefly, so obviously the different social determinants have different effects on the people. The same social determinant will impact different people differently because there is inter-individual susceptibility which varies. Secondly, as we again heard from the previous panels, there are sensitive life periods. So what happens during perinatal period, of course, is far more impactful than anything else. Early childhood, again, major impact on the rest of the life. Adolescence, adulthood, older age. There is something called Mendelian randomization that has received increasing publicity in recent years. And what it means is knowing what the genes are doesn't make that much difference. Knowing the epigenetics makes the difference. How the genes are affected by the environment. Digital exposome with the social media. Now, there are so many factors that are occurring at that digital level. So digital exposome has become important. And lastly, as again, previous speakers talk about, precision medicine is what we need for each individual person. So we have done some systematic reviews and umbrella reviews of social determinants of health related to major mental illnesses. And we found surprising similarity. Adverse childhood events, food insecurity, homelessness, immigration, incarceration. Similarly, on the social side, social isolation, social fragmentation, social discrimination. All of these factors are associated with increased risk of schizophrenia, major depressive disorder, and various other psychiatric disorders, also increased risk of suicidality. At the same time, we have to realize that social determinants are not always adverse. There are positive social determinants. So our job is not merely to prevent the adverse ones, but do something to promote the positive ones. For example, larger social network is associated with lower prevalence of schizophrenia. Better parental care reduces the risk of depression. Being married or having a partner with whom you have good relationship, and religiosity and belonging to a religious group, they reduce the risk of suicidal mortality. School connectedness is especially great for teenagers and children because that is where much of their stress comes into play. And even the risk of dementia has been shown to be reduced by access to better education in later life, also social support. So clearly there are social factors that are at various levels that reduce the risk of diseases and mental morbidity. How do they do that? Clearly there's a biology model, and we published this some time back, but if you take a look at the usual social determinants like early life adversity, social disconnection, they impact various pathophysiological processes. They increase allostatic load. You heard about that yesterday. Accelerated inflammaging, social epigenetics, and microbiome. By the way, microbiome really has a major impact on brain health and the rest of the health. I think it is only research in the last, I would say, 10, 15 years that has made significant changes in our understanding of microbiome and how it affects brain and the rest of the health. So these pathophysiological processes then affect the brain. They affect the structure of the brain function, chemistry, neuroplasticity. Then what? Then the clinical outcomes. People develop illnesses, schizophrenia, depression, PTSD, so on and so forth. Psychosis with positive negative symptoms, cognitive impairment, quality of well-being goes down, comorbidities, physical comorbidities. So there is clear association of the social determinants going through these biological processes to produce clinical outcomes. But then it goes the other way around. These mental illnesses worsen the social determinants. Again, that is something really important to remember, that the association between social determinants and biology is bidirectional. Each worsens the other, and that is how it gets worse and worse and worse. So when it starts, wherever it starts, it only gets worse unless we start doing something with those positive or protective social determinants. So this is about social determinants, exposomics in general. As I said, I want to focus now on the single most important social determinant, social connection. And by the way, this statement is not based on any philosophy, morality, ethics, not at all. Based on solid empirical evidence, hundreds of studies all over the world, including longitudinal large sample studies with different kinds of biology. Based on that, social connections have greater impact on health than actually even medical risk factors like hypertension, diabetes. Social connections have a greater impact than anything else that we know of in terms of health. And there's a beautiful quote here by an anthropologist and gerontologist in Utah who has done a lot of research in this area. She has published lots of papers. Humans need others to survive. Social connection is crucial to human development, health, and survival. The evidence supporting this contention is unequivocal. There are perhaps no other factors that can have such a large impact on both length and quality of life from the cradle to the grave. Again, as I said, this is an evidence-based, strong evidence-based finding that shows the importance. So something else is happening, though, in the last 20, 25 years across the world. I'm sure most of you have heard about this, our former Surgeon General, Vivek Murthy's write-up about loneliness epidemic. He made loneliness a priority of the CDC. At the time, the government published a report that showed that more people die from social isolation and loneliness than from stroke or lung cancer. Again, this is based on data from number of years, and it is not just a US thing. There are new ministries of loneliness now in the UK and in Japan. And the World Health Organization published a report 3 years ago saying loneliness is a global health priority. And global loneliness is whose really part is it? Is it a part of mental health or is it a part of something else? It's mental health, right? Yet, how many times do we ask our patients about loneliness? Almost never, right? And I think that is something where psychiatry really needs to do something. Go ahead. So how does loneliness work? Because again, there's a lot of research on the biology and genetics of loneliness. It shows that loneliness is a modestly heritable, polygenic stress with genetic predisposition to cardiovascular, metabolic, psychiatric disorders, triglycerides, HDL. That is why the mortality goes up. Loneliness is inevitably associated with lots of major illnesses, including heart disease, stroke, as well as dementia, depression, and so on. And the genes associated with loneliness are expressed in brain regions that control emotional expression and behavior. Why am I talking about that? Because it has something to do with what we can do to control loneliness. And that's my before that. So why has it been happening in the what is changing in the last 25 years? Three major things are happening. One is globalization. We all know that, right? the world has become a smaller place. You can fly from any place to another place in no time. Super fast growth of technology. Technology has been growing so fast, we have no idea, right? Where is it going? Social media. Actually, some people call it anti-social media. And we heard about children and they're going through a difficult period right now. That is true. Part of that is because of social media affecting children and adolescents. So all of these things, there are good things in some ways, but there are also bad things in other ways. Globalization increases the competition for any job that you do, right? Super fast growth of technology. People are losing jobs because the technology is taking over. And social media clearly have created much more stress and anxiety in people. So this is why we are living through a period of loneliness pandemic, which is as bad as the COVID pandemic because it is lasting forever. So what is the antidote for that? The antidote is wisdom. What is wisdom? So wisdom actually has been known since times immemorial. Many religions have that, in the long time period. But empirical research on wisdom started around 1970s at the Max Planck Institute in Berlin, and it has been growing fast. There is a lot of neurobiological and other research on wisdom in the last few years. By the way, the human species is called Homo sapiens, right? What is Homo sapiens? A wise person. This was a term devised by an anthropologist 200 years ago. Our society, our species is the most social species of all the species in the world. So humans are a social species where the social connections become important, right? So what is wisdom? So wisdom is a unique personality trait with specific components. The most important component is empathy and compassion. Also emotional regulation, self-reflection, acceptance of diverse perspectives, decisiveness, and spirituality. Importantly, wisdom is associated with greater personal and societal well-being. And that is where the question about AI comes into play. AI has been growing tremendously fast, no question about that. I think yesterday, Steve talked about how fast the different things are growing, and he said AI is growing 1,000,000 times faster than others. So why is it not reducing loneliness then? Because intelligence doesn't help us. Intelligence is not associated with well-being. Intelligence is not associated with social connection. What is associated with social connections? Wisdom, with its compassion component. Because compassion, when you have that, then there is a better relationship. Actually, in the previous panel, talked about the team sportsmanship. Why the people who participate in these team sports really grow up into better care, even adults, right? Because of the great social connection. That is something that is needed at every place, in every profession. Wisdom is a neurobiological construct, by the way. It is mainly the prefrontal cortex and limbic striatum, and these are also the regions that were involved in loneliness, and that is why it helps biologically. We and others have published a number of studies in the recent years showing that loneliness goes in the opposite direction as wisdom, especially the compassion component. We have published several cross-sectional studies with hundreds of people, and including one longitudinal studies of 1,200 people followed for 5 to 7 years. And these are not just clinical studies. Studies using EEG and gut microbiome. Even biologically, wisdom, especially compassion and loneliness, go in the opposite direction. And very recently, there was a study published from Hong Kong. It was a randomized controlled trial with 3 groups: wisdom support, empathy support, and a control group. And the interventions were administered by lay therapists who were trained. And they found that the wisdom intervention markedly reduced loneliness in the people, then the empathy intervention, and then the control group. And there are actually several other studies that have clearly shown that compassion and wisdom reduce the level of loneliness. So It's my last but one slide. So AI, as I said, as we heard from different people, is growing so fast. You know, there's something like 1 million people use ChatGPT every week if they have anxiety or depression or feel suicidal. Why? Because it is easily available. It is much harder to find a psychiatrist, psychologist. There are not too many of them. They cost more, right? And AI is growing very fast. However, AI is not doing anything to loneliness because intelligence is not associated with well-being. Wisdom is. So what we need is artificial wisdom. Is it possible? Today it is not possible. Will it be possible? Absolutely. Rapidly expanding large language models will help develop artificial wisdom in machines and robots. Of course, they won't have their own consciousness or emotion, but they can serve as therapists to assess and promote empathy, compassion, and other wisdom components. Of course, it needs strong interpersonal, professional collaboration and ethical oversight. And the AW therapies can potentially help billions of people worldwide. We don't have enough psychiatrists, psychologists, but we have enough chatbots in the world. By the way, is this feasible? So I wrote this paper actually in International Psychogenetics 5 years ago. Since then, I have been working with several AI experts. And we have I can't tell you more about that, but we have a paper coming out in a major journal that will show that artificial wisdom is feasible using the technology. And as I said, I can't tell you that because it is in 3 more weeks, it will be officially published, and then I can talk more about that. No, but this really shows that there is something we can do, we will do, we must do. So our goal is really to move today's lonely, distressed, polarized world into a happier, healthier, and wiser society. So thank you for your attention.
Questions? Getting my steps in again.
Interesting perspective on artificial wisdom, and I appreciate the premise of it, especially the connection, compassion, and passion. I guess my question to you is, what about human connection, the belonging to a community, and even physical connection? And I also speak as a survivor of a hemorrhagic stroke, and often we become very lonely afterwards. And it is difficult to reach out. And yet, that connection, that includes the physical connection, which is one of the reasons why dance therapy works, is so important. What would you say about that?
Very nice question, important question. I think the connection, when we talk about connection, that we need positive social connections, not the number of connections. Like social media don't help, right? But if we have like this team sportsmanship as an example, or family with good relationships, and neighborhood where there is a good relationship, those relationships will vary in the sense sometimes they are physical, sometimes they will not be physical. Sometimes they will be, but essentially, clearly there has to be a psychological positive connection. Sometimes it is actually physical, like or in the sports, etc. It is the quality of the connection where you trust somebody and somebody trusts you. You know that they will help you, they will help us. That kind of attitude is critical. And that is where, we talk about empathy and compassion. That we need to understand somebody else's emotions and help them accordingly. And likewise, they will help us. So it is bilateral, bidirectional. And so the connection varies according to what is expected from that person. But these social connections are critical. As I said, human species is social species. Human species will end if we don't communicate with one another and have good connections with one another. So that's why it is so important. The type of connection, of course, would vary depending on the species people.
Last question.
Hi there. A question on the genetic predisposition, nature versus nurture. So, if you're raised in a household that has the isolation, the loneliness, and all of those things parentally, but not biologically, is there a correlation still? Even though it's not potentially not like in my DNA, for example.
I think there is involvement of genes, but it is more from the epigenetic perspective rather than the genomic perspective. In the sense, the gene expression is affected by social connections, for example. And that is why you would often see good connections in families, for example. So part of that is genetically determined, part of that by the social and communicational factors, right? So studies have shown, and these are actually some of the terrific studies even in animals, showing compassion and social connection, that they are related to biology, but biology affects the social factors, and social factors affect biology. So it is bidirectional. Yeah.
All right. Please give Dr. Jeste a round of applause.
So our next talk is by Dr. Melissa Breimer, who's the director of the Terrorism and Disaster Program of the UCLA Duke University National Center for Child Traumatic Stress and its National Child Traumatic Stress Network. She will speak about restoring hope, addressing the disaster behavioral health needs for children and families.
Thanks so much, Helen. If folks haven't heard about our Child Trauma Network, we are a network funded by SAMHSA, and we have 193 centers across the country, and our national center is based here at UCLA. Normally, our network works really well together, except during March Madness. So things are kind of pretty tense right now. One of our sites is UConn. And I'm from Connecticut, so a lot of my family are trying to, put pressure on me about tomorrow's game. But I hope there's more fans here that want an upset tomorrow. Come on. All right, thank you. But in all seriousness, yeah, we know that games are going on today and checking our sports. But part of our Child Trauma Network is that we are dealing with all types of child trauma. But my segment of the work is dealing with those major disasters. I just want to do a little bit of clarification because we were having a wonderful conversation about ACEs earlier. And we were talking about ACEs and trauma. For our network, not all adversities are a trauma. And so we do actually make sure that we do a differentiation that trauma is something that is distressing, causes life threat, bodily integrity impacts, but not all adversities get up to the level of trauma. We also know that, and ACEs acknowledge it, that not all child traumas are in ACEs. So any of my work is not part of ACEs right now. And we do know disasters are something that's happening regularly and consistently and may be a trauma for some of the kids that are impacted by this. My work actually is changing right now because I used to be going into events that here's the disaster that I'm working with, but with climate change, there's no beginning and end. So we're really having to think about how do we think about brain health for something that's ongoing, something that's getting worse. And for many communities, they're actually having different types of hazards and impacts. So I had the joy of working with Maui over the last couple of years because of the wildfires in Lahaina. I'm actually working with them again now because they're experiencing flooding. So many of the folks that had evacuated Lahaina moved to the Kihei area. Those areas are the ones that are now getting hit by the flooding. So they may be losing their home twice now within a couple of years, one from a fire and now from a flood. So it's been really important for us to be thinking about how are disasters impacting our families and our kids. And, Helen said, can you do this in 5 minutes or less? So the impacts are greatly demonstrated in this documentation here, that with the climate change, there's a lot of, we know that our disasters are becoming more frequent, becoming more deadly, they're larger. So that means that we know that there's both those long-term direct impacts as well as those mental health impacts. But our youth are worried about climate change. I know I'm federally funded, I'm not supposed to use those words, but it is happening. And there is a concern about the future of our work. So it's been really important for me when I'm working with kids and families going into these communities. I can't be talking about from a PTSD, from a grief perspective. Those kind of terms don't mean anything. So we really have been looking at what are those interventions that we need to be really focusing on? What are those things that impact folks who have experienced either a mass violent event or a disaster? And so we really kind of have broken it down into 5 key components. When a disaster or mass violent impact happens, we know that safety is impacted. We might be worried about the safety of our loved ones, safety of our community. But even over time, safety can change. So as I'm working with Brown University after their December mass violent event, I'm now talking to them, hey, do you guys know that April tends to be a risk factor for college students on suicide? So are we touching base with kids who are in the epicenter of that shooting who might be also struggling with depression and hope right now? Are we creating a plan so that when classes end for the semester, they go home to their home community? What's their continuity of care? These are safety factors for some of the youth that we're working with. Thinking about what are those brain health elements of, we know that disasters impact people's sense of calm. So what is those level of distress? I'm so glad that we've been talking about sleep impact, but we don't actually talk about in disasters. Sleep impact is one of the longest lasting impacts. So if we don't talk about sleep hygiene and how you're sleeping, it actually impacts that overall health. We're seeing it in the data here. I'm really glad that throughout the conference we've been talking about connectedness. And you talked about, with our former Surgeon General, he not only talked about connectedness, but he talked about belongingness too. And so when we have policies and practices that don't make everyone who's been impacted by a disaster feel like there's a sense of belongingness, in fact, policies that say they can't get care, it's putting them more at risk. And so we're really thinking and having to, how do we help community members who may not feel like they have access to health care? They may not have the benefits of FEMA because of their legal status, their gender, or other reasons. And what are we going to be doing so that they get the support and the skill sets and services, even when there's this concern about their safety and mistrust that the systems are there for them? And that really making sure that any of our interventions and our strategies are thinking about their efficacy, the strengths that they're bringing to the table. And so earlier someone brought up the importance of culture. Any of the work that we're doing, we need to be making sure, how do we give breadth and space for indigenous practices, for cultural traditions that we know that can be helping the families cope, the kids cope, and to help them with their overall brain health, which leads them to say that, throughout history, there is hope. There is a path forward in doing this work. And so as we do disaster work, we really do follow that the public health model. And we've been really focusing more on that tier 1 and that tier 2. There are the evidence-based treatments. We have good grief and trauma treatments, both for kiddos and for adults. What we weren't as solid with were those tier 1 and tier 2 interventions. Questions have been coming up, well, who should be getting these brain health skills? Our philosophy is everyone, because I don't get to choose who's in a disaster. When a disaster happens, we all were through the wildfires here in LA. Whether you directly lived in those areas or you knew somebody, there wasn't any of us who didn't know somebody that was impacted, whether we supervised them, whether they were our colleagues, our friends, or we used to live there. So it's really important, how do we make sure that everyone has those tier 1 levels of what are those things that we all can be doing to provide basic support for those who are impacted by these types of events. We also know that even for tier 2, there are folks that now are still having some moderate distress, but they may not be wanting to get treatment. They might not be able to get treatment, but there are things that can be done at schools, at our clinics, our faith-based. We've been doing a lot of work in some other areas. Our local librarians who do psychoeducational classes all the time, they can be teaching basic skills on behavioral health. So there's a lot more folks that we can be bringing into this discussion of how to make sure that we're translating and providing these types of supports. So our network, we have a lot of resources for child-serving professionals, for youth directly. We know, and the data says, if parents and caregivers are functioning well, kids are going to do better. So we really need to be making sure that we're checking in and we're screening the adults in their lives, giving them the tools to provide that type of support. I don't have an elephant, but I have my buddies Trinket and Sam. So if you haven't met Trinket and Sam are ebooks that myself and my colleagues at UC San Francisco created. You don't want these preschool mice in your community because they've been through hurricanes, they've been through a tornado. The poor little guys went through wildfires, and yes, they went through COVID. But this is one way we can be having parents talk to their kids about, hey, here's what these events have done for our families. And through characters, we can then be talking about, here's some of the reactions you may be having, but then here's things we can do together to start to feel better, to start to heal. So using children's books is just one tool. We know that access isn't always there for everybody. So we've really been working on, are there some of these skills that we can be doing from a technology side? So Bounce Back Now is an app for both in English and in Spanish. Currently it's for adults, but we'll be releasing the adolescent version in hopefully in about 3 months' time. But this is an app for anyone who's been through a disaster or a trauma. Hey, let's learn about some of the reasons why I might be feeling the way I am right now. Here's some of those coping skills that you guys have all been highlighting that are so important to brain health. Are these things that you can be implementing? And there's some basic screening of, hey, is it working? Can you actually start to see improvements? So we can be using this in conjunction with our treatments, or sometimes if we're on a wait list or other things, people can be using these on their own. Psychological first aid, some of you may have heard about it and some have not. Psychological first aid is an intervention that the NCTSN with the NCPTSD co-created. This is an early intervention that has been adopted by all the federal government agencies as well as the World Health Organization. But we really wanted to look at, with psychological first aid, this isn't about who's diagnostic, but what are those elements that we need to be thinking about when our patients or those that are in a community have just experienced a crisis. So it's first really, how do we make sure we engage with them? How do we address safety concerns that might be coming, that they might be having because either they still have unknowns, the event might still be happening, or are they processing that their loved ones are either missing or are deceased in the situation? Some may need some basic stabilization. But if we want to make sure that people are getting their behavioral health needs, we need to make sure that their practical needs are met. Do they have housing? Do they have the food? Do they have the basic needs that they're needing to carry on? The social supports that you guys have been all talking about are so critical. How do we either get them connected to their former social supports or create new ones so that they can utilize those supports in this time period, as well as some of those basic coping strategies that you guys have been highlighting. It was brought up that California, there are a lot of great programs that are out there, and Shannon had started to talk about them. Together for Wellness is a website that both here at UCLA and UC Davis are the prime. This is a website that's in 13 different languages. Ken is here with me and my partner in crime in this, amongst other colleagues. But our youth are actually highlighting what are those issues that are most pertinent to them. And they recently had said, I want to know about, for example, what substances do for me. But now I have this knowledge. What do I do to help myself to get better? So we're actually created a coping corner so that we're taking out the coping skills that and they can actually start to learn how to help themselves through the website and trying to match that knowledge and then the skill sets so that they can become champions of brain health for themselves. It was brought up that California has what's called Saluna. Saluna is for adolescents up to 25, so with young adults. This is a free mobile app for anyone in California, a youth. What's important is this app does a lot of great self-education. It has a lot of these skills. But if a youth needs to talk to somebody, they can actually get peer coaching, and it's anonymous, especially in this age where some of our community members may not feel comfortable to be getting access to health care and mental health right now. They don't have to give any personal information at all. Bright Life Kids is for our younger, so it's for parents and for parents of kids under 12 years old. Again, there's a lot of great parenting resources, skills-based brain health, and there's a coaching aspect. All of this is for free. So how do we make sure that those that we're serving know that these resources are here for them? The other piece I wanted to be highlighting is that psychological first aid is just for acute care. But sometimes we still need to be thinking about that tier 2. So skills for psychological recovery is for those who might be in moderate distress. This is when I might have a little bit more time and space. It's usually a couple months after a disaster or even a year post like we are here in LA. What skills can help them get through this healing process? So they might need support for problem solving. So can we teach basic problem solving skills so that I can help them with their current adversity, but then they have the skills when other things come up? Help them to realize what are those self-care strategies that they need. Make sure that they're integrating positive activities that we know is important for our overall wellness. Managing reaction is another skill set. So with trauma, we know that there are times that we're doing great. Then all of a sudden we might have a trauma reminder, a loss reminder, or a change reminder. And then all of a sudden everything is flooding back again. So let's give people skills of when that happens, you can regulate your body. There's things that you can do so that you can actually control those reactions. And so that's where the managing reactions come in. Helping to build those social supports. After trauma, sometimes our relationships change. If I'm not my best self, I might have gotten some people upset with me, right? I might have to be rebuilding some of these social connections, or I might need new ones. And sometimes I need to focus on my overall thought processes. So the last piece that we work on is that, frankly, when we do this work, in all of us, what are we doing to make sure that brain health is for all of us? So I'm not an MD, but there's a lot of MDs in the room. And so sometimes you might prescribe medication to folks, and you might prescribe it as needed. So we have changed what as needed is in our philosophy. So as needed for wellness is pause, reset, and nourish. So I ask all of you to think about your PRN plan. So pause is really, I'm wanting everyone to take 3 breaths. 1, check in with your body. We hold in our stress in different parts of our body, right? The second breath is check in with your thoughts. What's going on in the brain? Is it full of clutter? Is it full of worry? And the third breath is checking in with your feeling state. So pause is literally 3 breaths. Check in with your body, check in with your thoughts, check in with your feeling state. Reset is what can I do throughout the day to keep myself steady, to keep myself grounded. Many times when we're talking about stress relief, we focus on the big things. As Helen would, we've gotten to work a lot together in the department. Sometimes the smallest things can help us to feel grounded. Just saying gratitude to a colleague, for example, to our colleagues that have organized this amazing conference, they deserve support. When we give gratitude to folks, they get that praise, we get it back. Sometimes even just holding a drink, whether it's hot or cold, that sensation can be helpful. So thinking about what are those things that we can be doing to reset so that as we're going through the day from patient to patient, client to client, we can be that calm, steady person. And then we always need our nourish. What are those things to really do that have those fun times, come together with your family tonight, having some drinks, having some jokes and celebrations, and remembering why we do this work. When we go, remember our why, it helps us to be sustainable. So I appreciate everybody, and here's some of the, all of our materials are on our website. So thank you very much.
So before we pause, reset, and nourish ourselves with a coffee break, any questions? More steps. I like it.
A little dancing too to your step as well. I like that. Thank you. I was looking forward to your presentation today. Being that I am with LA County and also co-chair for the TAY table, thank you for showing the Saluna app. We are using that app county-wide and we are promoting it widely. Thank you for your support to our staff in training and supporting our volunteers as well during the Eaton fire with the psychological first aid. My question is this, and it relates to our, someone asked a question or comment of who's responsible for the trauma-informed approach, and I would say we all are in this room and beyond. But one of the questions I have is preventing ACEs. And so when we were one of the organizations to respond to children during the Eaton fire with the 5 care camps. We served 2,700 children. Thank you. We're with UCLA here launching research on this to see the impact. And one of the questions we have about Care Camp, and quite frankly, thinking about our other youth prevention programs from teen after school, we have many kids that live in areas where there's high violence, and we have this Care Camp. One of the questions that I would say that I'd like to continue to work with you all on is preventing ACEs, and do these programs, in fact, after a traumatic event, a shooting, a fire, if we have early community intervention and trained trauma-informed staff, is the research showing that, in fact, we are reducing the chance for ACEs and lifelong challenges that we've been discussing during this whole conference?
It's moving in that direction. I never want a disaster, and especially the mass shooting part of my job, I want it to end. But there's also an opportunity because resources get poured into communities that have these events. And then what's happening is we're finding kids who have experienced past trauma that no one has ever known about. And so my hurt in all of this is, why does it have to take a Sandy Hook, a LA fires, for us to be having these conversations, to making sure that everyone in a child's life understands about child trauma. And I am still always asked the question, are we traumatizing kids by asking them the questions about it? And when kids talk to me, they're like, you're not traumatizing something that I went through. You've just told me it's taboo that no one asked me the questions. So we have to get more comfortable, and that's why I am thankful for all the work that you guys are doing. So one, to make sure that we're teaching everyone about screening and how to talk about this. But we need to do a better job of continuing to talk about what is child trauma, and then also making sure that they're getting the next step. I don't think we're still there. I think prevention is not something that we are good at in this country. We do try to make sure in these moments we get to really bring in a lot of trauma-informed perspectives. And you have to admit, after our fires, we've even gotten more support in this. I wish it was before the fires, though. So I guess there's a hit or miss. I don't think we're where we need to be yet to really say that we're really bringing down those numbers. But when kids are being treated and they are getting the support, we know that does prevent them from experiencing other types of traumas. So there's kind of a yes and but kind of thing to your question.
Next question.
Hi, how do you incorporate resilience in your work, and how do you define it in what you do?
I struggle sometimes with the word resilience because, and I'm not saying I don't feel like kids and families aren't resilient after disaster, but at least after mass violent events and disasters, people like to say the community is strong, the community is resilient. And what I am finding is that it's actually putting a blockade of us doing the work. So, Maui was considered, all the kids were resilient. And I was like, how do we know that? Well, they're coming to school. I go, that still doesn't mean that they are resilient. Can we do a trauma screening? And after the trauma screening, it was pretty amazing how many times the teachers were like, you just caused them trauma. I'm like, no, they answered what they're going through. So sometimes we're using that word resilience and we're actually avoiding doing the hard work. So I try not to starting off with resilient. Do I feel like there is that pathway that kids are resilient and that I use their strengths? So many times, and we had this, Shannon, a discussion in the hallway, what's those things that help you in those hard times? Can we help you to use those aspects now? What do you need? What's those support systems that you need? Those are all factors that help with those resilience. But I tend to not bring up the word resilient because sometimes it's misused, and especially for different populations and especially populations of color.
All right. Yeah, last comment.
I was just going to share, just as an example, sort of the mixture of disaster and resilience. When the LA fires occurred, one of our homes was completely burned down that one of my children lived in, and Melissa had publicized the cartoons and things like that, and I shared them with my grandchildren, both those who were directly affected and those who were not directly affected. But you know how hard it is when your cousin loses their home and so forth. And within a day, it had a huge impact on their ability to move forward. And then they asked me to share more. So I shared the 7 strategies or the 8 strategies or whatever, and they said, I'm going to share this with my class. So I think, and these were little kids. So I think, it's really helpful to have these kinds of resources available. So I would encourage, if it happens to you, get the cartoon.
Let's please thank Dr. Breimer for a lovely talk. So we will now nourish ourselves, come back in 10 minutes, and we'll kick off the next panel.
You can just, we're just gonna have you guys. Karen. Go be careful.
How long do we have to talk?
Like, it's, what was it? There's 4 of us, so 15 minutes each with 15 minutes of discussion. Yeah. Yeah, at the end. Yeah. Okay. And I'll introduce you. And you only have 3 slides. Some people have more, but you can just talk for that. And I'll tell you like when it's yeah. You're first. As you're sitting, I think. So Sahib, is this the order then? Is this the order? All right, everyone, we're in the final stretch here. We're excited. We've, last but not least, we've got the innovations panel. So we're very excited to have this amazing group of folks. And thank you for continuing to be excited about this area. And we're just about an hour and a half left. So stay with us. So it's with, I see Janine back there. Very excited. So it's with great pleasure that I introduce our first panel member, who is one of my closest friends in the world, Terry Sanger. Dr. Terrence Sanger is a pediatric neurologist, engineer, and professor of biomedical engineering and neurology at the University of California in Irvine. He is a Renaissance man, as you will find out from his talk. He is brilliant in so many different ways. Electrical engineer, he's just a robotics expert, and really an amazing proponent for children with sometimes historically what would have been thought of as devastating disease. So we're excited to hear from you, Terry, and thank you for joining us.
Yeah, thanks, Indu. I have to live up to the introduction somehow. Yes, I'm Terry Sanger, and I'm a child neurologist. I work at, well, Children's Hospital Orange County, now Rady Children's Health Orange County, and I run the movement disorders program. And this is a picture of the kind of child I see. I actually see somebody I saw almost 20 years ago. Has subsequently passed away. She has a disorder called pantothenate kinase-associated neurodegeneration. That's not, the important thing here is the nature of the dystonia, which is this very, this very severe loss of control over muscles. One of the ways to think about it is that dystonia distorts whatever it is you're trying to do. So it takes the muscle pattern that you're trying to do and turns it into a different muscle pattern. So most of these kids, when they lie down, they can relax and the stuff mostly goes away. It's just anytime you try to move, you get something that isn't what you want. Actually, it's beginning to look like, in many cases, you get the opposite of what you want. As you try to reach your arm forward, the muscles in the back of your shoulder tend to activate. So that there's a lot of, almost a reversal of volition. Something that I find very interesting, because there are disorders where you get different types of reversals of volition in certain other neurodegenerative disorders, and I may talk about that in a second. So she was a child who was seen down at Texas Scottish Rite Hospital as part of a group that we were looking at a number of different children and the way in which we can do diagnostics in these children. That's Mauricio Delgado, who's one of the child neurologists down there. So the interesting thing about this particular disorder is that her cognitive function at this time is probably normal. And so we've been talking a lot about the cognitive issues and brain health and trauma, and I don't know what it's like for a child who is trapped in this way. And this disorder has its onset about 5, 6 years old or so and progresses. Most of the children die by the time they're in their mid or late teens, but there's a great deal of variability. And there is a dementing process to this, so they do become demented over time. There is a cognitive loss, but that's relatively late. And until we had treatments for the motor components of this, we didn't know that. So one of the things that we're starting to realize is that as we improve the motor components of this disorder and others like it, we start to uncover the dementing processes underneath. which, and hopefully as these children survive into adulthood, it will now become the domain of dementia experts. And so, which is something I know very little about, but I'm hoping that there will then be interaction between these very multifactorial diseases that we never expected. I remember the first time when I was in medical school and met two very, very severely handicapped sisters with cerebral palsy. Before walking into the room, the orthopedic surgeon, whose clinic it was, told me, you know, don't be fooled, they're smarter than you are. And they couldn't speak. But if you sit down and start talking to them and try to communicate, often with assistive communication devices, you realize how quickly they can type using their eyes or head switches, and the level of sophistication of some of these children. So that's sort of the background. Now, what do I do? I believe in deep brain stimulation. This is an example of the kind of setup we use for deep brain stimulation. So deep brain stimulation has been used a lot in Parkinson's disease, and one of the reasons I'm talking about the relationship between this and dementia is that Tony Lang, one of the greats in movement disorders, gave a lecture, it's probably almost 25 years ago, in which he said, now that we can cure the movement components of Parkinson's disease, we need to start focusing on the cognitive components. So I think and whether or not we truly have achieved cures of the movement components of Parkinson's disease, I think it is important to recognize that as we peel away symptoms, we uncover other symptoms underneath, and we always have to be looking for that. So one of the things that happens in deep brain stimulation, particularly in children, is that children are a heterogeneous group. So we don't know, the etiologies are very different, right? Parkinson's disease also has many different etiologies in adults, but it turns out that there are a few brain areas in which if you put electrodes, you can make a fairly significant benefit. In children, if you put electrodes into those or the other standard areas, you tend to get about 50% of the children have a clinically significant benefit. And what we've known for a long time is, just as in real estate, location matters. And the point is, you need to figure out where do you put these electrodes. And so a procedure that I developed working with Mark Krieger and Mark Leiker and several of the other neurosurgeons when I was working at Children's Hospital Los Angeles involves borrowing a technique from the epilepsy world, which I think is way ahead of us, in trying to do really the aspect of sort of personalized deep brain stimulation, which is, we don't know where to put the wires, so let's put them everywhere and find out. My doctoral degree is in electrical engineering, so I apply currents and measure voltages. That's what I do for a living, and whether it's a brain or some electrical device. So this is an example of a child who has 10 different leads in their head. Each one of those things has 16 contacts on them, so we have 160 channels in the brain. That sounds like a lot until you realize that we're dealing with 100 billion neurons. So it's a little bit of an undersampling problem. Nevertheless, it's better than anything else we've got. And then we can watch these kids in hospital for a week and do stimulation testing and find the right locations for all of this. So this is a picture drawn. The mom wrote the purple words. The child drew those pictures with stimulation on, and that allowed her to draw those pictures. She was 7 at the time of this. So we do this in an attempt to really find the right locations and make a difference. Now, it's not a good enough difference, but it's better than anything else we've got. The medications that we have available for children with dystonia are poor. And they will make a little bit of a difference, and it's not that we don't use those, and we always test it, and there's some children with mild disorders who will do okay with that. But if you really want to make a difference, a clinically significant difference, however you're going to define that, then this is really the only thing we've got right now. And orthopedic surgery, for that matter. I mean, there's if joints are tight, we can make differences. But these are very mechanical, outside interventions. Now, this is, in some ways, a very mechanical inside intervention. And one of the things I want to point out about this is a symptomatic treatment. This never cures a disease, right? I cannot cure pantothenate kinase. The first child I showed you did not receive deep brain stimulation. That was early on when we were still looking at these, but now we have children that do. I have a child who had been unable to eat and had his mother had to do the Heimlich maneuver many times because he would keep choking every time he would try to eat. And we were able to find a place in his brain that caused him to be able to eat. So much so that while we were doing the testing, we'd walk into the room and his mom would bring in these piles of food. I mean, just the burritos, the steaks and stuff. And we said, "What are you doing?" And she's like, "Oh, well, he's only here for a week. It's the first time he's been able to eat in 2 years. I'm going to fatten him up right now," right? And afterwards, we put the permanent leads in. We have that same benefit. Now, it's a degenerative disease, so we can't stop the process. But you can make people's lives much, much better in the meantime with these things, and that becomes very, very important. And really what I wanted to talk about here and just raise this issue is that in the world of neurosurgery, functional neurosurgery is a relatively new concept. It's not that new. I mean, you can date the earliest examples of deep brain stimulation to the late 60s, early 70s. So I guess in that sense, it's a 50-year-old technology. But I think the things that are happening now, the ability to use advanced electronics, better materials, better battery systems, really allow this to become a lot more effective. And I think that this is going to be effective as a very different and sort of almost orthogonal intervention to many of the things that we do in neurosurgery. I'm not a neurosurgeon, I'm a neurologist, but some of my best friends are neurosurgeons, and we work very closely together on this. Now, a lot of neurosurgery is, take things out. You've got a structural problem. You've got a tumor, you got too much fluid somewhere, you got too much blood somewhere. Let's remove that, right? It's very physical and structural. This is functional. This is saying we care about what the brain is doing, how it's processing information, how it's going to move information from one place to another. Can we modify that? Can we make a difference in the way it actually processes? In situations where you can't fix the underlying problem. The vast majority of children in my practice have some form of hypoxic ischemic injury. I cannot fix that. There's no genetic therapy that's going to go in there. There's no chemical that's going to, those cells, dead cells are dead cells. Maybe someday stem cells, maybe, right? But the point is probably not in the lifetime of the children that I'm working with. So all we can do is try to fix the function in some way. And I just wanted to sort of point out just some of the sort of the theory around this. We call this stimulation, right? But again, I've got 160 channels, and when we put the final permanent leads in, we've got 32 channels in something that is one of the most complex information processing systems ever seen. I would say one of the, because elephants have about 5 times the number of neurons that we do. So I don't know who's got them. Speaking of animals, we have to introduce elephants at some point, right? But the point is that if the complexity of the intervention doesn't come close to the complexity of the thing that we're trying to do. But what it does do is, opposed to medication, which is biochemically specific, but localization non-specific, right? Anywhere blood goes, the drug goes, right? This is location specific and biochemically non-specific, right? We depolarize everything. And in fact, for the most part, we don't know what we're depolarizing. So it gives just another way of attacking the problem. It's the same kind of thing we do when we're dealing with people with high tone. I can give you a medication, an oral medication like baclofen. It goes everywhere in your body, might loosen up the muscles I want to loosen, but also loosens a bunch of other muscles I didn't want to loosen up, right? So what do we have? We have botulinum toxin. I can hit specific muscles, right? So it's the same kind of thing doing that within the brain. It is important to realize we cannot give back. So I cannot, with this, make you coordinated. I cannot make you strong. I cannot make you clever. I can get the things out of your way that are making it hard for you to become coordinated, and things that make it hard for you to become clever or to become stronger. And that's really what you're trying to do. You're trying to get these things out of the way. The fundamental principle that I try to explain to the parents is, if the brain could have done it by itself, it would have. The brain is very, very plastic. We all know that in children you can remove very large parts of the brain and have almost no symptoms. Children can be born with very complex malformations and have almost no symptoms, right? The brain has tremendous plasticity in it. And so it is designed to deal with a large number of injuries. So sometimes, what all our goal is to do is to say, okay, when the brain gets screwed up, either when the recovery mechanism itself is injured or when there's something else that is preventing that system. Epilepsy is a great example. Too much signals flying around. If you can get those signals out of the way, you can allow language development. So it's about getting things out of the way. So and I really want to be cognizant of time, but I think the point is just the excitement to me of this technology is I really think it's a new way of looking at brain disorders. It has its limitations, of course it does. It's not the cure for everything. In fact, it's probably not the cure for most things. It's just something new. And I think we really need to be able to figure out how to use it. I think the technology is there. I'm working with people who are trying to design our own stimulators. There's people who are trying to design their own electrodes, really trying to pull this together and say, what would it look like if we could really not just personalize where we stimulate, personalize how you stimulate, whether we're using it for movement disorders, whether we're using it for psychiatric disorders, whether we're using it for sleep, for pain, for obesity. There are lots of places in which drug addiction, right, there's going to be lots of places where we can make a difference for this. My vision for this is that this is an ongoing sort of research and clinical process. It's one of the things that I'm very excited about doing is building research-grade deep brain stimulators. We can put these things in, and now people are walking around with personalized stimulation. But as things change in time, as we learn more about the right form of stimulation, as we learn more about them, as their stimulators are analyzing their own activity, these things could change and get better with time, so that the thing adapts to them. The brain is adapting to the stimulator. Stimulator should adapt to the brain. We should be able to take that information, give it to other people. Everybody becomes their own walking experiment with the express purpose of always trying to optimize. This becomes particularly important in children. There's a lot of plasticity going on. Plasticity works against us. The brain does not like having wires in there with 5 volts on them. The brain goes to a lot of effort to shut this stuff down. We need to work around that. We need to figure out how to work with the brain and the electronics together to make a better functioning child or adult. Anyway, I'll stop there, and thank you very much for having me here.
That was so cool. Next we have Brennan Spiegel, Dr. Brennan Spiegel, who is here from Cedars-Sinai. He is the Director of Health Services Research at Cedars-Sinai. He holds a chair in digital health ethics. He has a very cool background. He's actually, I believe, a gastroenterologist, but he has sort of this spanning of work from medicine, behavioral science, and emerging technology. So we're excited to hear about his thoughts on innovation in the future.
Okay, well, thank you very much. It's a pleasure to be here today. I'm starting with a picture of me with a patient with permission who is contemplating at this moment whether or not to use a virtual reality headset to manage her chronic pain, which has not gotten better with a number of interventions. And I'm going to talk more about why would we use virtual reality. We've now used it in well over 3,000 patients at Cedars-Sinai, and what exactly is it doing for pain, anxiety, depression, and so on. Most people, when they think of virtual reality, they think of these headsets. They might imagine kids playing first-person shooter games in their parents' basement or something like that. It is considered to be a platform for gaming and entertainment. But long before Mark Zuckerberg knew anything about VR, this technology was being tested in psychology labs and cognitive science labs all around the world, and starting in the 1960s and even late 50s. And it was becoming very clear that it had profound effects on the human mind and body, as we'll see in a second. And the idea of virtual embodiment to change the mind-body complex has become an actual reality, and there's now a branch of the FDA dedicated to the field of medical extended reality, or MedXR. Now, to orient you, I'm going to show you the very first time that I used virtual reality. We actually have it here on video. I was asked to stand in 2016 on the side of a window washer rig, and I went up the side of a 50-story building. And this is literally my first-person view. I can hear the sounds of cables creaking, I can hear the engine running, and I'm looking around taking in this virtual world, and I can literally feel my real body, not my virtual body, becoming, intense. I had sweat beating in my hands, my heart was starting to palpitate, and I'm a little bit afraid of heights, but at least that rail was there, so I can sort of just lean over gently and take a nice look at some of the details, like the dents in the gleaming steel and those splats of paint. And then they released the bar, and it falls 50 stories down. It smashes on the ground. There you go. And I realized, oh my God, this is an existential moment. Like, I'm going to fall and I'm going to die. And they said, listen, just go ahead and jump off. And I said, no chance. They said, but you know your feet aren't carpet, right? I said, my feet know that, but my brain doesn't know that. Like, my brain thinks I'm about to die. And the only way I was able to do it is I had to cheat. I had to break the simulation and see a little bit of carpet through a sliver underneath the headset, which broke the illusion of being in this simulated world enough so that I could live in real reality, or RR, for one moment, throw myself over this building, fall 50 stories, and a complete whiteout. Thank you. And I thought, man, if we can use it for evil, there must be a way we can use this for good. And that's what we've been doing ever since. This is one of the 3,000 plus patients that we've used VR in the hospital. This is an old picture because that's a Galaxy S7 phone snapped into a Samsung Gear VR headset, which doesn't exist anymore. This patient has sickle cell anemia. Severe pain. Moments before we took this picture, was doubled over in pain. But at this moment, he is flying in a helicopter over fjords in Iceland. And you can see the emotional experience on his face. And this is one of 3 psychological concepts that we work with in our NIH-funded research to study medical extended reality. It's the notion that emotion matters. That's not lost on anyone in this room. If you think about the most profound memories of your life, both the positive and regrettably the negative memories, they were all tied to some strong emotional experience. That's what burned the memory into your brain. That's how we learn things. That's how you can learn something right now, by hearing a story and seeing a picture rather than bullet points on a screen. That's how we learn things. That's how all of human history, I'm not saying anything about anyone's slides, by the way. I have plenty of bullet points too, just wait. But all of human history was conveyed through stories and talking and emotionally valenced experiences. That's how we learn. And that's how virtual reality deeply changes the human mind if it's used in the right way and the right time. This is a picture of me with Dr. Omer Liran, cognitive neuroscientist, psychiatrist, computer programmer, AI expert. We're using here VR. There are embedded sensors. Those sensors are measuring heart rate variability, pupil diameter, eye tracking, and calculating the cognitive load minute to minute. And then we use an AI system that changes the virtual world around the participant to keep up with their biodata. And I'll show you in a second what that looks like visually. But this is kind of this notion of escape. And just look at those cables in the foreground. It's sort of metaphorical. It's as if she is surrounded not only by the 4 walls of the hospital room, but the 4 walls of her biopsychosocial illness experience. To give people a sense of escape, to give them a sense that they can go beyond those 4 walls even for a second, is vital. And this is how we do it. We use VR software like this. This is called Trip VR, have nothing to do with the company. You can get this easily online through the MetaQuest store. It's very inexpensive. It's called a cyberdelic. It's sort of like a psychedelic. It may, in fact, inhibit the default mode network. There's been some functional MRI work with magnet-friendly head-mounted displays to look at what's going on. And here's another patient. In fact, he is now my yoga instructor, and it's actually true. We did yoga this morning. His name's Harmon Clark. He's also one of my graduate students, but long before that, he was a patient in the hospital, and he has Crohn's disease, had over 200 days in the hospital one year, and he's, again, allowed us to show his picture and his image, and he likes to go in outer space. And he goes in outer space, he says it gives him a sense of awe and wonderment. He says he feels as if he's part of something greater than himself when he's in the hospital in outer space looking back upon the planet. And he says it gives him goosebumps. And this is a biomarker that we can actually measure of awe, and this has been studied. Are you awed yet? How VR gives us awe and goosebumps. And this is a study from Simon Fraser University in British Columbia, where they took research participants, put them in VR, flew them over their city first, Vancouver, then over the Canadian Rockies, and then blasted them up into space where they looked back down upon the planet. And all along they have this experimental setup, and they have something called the Goose Cam, which is a camera entrained on the forearm measuring the onset of goose flesh as a biomarker, and have found this sort of dose-response relationship between the onset of being in space and looking back upon the planet and the rise of the goose flesh, which is what astronauts in the International Space Station report, which is now called the overview effect, this sense of awe and wonderment. It's interesting because awe and fear and related experiences like music and beauty all create chills. Why does fear cause chills and awe and beauty cause chills? Well, the notion is it's all about your mental relationship to that. Depends which portal of the space station you're looking out of. If you're looking at the Earth, it seems like something beautiful and wondrous. If you look out the other portal and there's vacant space, you feel an existential crisis. They both give you chills. And so it's an interesting psychological concept, awe, and one that's very important to think about. So those are the three concepts, emotion, escape, and awe, and I now want to show you an actual experience with one of my patients who has irritable bowel syndrome. I'm a gastroenterologist, so we're very interested in the brain-gut axis. And this patient is in this room. You can't see them, but I'm showing you two computers. On the left are the biosensor data, the cognitive load, which is an integrated unified metric that looks at several outcomes, pupil diameter, heart rate variability, and so on. And on the right, this patient is on a beach. That's where she wanted to go. It's very hard to tell what it feels like on a two-dimensional screen, but she feels like she's literally present, floating over water. This mandala expanding and contracting in lockstep with her breathing. And when she first came in, she had a very high cognitive load, and it just collapses as soon as we started the VR. And you can see it right there. And as it collapses, although you can't see the arrow, we thought she was hypnotized. We thought she was asleep practically. But we can see with the backward-facing cameras that her eyes were open. And we asked her, "Are you okay?" And she was crying. And she said, "Yeah, I'm in heaven with my son." It turns out her son died 6 months before this video, which you can only imagine significantly worsened her IBS symptoms. And we said, "Do you want to come out?" She said, "No, I don't." And about 12 minutes in, which is near the end, she said she was in the presence of God. And this is not uncommon. We see this quite frequently with our patients, that they have almost a religious experience. And we take the headset off, tears coming out. She said she didn't have any pain. She felt as if she had been released, like her nervous system had released its grip upon her, is what she described. Like she was floating up, like literally like high, right? Like a psychedelic makes you high. That's an explosion of serotonin in your brain, making you literally feel anti-gravity sensations. And so she felt that way. And what I always do when this happens in my clinic is I use The Glass Brain by Adam Gazzaley at UCSF. This is actually his brain, by the way. And he made this amazing image showing the higher order networks in the brain. And I show this to my patients clinically. And I say, what just happened in your brain? Because the brain's not like a block of Play-Doh that rattles around in your skull all day. It's a shape-shifting organ. We just talked about how plastic it is, like any other organ in your body. And yours just changed. Now, we didn't cure your IBS just now, but something just happened. And if we work together for the next 8 to 12 weeks, we have this home-based VR daily therapy, which is a form of cognitive behavioral therapy through these generated reality, AI-enabled environments. It allows the potential to change your brain over time. And I say that even when we are in physical distress, we can still modify how our brain perceives our body. Now, so far I've shown you two experiences, jumping off a building and this kind of cyberdelic world. We recently worked with Mount Sinai. We did a randomized controlled trial where we put people either in the kind of scary jump off the building experience or in the relaxing cyberdelic experience. And then we measured all sorts of biomarkers. And this is just a little quick view of it. We looked at their heart rate variability. We looked at cortisol, circulating cortisol levels, white blood cell count. We looked at body temperature, respiratory rate. Everything changed within 15 minutes. White blood cell changes. I mean, that's the craziest thing to me. It demarginates white blood cells as soon as you start feeling like you're going to jump off a building. And the body temperature changes. This is virtual reality, but it's genuine reality. Now, this may have bigger philosophical questions, like are we in a simulation right now? Right? Is this all a simulation? And this is a simulation within the simulation? Because whatever it is, this simulation definitely changes real reality such as we understand it. Now, we can get philosophical some other day. I was a philosophy major. So VR is genuine reality, and when we use it to recalibrate unhealthy perceptions, it becomes a radical new therapy to improve quality of life. And this was shown all the way back in the early 2000s. You can see this very low-resolution experience called Snow World. This is from the University of Washington, very famous research. from Hunter Hoffman. And here he took people with burn injuries who are undergoing bandage changes, extremely searing kind of pain, and he randomized them to just play this fun game in this snowy, cool environment to sort of metaphorically countervail the searing pain of the heat of the pain they were experiencing. And in one of the most famous studies shown here in a randomized trial, they showed with the black bar, the VR condition, that not only was the sensory component of pain lower, but so was the affective and the cognitive components of pain. And then they had this curious outcome called fun that they measured, and they also found people had more fun playing these games while they had less cognitive, emotional, and physical pain. And what's very important is they did functional MRI research over the years, and you can see, the signals in both the sensory cortex and in the limbic system and the insular cortex. We all know pain is not just a physical experience, it's a biopsychosocial experience. And what's amazing is the VR appears to reproducibly tamp down the signals in both of those locations, the sort of sensory and cognitive centers. Now, we had been studying this research at Cedars and decided we needed to do this just pragmatically in our hospital. And so we started using virtual reality about 10 years ago, giving people access to this software. Here, this patient is reaching out to a blue whale swimming across her visual field. And we did a lot of work just talking to our patients and finding out what works and what doesn't work, and doing qualitative mixed methods research, found that they really, really enjoyed it and had very specific preferences. Some people just wanted to, go like on a safari, or wanted to, go to Hawaii, but others had really interesting ideas about cognitive behavioral therapy, and we ultimately made a program called the Virtual Medicine Program with a clinical service, and we moved this cart around the hospital. It has a whole bunch of equipment on it. We did a randomized controlled trial looking at pain in the hospital, looking at VR versus a two-dimensional control on the television screen with health and wellness programming, and found reductions in pain. Both in all patients and particularly in those with the most severe forms of pain, scores of 8, 9, or 10 out of 10. Now, most recently, I'm going to end with this. We've been advancing to some of the new headsets. This is the Apple Vision Pro. It has 23 million pixels and 8K display, and what we can do with this is just ridiculous. This is very expensive, but it's a beautiful experience, and now we integrate artificial intelligence. And I'm going to show you this video. This is not vaporware. This is actually what it looks and feels like. We give this to patients in the hospital or at home. That music is actually generated by AI. And this is a robot called Zaya. She's a HIPAA-compliant robot with over 150 different facial expressions. She provides mental health support across different forms of psychotherapy. Depending upon what she hears and what she sees, she will change the environment using something called GR, or generated reality. And she has different, she'll make eye contact, she'll look away, she will pull back and move forward depending upon the success of the therapy. She scores it automatically as she moves through the experience. She might make a bioluminescent forest or whatever. We wrote a paper in Nature Digital Medicine validating this qualitatively, and I was blown away by how powerful this seemed to be. And it was actually our therapists that helped us develop this software. By no means to replace any humans, but to actually help them as a paratherapist, because at the end of this, she literally writes a note, and she puts that note right into the chart. And the note is spectacular. And then the human walks into the room and has the full note written, and we're doing this literally right now. And we do this routinely at Cedars-Sinai. So I'm going to end there. We have a conference. It happens to be next week. Every year we do a conference called the Virtual Medicine Conference. This year it's Wednesday and Thursday. It's at the Hilton Universal. And the way I think about it is we put a bat signal up into the sky, calling the most creative health technologists in the world to convene in Los Angeles and show us what they're working on. And it's like my favorite conference. If you want to learn more about this, I wrote this book a few years ago. It's called VRX, How Virtual Therapeutics Will Revolutionize Medicine. And since we're in Hollywood, I'm going to end with a scroll, because this is very much multidisciplinary research. Lots of different people work on this kind of stuff. So I'll stop there. Thanks so much for the opportunity to be here.
That's very cool. All right, so we'll keep going. Professor Ruth O'Hara, she has come here from Stanford, so we're having representation from all over the state of California and also across the country. So she's a professor in the Department of Psychiatry and Behavioral Sciences, and she works at the in clinical and translational science at Stanford. So she has a very interesting sort of background, and we look forward to hearing from her.
Well, I have to say it's going to be hard to follow that. It's, you know, we had a lot of dad jokes today, but I actually am reminded at times like this of something my father used to always say to me. My father passed away in 2000, and he used to say, you know, he really appreciated memorials, weddings, christenings, those events and celebrations, because he said it reminds us of the important things in life. And when I was asked if I could join this week, I really did a lot of thinking about how things have changed since I was fortunate enough to be here at UCLA. I was what they call a special fellow. I came from USC, where I had taken my PhD in cognitive psychology, and found a very receptive home here at the MPI, where I stayed for 5 years, and really it forged the rest of my career. And I was looking back, and I know today we're focused very much on this panel on what is the excitement of new technologies and what they bring, and it is astonishing. But I do think it's important to remember also how far we've come. When I came in 1990 to UCLA, they had to make a special designation for me. I was a non-clinician, so they called me a special fellow, and I was fortunate enough to be in a class of other fellows, MDs mostly, and Helen was one of them. And we were very focused on that time on cognition in Alzheimer's disease. But it was really at UCLA and with that group that we started to understand that actually cognition was a core component of psychiatric disorders. And we started that in late life, looking at depression. Depression, when I started, was called, cognition in depression was called pseudodementia. And it was really Dilip Jesti and other colleagues across the country who started to recognize how important it was to actually measure cognition in the context of psychiatric disorders. I just want to make sure I'm moving this on correctly here. Did I get that right? Marvelous. And it was very innovative. And it's a measure that in the DSM-5, which came out many years ago now, that in fact cognition is routinely referenced as a core symptom in all sorts of disorders across the lifespan, including psychiatric disorders. And at the time, it was kind of almost blasphemy to say that cognition was part of schizophrenia or part of depression. The other thing that was really amazing at that time is it preceded fMRI as we know it. So when we talk about technological advances, actually one of the most significant occurred here. You had the wonderful Dr. William Oldendorf, who actually really forged the field of neuroimaging. And then on top of that, people like Mark Mandelkern with PET imaging over at the VA here, West LA VA, but also John Mazziota. I mean, amazing, amazing individuals who put fMRI on the map. And we are where we are today in mental health in particular, but also in all of our neurological disorders that are brain disorders because of the work that they started and did. So much of it led to here. So what is the future for us? Well, the future is to build upon that legacy and bring together, and we heard it so often today, multimodal assessments that actually can synergize. We heard about sleep in the context of autism, but that's one siloed area. We heard about cognition in the context of epilepsy, in the context of so many brain disorders presented today. And I just want to talk a little bit about what does it mean to actually have good brain health. I was very fortunate that I had a great mentor, albeit not at UCLA, in Dilip Jesti. And Dilip really had us sit down and think about defining what it means to actually have brain health. It's not just an absence of dementia, it was so often perceived at that time when we were starting off in the 1990s. It is sustained cognitive, emotional, and physiological resilience. Dilip actually developed one of the first attempts to define successful aging. He had a 45-page survey that we all actually contributed to and took by hand. And I asked my mother to beta test it. She was 75 at the time. And she said to me, did Dilip Jeste fill this out himself? As she got towards the end. But the most compelling component of that was that the significant factor related to your sense of successful brain aging was your cognitive function. And so we know it's really important. Over the years, we've seen really increased understanding of the neurocircuits that subserve psychiatric function. Many of these actually overlap with circuits that subserve cognition. And we know that we still are at a point where for many individuals, particularly in the field of depression, where we have so many who still don't respond to standard either pharmacological or even cognitive behavioral therapies, that it may be that some of the challenge is because of the cognitive deficits that they're experiencing. Sleep, however, can be a very modifiable factor. A lot of us don't have good sleep hygiene, and particularly now in an era where many take their phones to bed in the evening and they have actually impaired sleep because their melatonin isn't coming on board because the light is actually suppressing it. There are a lot of simple things you can do to enhance sleep. So we've argued over the years that sleep, cognition, and psychiatric symptoms really should be considered together. So on the face of it, we have the technologies to do this. And so you might say, well, that's very easy. Well, of course, one of the challenges, and even if you think about today, this synergy that we're all proposing in our talks, how do we actually achieve that? In fact, when we first started to get the data from fMRI about all of the neurocircuits, both default mode network, but also activated neurocircuits, it can be quite overwhelming. There are so many. The brain is connected in so many different ways. And I was very fortunate to meet a psychologist from Sydney, Australia, who led their brain disorder center there, that said, you know, at the end of the day, we can probably boil this down to 6 really impactful circuits that underline the neurobiology of depression, and that's where we should start. And this is Dr. Leanne Williams. We stole her over to Stanford. She came on board and she said, not only should we start with these actual networks, but we should then implement a system very much like what Dr. Jeste Jr. talked about earlier today, which is a system where we really try and get the maximum information on cognition and neurocircuits at the same time, synergize that information, and make predictions about treatment response. And she wrote a textbook now on precision mental health that is really seminal for many of us in the field. And what we've discovered is that we can do this. We actually are funded by an NIH grant right now to bring these circuits together and to iteratively expose individuals with certain neurocircuitry and cognition phenotypes to different treatments in order to be able to bypass the often 7 years that it can take to get an effective treatment on board and get people aligned with the treatment that works for them based on this information. You know, the challenge is always in the details, and I show this slide not to convey, you know, any extensive data here, but it took pretty much a decade for Dr. Williams, her team, my team, and others to come together to really hone, in fact, standard definitions for these circuits and to make sure that we are validating the algorithms that we had created. And we've done that, and so we now have a platform that we feel is really actually going to support the next step of not just examining what are mostly pharmacological treatments, but also other types of treatments, such as cognitive behavioral therapies. And actually, using the VR method here could be instrumental. We had a very interesting study when we were looking at non-responders to the standard SSRIs among older adults with depression. Depression affects almost a third of older adults, people over 65 at some stage in their later life. And it's underestimated because it's extraordinarily debilitating. It can absolutely impact cognition. It can impact function. And the other thing that people often don't talk about is that the ratio of suicidal attempts to completed suicides in younger adults is around 1 to 5 to 1 to 8, depending on the study. But in older adults, it's much closer to 1 to 1. Gives us very little opportunity for intervention. And it's really a problem. And indeed, I have to say, sad today for us here presenting who knew Dr. Nolan Williams. He was a wonderful collaborator of mine at Stanford who lost his own life to depression and suicide earlier this year. And in part, one of the innovators of transcranial magnetic stimulation for depression. And very, very sad to see that someone like that could not reach out for the support that he obviously needed. So there is so much work to be done here. But what we want to do is try and actually target other treatment systems. So for example, with the CBT, we had a study where we had about a third of older adults who did not respond to cognitive behavioral therapy. And so we figured that there's about a third who also have executive dysfunction, referenced many times today. And we figured those are the individuals who can't respond. And like so many of my studies, we found exactly the opposite. We found, in fact, that individuals who had executive dysfunction improved their mood by over 50% when they actually went into a CBT program, suggesting that, in fact, the augmentation and support they were getting for their cognitive functioning was instrumental for their mood, and they didn't improve their executive function. So what we'd like to do is take this and add in sleep. There's been a lot of information on sleep in recent years, older adults with slow wave sleep impairment, where they don't have a lot of slow wave sleep, not doing as well in their cognition. We've published on this ourselves, and the nice thing about this domain of sleep is you can, in fact, use all sorts of stimulation to enhance slow wave sleep. So just to go to the bottom line here, a lot of technologies that are advancing that could make this easier to do. Right now, we do it with full polysonography in the home. So the future really is taking these technologies and bringing them together to really give us the better assessment of multiple systems at the same time. And the other one we're working on as well is, of course, the glucose monitoring. I think that's the challenge. I think we have to be cautiously optimistic that this may happen, but it'll take us a while because there's so much to do. Thank you very much.
That was amazing. So interesting. And last but not least, we have Amir Rahmani, who is from a professor of nursing and computer science at the University of California at Irvine. So we have two esteemed colleagues from Irvine here, and he also holds the Samueli Endowed Chair of Integrative Health there. So we're really excited to hear what you have to say.
Thank you for having me. A great, I would say, segue, because many of the notes made by speakers actually were music to my ear, especially the last few slides about how we can look at some of these outcomes kind of longitudinally and outside everyday settings and using wearable devices, and the notion of multimodality. I think these are really, really important because that can give you a holistic kind of understanding of what's happening. So no, I'm a computer scientist by training. So I'm a professor of digital health because I've been working with different types of healthcare data and biosignals for like the last 15, 20 years. What I wanted to make a case today is that healthy aging really is not something that you can just understand and kind of realize episodically. You really need kind of continuous monitoring to kind of look at it and also better understand it. So there's a lot of technologies out there these days. Some of my colleagues already kind of showed some of those, including like, more wearable devices down there that we use a lot in our research center on understanding in a multimodal way different pillars of health. For example, how we can look at sleep, at the same time nutrition, at the same time, for example, physical activity and certain outcomes, for example, physiology outcome, for example, like heart rate variability, skin conductance, and all of those things, and have a holistic understanding, and in other words, how we can build personal models of individuals. And there are a lot of sensors. I'm just showing you like a few of them that we have used in our research, ranging from, of course, more brain directly kind of devices that directly capture signals from your brain, for example, like that Muse or Dream Band or Sleep Profiler that actually you have a few kind of electrodes to capture EEG from your brain, all the way to more like more user-friendly but may not be as accurate as those devices. For example, for looking at actigraphy, devices like Oura Ring or Garmin that I'm wearing, and the devices that these days we can tap into and get access to raw signals and really have an understanding of someone over months or even years, and we have done it. But there are also many devices that are entering the market that we have used in our research to really kind of capture multimodal data. For instance, Lumia is one of these devices that actually looks at the blood flow to your head or cerebral blood flow. And we know, for example, that can be a very kind of strong marker to look at certain outcomes. For example, like we know of several chronic symptoms like dizziness, brain fog, fatigue, headache. Actually, they are people with chronic disease actually have a much lower kind of CBF. And in some other research, it has been shown that during healthy aging, every year there's a decline of, for example, like 0.3 to 0.5% of your CBF, but in more pathological kind of aging, let's say neurodegenerative diseases, this is almost like 10x. We're talking about 3 to 5% or 2 to 5% decline every year. And that can be these days monitored through these simple kind of smart earrings that actually look at the amount of flow of blood to your kind of brain and continuously. But the message is really like, the takeaway is really kind of how we can holistically monitor many of these outcomes continuously, longitudinally over time. And that's what we do in our research a lot. One of the projects that we started a few years ago, we just completed the data capture a few weeks ago. It was this grant that we had from NIA to build a home-based, like culturally tailored intervention delivered by community health workers to dementia family caregivers. And the idea was to help them, like, do stress reduction and provide education using some of the technology that we built at our center. And it was like a 3-month intervention. We trained these community health workers, often speaking, because our population were mostly or primarily kind of first generation or immigrants who wasn't even fluent, who were not even fluent in English oftentimes. So we had Vietnamese, Spanish, Korean, and we looked at some of the outcomes that we continuously captured. I don't have the full data right now because we just finished this. We had about 400 participants, and we just finished the data capture. But I'm just showing you some pilot data on how over time, by looking at some of these, by objectively and subjectively monitoring these participants, we could capture how, for example, their stress, which was kind of modeled through the use of heart rate variability, was improved for these dementia patients or family caregivers, as well as how their kind of sleep quality, number of times they wake up during night, their even sleep efficiency, their sleep onset latency, how these kind of metrics are kind of captured. One thing I wanted to also emphasize is that data, in my opinion, when you have a very deep, especially N-of-1 data of someone like very deep, you can start uncovering many phenomena that are really not easy traditionally to capture. For example, we just finished another study to look at preterm birth. And we know stress has been shown to be associated with preterm birth in pregnant mothers. So we kind of had two groups of pregnant mothers, high risk and low risk, and we monitored these pregnant mothers for 9 to 10 months every 40 milliseconds of their life. So you can see about millions of data points per pregnant mother. And actually then we went back and built AI models to see if we can predict the risk of preterm birth already by the end of the second trimester. And our models were actually could really do risk stratification with more than 80% accuracy, even though we only had about like 100 kind of participants. And the value was really because we had a lot of data of these individuals, not just some episodic data, let's say every trimester, every month they come, we maybe capture certain things. We had changes, trends. And the takeaway is that some of these wearable devices may not be very accurate, especially to give you absolute values of certain outcomes. Maybe you're looking at blood pressure, continuous blood pressure. I really doubt that there is a really like a super accurate continuous blood pressure, non-invasive one out there. But they're very good at capturing changes, especially over time. And that is the kind of the power of these wearable devices in our opinion. And the technology is out there. Of course, something that is very important is also the infrastructure. Do we have the infrastructure to kind of build and rapidly prototype technologies that can help us do research like this? And I wanted to just also bring that into your attention that we ran a lot of studies. I mentioned about preterm births, dementia caregivers. We had another study on loneliness, where we actually gave devices, smart things, smart watches, mobile phone loggers to log the interaction of these participants with their mobile phone, how many times they lock or unlock their phone, how many times they watch, for example, or anything. And at the end, we noticed that you can build models that can objectively detect loneliness by using, by looking at markers like heart rate variability, sleep, as well as like certain activities on phone. If you build multimodal AI models to holistically look at all of these outcomes at the same time. And wanted to also mention that we have built the platform, and the innovation here is to enable you to innovate. So the idea is that we have built a platform that you can just go there, choose different kind of devices that you want to use in your study. There will be like one all-in-one platform where you can not only select what devices you want to integrate and have access to raw signals. For example, this like device, $75 device by Garmin, we have partnership with them. We have raw signal access to, including heart rate variability for every heartbeat, and then we can make it available to you to kind of look at different phenomena. But on top of that, without any coding, you can also kind of implement just-in-time interventions. For example, you can say, send this intervention, this sleep hygiene intervention, only on the mornings or nights following poor sleep quality reported by a device. In that scenario, you can automate, like send this not in a personalized way, not every day or every morning or something, only when they need it. Or whenever, for example, we have integrated the sleep pad that also showed by Dr. O'Hara about the feedings. So you can integrate these things in a matter of hours and start implementing. So that's our passion, to really kind of democratize the way people actually use wearable technology. And yeah, that's it. Thank you so much for the opportunity.
Thank you so much. So we're going to move to the Q&A portion of this before we wrap up this panel. Everybody have a microphone?
There's two up here.
There's one chair. So I'm just going to kick off with the first question. Well, make an observation and then a first question. This question is, I'd like sort of each of the panel members to take a stab at it. So the the observation is that that point just in time sort of point and click interventions looks amazing, but one of the things that I do as a psychiatrist treating patients with anxiety disorders is often tell them to stop using wearables. And I systematically often peel that away because there's a degree of pathologic reassurance and there's false alarms, et cetera. So, so it'll be interesting to see kind of how that balance comes into play over time as you're working with these interventions. But here's the question for the panel. So this is amazing technology that each of you have talked about, and innovation. You know, I'm actually the Jolly West Innovation Chair, so I love innovation. I love new things. It's shiny, it's exciting. But everybody who's come to this this conference, especially the people with lived experience, the family members, the caregivers, are interested in traction and what's happening. So the question for you is, 5 years from now, when you're sitting on this panel, what breakthrough would prove that these technological innovations have truly changed care from a brain health perspective? You can take it in whichever order you want.
Oh, I was actually giving the floor to Amir there, but I think you've raised several really critical issues. I think that's why I started with a little bit of history, because sometimes it can be very challenging to say positive. There's so much data now. How do you even bring it together? And I think what I'd hope to do there is say, well, we've come so far, really, because of the work that has been done, but it can take a long time. So I think it's important not to underestimate how much work will be involved in actually pulling pieces of information together. We work with individuals with autism and go to the homes and set up full polysonography, and we get a lot of in-depth information, but that's not sustainable to scale. So we'd have to look at how well other models and approaches, such as, you know, the more integrated approach, actually will give us as much information, and that's the critical piece, predictable information, and that too will take time. So it's a time-consuming endeavor, but I think there's great reason to be optimistic.
Yeah, from the virtual reality standpoint, it's been interesting to see the journey of scaling this technology, because when I started working on this, it was really a fringe research area, and now there's over 30,000 papers in the biomedical literature examining these technologies. There are now practice guidelines that have been published. We have a Journal of Medical Extended Reality. CMS now has codes for reimbursing use of VR in different practices, and there are ICD-10 codes now as well. We're actually seeing uptake, traction, use of this technology. I would always love it to be more. You know, now you have smart glasses now, so soon we won't even need those headsets. It'll all be on the lenses of your own, you know, eyeglasses. So it's an example where we have seen scaling. And although I would always love for it to be faster, you know, more expansive, there has been directionality towards greater uptake and usage.
From a continuous monitoring perspective, first I fully agree with you. Technology, the choice of technology matters. I'm not only saying that wearable technology is the solution. I'm trying to champion the case that continuous monitoring. For instance, for sleep, we have the study with dementia patients, highly demented patients, and for example, we know that they don't even want to wear a wearable device. They take it off quickly. So, for example, in that study, we use the sleep pads, the invisible ones that are not even kind of visible, and you can just better understand their sleep. There are many other kind of biomarkers. But going back to what I like to see in the at scale is, as a computer scientist, I'm a fan of what I call personal models. And when I look at other industries, for example, like YouTube, Amazon, Netflix of the world, I see that the first day you go there, you create an account, they create a personal model of you, which with every click you make, with every interaction, you open a page, you watch a movie, or see, they keep updating that personal model. That's why over time they can kind of personalize their service so much that you're sometimes even scared and if you freak out. So, wow, how did they know that I really want this to work? But why can't, and that needs multimodality, right? They're not just only focusing on one thing, there are cookies and all. Anyway, the idea is that if at scale we can use any sort of sensing that we have, it doesn't have to be sensors, EHR is very rich, we have smart spaces, we have phones that are anyway, there are, of course, we have some other faculty here that are very active in this field, but your typing pattern, as I think Alex, she's expert on that. That's just a huge marker of like how, in fact, in our loneliness study, the highest ranking featured in our AI model was like on anxiety was how many times they lock and unlock their phone. And they don't need to wear anything, that's something they're already doing. So how can we do that to build personal models that can guide everything else? And that personal model, then the sky is the limit. You can guide it when to intervene, you can guide it to diagnose, you can guide it to uncover and for research, and that's my wish to really kind of see the notion of personal models entering the healthcare.
I mean, no one is going to do neurosurgery if you have some alternative. So, and I think what we're hearing from is a lot of the alternatives. And the kind of the neurosurgical options will be for people who are much more severe and when all else has failed. But I do think that it's worth keeping in mind a lot of these interventions in my mind, the non-invasive interventions, are very much dealing with plasticity as a modifiable factor, right? You're putting in information, you're changing the environment, you're giving information, you're trying to change behavior, you're trying to make a more supportive environment. And there's tremendous power to changing the brain through loading different information onto the synapses. And that's how the brain usually fixes itself. And if it's unable to fix itself with the environment it's given, we can give it environments that do put it in a position to do that. Just like chemical interventions have the ability to change the interaction between cells, I think these informational interventions have the ability to do things between cells. Those are two categories, right? And then there's the structural ones, right? It's if you have a brain tumor, it's a good idea to take it out. And then I think there's going to be electrical ones. And I think there's going to be situations in which hopefully there are non-invasive ways of modifying brain electrical activity with ultrasound and transcranial magnetic electrical stimulation. And I just think putting all of these in the categories of recognizing that we now have different categories of interventions. And I think where a lot of the excitement is going to happen is going to be the interaction between these. So if you are in a VR environment and you use transcranial magnetic stimulation at the same time to stimulate or inhibit your orbitofrontal cortex, yeah, what actually would happen in those cases? Or yes, you combine these with medications, and of course you do want to combine these things with early detection interventions that prevent the life-threatening outcomes of some of these mental disorders. So I think ultimately, to answer your question, it's going to be the combination of these tools which all operate on the brain from very different directions.
Thank you. Indu?
So one thing that just struck me by listening to some of the things that you were talking about, and just this meeting overall, and Sabin and I might just sort of reflect while we're asking these questions, just to wrap up the final portion as well. I deal with a neurodegenerative disease, but I obviously, we have similar training in that we're both neurologists. You did peds, I did adult, and then we specialized in movement disorders, and we met at a movement disorder meeting. And I think the one thing that strikes me, as you're talking about removing the roles of neurosurgery and even imaging, is that you can have a profoundly devastating looking disease with actually normal brain architecture, right? We say that when we talk about, imaging for a disease like Parkinson's, that the MRI is actually not that helpful because all the stuff's in the right place, the road map looks fine, it's just these cells aren't working well. And then on the flip side, you can have, a lot of brain tissue missing, and the brain sort of finds a way to work around it. And so I think it becomes such a hard thing in some ways to figure out about what brain health is when the classic ways that we look at it and measure it and MRIs and things that we're so used to ordering now, and historically CTs and whatever was before that, looking at where things are, right? The encephalograms or whatever of way back yonder, and those can all be totally fine, and yet you can have a profoundly a degenerative disease or a patient whose quality of life is horrible. So I think it's it just adds a layer of complexity that is so fascinating to me. And Terry, you probably do the most of this, right? Because you do see these sort of the circuits are all messed up, but then the structures are all really cool. So maybe you could just reflect on that.
It's striking to see a child born without a cerebellum, and you only find this out when they're an adult complaining of headaches. It's striking when you see a child with some mild developmental delay, and you do an MRI and find out that they have double cortex or schizencephaly. The types of abnormalities that are possible with relatively minimal dysfunction are striking. And then, as you point out, just the wrong abnormality in just the wrong place can be completely devastating. I think, it's obviously it's a truism to say, isn't the brain an amazing thing? But if you think about it, it's a device that no matter what environment it's placed into and no matter what input it's given, it ends up doing something useful. That is not true of robots. That is not true of computers. These things are very, very special purpose devices. So the brain is also a device that no matter what structural problems it's given, it will generally do something useful. There are cases where it doesn't, but there's very few cases where over time with a fixed abnormality, people get worse. Dystonia is one of them. It's one of the reasons I study it, because it's interesting from that point of view. But in most cases, a static injury will still lead to improvement. The thing figures it out. Imagine a car with 3 of its wheels removed suddenly figuring out how to drive, right? I mean, that's the kind of stuff that's in there. So now when you're trying to look at the concept of brain health, what does it mean? The information processing in a disordered brain may look completely different from the information processing in a healthy brain and yet be functional. There may be more than one way in which, we know there's more than one way in which a brain can be functional. And so what is it? It raises this question, what does it mean to be normal? But it also raises the question of how do we detect on the inside normal, and what do we want to fix? What does it mean to fix the system? Because usually we can't fix it. Usually what you're trying to do is just find some functional mode. And you really don't care where the wiring goes, right? If you can patch around it, you could sort of do the equivalent of a cardiac bypass. You don't care if the blood was going down your LAD or if it went through some bypass and got into the same place, right? It's just the blood's getting to the right place. And I think for information in the brain, it's going to be something very similar. It's very important to look at the phenotype, and the phenotype, I don't know what the electrical equivalent of phenotype, but the phenotype information processing is not going to be sort of a one-to-one link, and we need to keep that in mind.
Okay, we've got a question from the audience.
Hi, I'm Janine, and this is Sparky the Brain. And we make brain health books for kids, and that teaches their parents and their grandparents. And thinking about Dr. Brennan, VR, thinking about imagination. Like, she was in my 3rd grade class. I was her 3rd grade teacher, and now she works with us. And part of my job is to make sure their imagination is robust and they have the ability to stop and basically visualize. And I'm pretty sure you've seen the research that your body responds the same when you're imagining, and it feels like it's going through the same thing. Do you think that the VR is going to dampen that skill as we're trying as parents and teachers and educators to make sure that they are heading into the workforce with those imaginative qualities and ability to have divergent thinking and not depend on the VR system to help them conjure up these particular scenarios? Thank you.
Great question. Virtual reality is part of the human experience. The dream you had last night, I couldn't see it. The pictures of your last vacation in your head, I can't view them. The songs that you can play in your head right now, I can't hear them. That's part of being a human, is being able to have virtual experiences in your mind's eye. And you're right. We don't want to cede those capabilities to external aids. Now, that said, yes, there's risk of overusing any technology, which is kind of a little bit at the heart of that question. And VR is VR too. But if we can use technology in the right place at the right time with the right person, with the right duration, we may be able to help people think differently about their mind and body than they currently are, and in a way that's more adaptive rather than maladaptive. So to me, the idea is if your mind's virtual world is maladaptive and incongruent with the reality you seek, then manufacturing in a way virtual worlds that can help countervene that may be useful. But in general, we want to encourage tremendous creativity in the mind's eye, and for people to live their own virtual worlds and be able to express them, and hopefully those virtual worlds are consistent with health span as well.
My question might take a bit, so I'm actually just going to turn it into a comment because I know everyone wants to be done. I just want to say this panel was incredible, and I wish that our medical students and undergraduates and trainees could hear this, because I think medicine is in such an exciting kind of inflection point right now, and I think, unfortunately, there's not as much excitement out of being in medicine, for a lot of different reasons. And I just think that what you guys shared today is just aspirational. So I just want to say thank you.
Thank you. So I'm just going to make one last comment, then we'll close the panel and hand it over to Helen. So AV folks, if you could do me the favor that I asked. So what we're going to do is just turn the lights off and the screen off. I want you just for a second. We've thrown a lot of information at your nervous system today, and yesterday, and mine, okay? And I want you to now close your eyes and let's just sit for about 15 seconds in silence. Don't forget to breathe. This is not a mindfulness meditation, by the way. Okay, you can bring the lights up. You can bring the lights up. That was maybe it was too nice, right? So, so what that was, right, was something, a very, 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 very teeny bit of something that we call reduced environmental stimulation. And for the last 10 years, one of the things that I've been studying in my lab with a colleague who's a clinical psychologist is how can you improve functioning and improve people's symptoms and their experiences of their brain-body connection from a mental health standpoint when you just give the nervous system a break. And it turns out there's ways of doing this in fancy contraptions that are filled with salt water. They look like, they're called flotation tanks, or the old term is sensory deprivation. But the concept here, and I just wanted to make the contrast with the exteroceptive sort of virtual reality sort of stimulation and the DBS, putting all this energy and information into the brain has incredible transformative effects. But there is also the opposite, the minimalistic approach of just giving people's nervous system time to restore homeostasis on its own. And we've been studying this in various mental health populations. I didn't want to sort of pollute your senses with an additional talk, but I didn't want to end this by not mentioning it, because I think that there's value to putting information in, and then there's also value to letting the body and the brain sort of communicate and see what happens. And so you can look up the clinical trials. We've done efficacy studies. We've done it in patients, kids with anorexia nervosa. We actually have an efficacy study. It improves body image, and it actually reduces anxiety to the same degree that a benzodiazepine would. Except in anorexia nervosa, benzodiazepines don't work, and you can't use beta blockers because they have bradycardia. So there's value to, and we studied it from a altered states of consciousness standpoint. It changes disembodiment, a feeling of separation from your body, to the same extent that ketamine does, non-pharmacologically. So we have a lot of different ways that we can manipulate the nervous system for positive benefit. And it's not meditation, but it actually may be a way to help enhance people's ability to access interoceptive signals. So I just wanted to make that contrast. I think there's an incredible opportunity in the future when it comes to brain health. I think what we're going to do is conclude the panel, and Helen. Okay, we're going to conclude. The last question goes to Helen then.
Yeah, well, just follow up on this ketamine and psychedelic experiences because your technique, especially Brennan's, emulate that. And the question is, can it replace the need for extraneous substances to promote neurogenesis, basically, and neuroplasticity? Can we do it with imagination or your technology? All these techniques are doing the same thing in various ways, and the least toxic ones are preferred, because we're surrounded by toxic substances.
Yeah, I mean, it goes back to this earlier comment about information being the substrate for change, and listen, we're computational systems. I think about every part of the body is just the extracranial extension of the brain. Every viscera, every organ, every nerve, every tendon is just an extracranial extension of the brain that is taking in the data of the universe. And there's really only two things we're really measuring. It's electromagnetism and gravity. Then there's the weak nuclear force and the strong nuclear force. And only really 2 or 3 of those have anything to do with our life. And so we are taking in the data through all of these tendrils and systems. We're compressing it and compressing it down and compressing it down like a computer. And it arrives as consciousness in our mind's eye, as a narrative making sense of this world around us, and then we act upon it. We're information processing systems. And I study the gut side of that. I'm not a neuroscientist at all, by the way, so I'm probably way off in a few important ways. But I think that this comment is very important because we can alter information processing in all sorts of ways. It doesn't need to be chemical or pharmacological. It could be in a narrative way. It could be, that's what talk therapy does. That's what simulation does. These are all different ways of changing the way information is processed, compressed, and interpreted. So that's my thought about that.
Or a development of consciousness that sort of supersedes, gets us out of our misery. And, I hear you. I'd like to speak to you about this aspect a little more later. Thanks.
All right. Thank you, everybody. Give them a big round of applause.
Okay, I think we're all exhausted and fulfilled and, spilling over. I'd like to thank all the speakers. Amazing. Everybody's brilliant. Amazing. Thank you for coming. What? Oh, where is she? Didi is out there. Yeah, so he's going to bring her.
Yes. I also want to I think we should have a standing ovation for Helen Lavretsky for organizing us, bringing us here. Thank you so much.
And thank you so much. It's been very satisfying to create this collective. I think it breaks ground, and I think it sets a precedent that will continue. I mean, once it happens, it's just in the books, so of history. Didi, you're amazing. Oh, the brain. And thank you to Catalyte for providing sponsorship for this event. Without you, we could not meet here. Thank you, everybody, for coming. And Didi, yeah.
So for those of you who don't know, our sole admin support person was Didi for this 2-day meeting. So you really should thank her for everything that she did to put this together. Thank you. Thank you. Yeah, let's do.
Thank you.
All right.
All right.
I think you should bring.